Shalu, are we starting at precisely 8 o'clock?
Yes, ma'am.
एक सेकंड अरे बस शुरू हो जाए क्या किसी को मेरे से फर्क पड़ेगा ना
A very good morning to all of you. What a pleasant spring morning of today. We received hailstorm in Delhi today. So on the behalf of the Department of Anesthesia of ABVIMS and Dr. RML Hospital, I extend a warm welcome to all the delegates who are joining us from across India and abroad, and the esteemed faculty members of APPEC 22, without whose contribution this program cannot be a good success. Recollecting the past year of APPEC 2021, in which we received an overwhelming response, we sincerely hope that this year also our program will be a grand success. Anesthesia pre-examination postgraduate course is an academic feast which is spread over 7 days, and we have made a few changes as compared to the last year's program. It caters to the need of the postgraduate students who are preparing for the MD exams, DNB exams, and various other courses. Without wasting much time, let us all join our hands together for the Saraswati Vandana before we start for the proceedings of the day. We seek the blessings of Goddess Saraswati to guide us in attaining the path of knowledge.
त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, everyone. To bless us further, we have a message from our respected dean, Dr. Nandini Duggal ma'am, who has encouraged her with her kind words.
Good morning, everyone. I welcome the delegates and the eminent faculty to this mega academic feast of 7 days. I congratulate Dr. Mohandeep Kaur, Head of the Department of Anesthesia, and her team for organizing the online teaching program to help anesthesia postgraduates to refresh the course before their exams. Her team has worked with full dedication during the COVID pandemic in terms of imparting teaching regarding ventilator management and oxygen therapy to all our residents attending to COVID patient care management in the hospital. I take pride in saying that students all over India have registered for this online teaching program. The faculty chosen to teach them is also experts in their subjects from various medical colleges all over India, UK and Singapore. It is indeed a proud fact for our institute that we can connect to students from various colleges all over India through this platform. This is the second consecutive year for anesthesia postgraduate pre-examination course. I wish a grand success to this program this year also and hope that all the students learn and perform well in their exams. Good luck. Thank you.
Thank you, ma'am, for the words of encouragement. I'm sure you'll all agree with me that to make any event a grand success, there's a constant binding force who always encourages us to do better each time. For us, undoubtedly, that has been our HOD ma'am, Dr. M.D. Kaur ma'am, whose humble nature and eye of perfection has always made us do better and perform even better every time we do an event. So let's hear Dr. M.D. Kaur ma'am, who will welcome all the delegates and the faculty of APPEC 2022 before the beginning of the program.
Hello, everyone. I am Dr. Mohandeep Kaur. I am HOD Anesthesia at ABVIMS in Dr. Ramanohar Lohia Hospital, New Delhi. And I take pleasure in presenting before you APPEC 2022. And this is anesthesia postgraduate pre-examination course meant for your exam preparation. Final exams are approaching and COVID has made the life very turbulent especially it has affected the postgraduate students because teachings have really been hampered because of the COVID postings and, the offline classes could not be held. This is the second course in succession. Last year we had held APPEC 2021 and I'm pleased to say that I received a very positive feedback of the program. So hence this time again, we are presenting before you this APPEC 2022. It's almost on the same lines as the previous course. However, this time we have made small changes. One, that this is a 7 days course. Earlier we had kept it 9 days, but we just thought that 9 days was pretty longer. But 4 or 5 days is just not sufficient to cover up the topics. And we are trying this time 7 days course in which, we are trying to cover all aspects of the postgraduate examination in the form of long cases, short cases, Then the Viva was say as drug stations and equipments, and then various topics are being covered by the didactic lectures. I really hope that after attending this program, you will be much wiser and you'll be studying smartly. At least you will have a channel to traverse after attending this course, and being online, the recordings would be kept live for rest of the day till the next session opens on the next day. This will really help you to go through the lecture again, or if at all you have missed something, you can again, approach the program. It will be there on the, uh, Facebook, I suppose. However, this time I wish to talk to the students regarding the examination preparation. Actually, exam has got, the theory part as well as the practical part. Theory part is as important as your practical part. And most of the questions, in theory, we keep on reading books, we keep on reading notes, we keep on attending classes. But, what is missing is, practice by writing, which we fairly do not do. And once we have prepared the chapter, we have prepared the questions, but when we start writing in the examination, we are missing on certain keywords, key points, and diagrams and algorithms which we have not practiced. And everything comes by practice. So my sincere advice to you is that you should practice making drawings, making algorithms, and writing certain keywords or key points in your notebooks while you are revising the things. This really helps in reproducing the things in the exam when you are writing. And time is very limited. You have to attempt 10 questions in 3 hours. That generally gives you 18 minutes per question. And that also sometimes, certain questions are very lengthy, or your knowledge about that question is vast, and you keep on writing that for 30 minutes, then you have really lost on the time to attempt the other questions. So kindly make sure that you are spending equal time on all questions. And if you know certain question well, please attempt it first as a first question, because examiner gets a fair idea of how you are writing by reading one or two questions in the beginning. And never miss out on anything. Please do not keep any remain. Your questions should be, all questions should be attempted. That's very important. And if you think that you don't know anything about that question, still I would advise you to write a line or two about that. Maybe some keyword, or something you are writing fetches you even a half mark or 1 mark. I have seen students failing by 1 or 2 marks. So my advice to you is that you must attempt 10 on 10. And if we see the previous year's questions of not only of your university, but of the rest of the universities also, we can make out that this question has been repeated a number of times. So you must know that this question is a possible question. And, you should really try to practice that question and learn that question and certain things by heart and by writing. And you should keep that diary in which you are writing at hand, so that on the last day you can flip the pages. And that's very good practice, of remembering things at the end. And another thing that I would advise you is, whenever you are learning something, the key points must be noted. Examiner, when you have attempted the question, then you have written 4 or 5 answer in 4 or 5 pages. But the examiner wants to find out only those key points. Have you written those points? So if you have written those, examiner is really pleased, and you get, good marks out of that. So this is another way that you know every topic has got certain key points, certain keywords, and if you remember that, that is always, you know, you can get full worth out of it. So another advice is this. Then we have very limited number of diagrams which are repeated again and again in the exam. These being your pain pathway, your brachial plexus, drawing of your brachial plexus, then, you know, the uterine innervation, then the coronary artery circulation, circle of Willis, then similar drawings and oxygen dissociation curve, then some flow volume loops, these capnograph diagrams, and then ECG blocks or certain things. You know, you should be practicing on these. These are repeatedly asked questions, and if you know them, you have tried your hand on it a number of times, and you will attempt these questions very well, and you will get good marks out of those questions. This was about theory. And then, you know, we have certain things to keep in mind regarding your practical examination. We are always focusing on the cases, you know, long case, short case. But, you know, the Viva Voce has got its own distribution of marks. And you have certain times got some spotters in 20 marks for those spotters are there, 1 mark each. And if you are able to, you know, get 19 out of 20 or 18 out of 20, you know, you are covering on most of the things that you are not answering correctly. So this is one point where you should practice, you know, you should be knowing the history of anesthesia. You should be able to recognize certain pictures of the important people who have contributed in anesthesia. John Snow, then, you know, certain other recognizing certain things like EMO or flag bottle or certain other old equipments, you know, which are often asked in the examination, Goldman vaporizer, to and fro, that canister, then certain other equipments which are not being used these days, metallic airways, then those anatomical masks and red rubber tubes. These are certain things which you should be familiar with. All the departments always, I think, have a museum in their every department has got a museum, and these things are placed in the museum. So only thing is, we never attempt to go and see. So I would request all of you to go and see these things. They are there in the departments. And if we try, we can always, you know, get an access to see these. And you have to recognize a few things. Examiner tells you to recognize. And then similarly, red rubber, double human tubes, olden time Carlin's tube, and the other Cole's tube in for pediatric anesthesia, then Randall Baker Susak mask of olden times. Those kind of things are there, which you should be able to recognize. And then, you know, that Boyle's machine. Whenever we talk of anesthesia workstation, the basic Viva is always there on the Boyle's machine, which most of the hospitals have stopped using. But, you know, our Viva on the machine comprises only on the Boyle's machine. And we should be able to see that this is mostly a mechanical kind of a machine, and the connections and all, if at all old models are lying in the museum, you should definitely try to understand the old Boyle's apparatus. That is also very important from exam point of view. Then comparing the Boyle's machine with the workstation, what are the new things which are there in the workstation? How is it different from the Boyle's machine? Then what are the safety mechanisms in the anesthesia workstation and in the Boyle's machine? How are the two machines different? So these are the important Viva questions. Then the questions on the vaporizers, on your circle absorber system, various circuits in being used in anesthesia, and then various kinds of oxygen masks, hoods. The COVID has made it very important, especially, the NRBM, which was so in use, then high flow nasal cannula. This again has gained a lot of repute. Then various video laryngoscopes, various other, modalities available to tackle the difficult airway, various, supraglottic devices, and classification of these supraglottic devices. This is all that you should be very clearly knowing. Then the drugs, we have tried to cover drugs this time in a viva voce manner, so that you can have a simulated viva on the drugs. And if you see these presentations once or twice, you will definitely be helped. Important questions about the drugs have been covered by the examiners, and a lot of input has been made into the preparation for these drug vivas and the equipment vivas. I hope you will appreciate this time that the faculty from anesthesia of ABVIMS really work very hard. And I am equally thankful to the faculty from Pan India, whom we have invited very respectfully to be a part of the faculty of this APPEC 2022. And the faculty, eminent faculty, has been, invited to give didactic lectures and be the external examiners for both long and short cases. And the long and short cases are again going to be a very crisp help to you, because we've tried to cover most of the comorbidities, and we have joined them for the surgeries in which, you can talk of the special considerations for that kind of surgery in any kind of, in the comorbidities. We've tried to make the cases very simple, and important cases have been discussed. Last time we had not covered short cases. This time we are keeping, short cases for the discussion as well, because I felt that we should be discussing these also, like a case of intercostal chest drain, then, certain other squint, cataract. All these cases have been kept as a part of the program, to give you an insight into how to answer the vivas of short questions and how to present the history of a short case. Main emphasis is that, if the PG students is presenting a good history of a long case and a good history of a short case, then, half the battle is won. Examiner is very happy to hear a good history. And if your history taking is not proper, then the things start going haywire. Then the examiner will ask you questions regarding how to take history, and you won't even know that why he is asking those questions. If the one rule of this practical exam is that if you present the case well, then half the battle is won. Examiner wants to ask you, check the basic knowledge of the thing. If you answer the basics well, and if you know the basics well, the examiner is quite satisfied. And then, he may ask you questions to see to what level you can answer the questions. The difficulty level of the exam is increased when you can answer the simple things. So basically, no examiner is trying to fail you. But you have to be conferred a degree of MD anesthesia, and the examiner is really worried that you know the basics of the subject, and the patient is safe in your hands, because after getting the degree there is no way to check you. So once you are conferred a degree of MD anesthesia, then the patient's life is in your hands. This is a very critical specialty. and the examiner only wants to know that you will not make any basic mistake. Though this kind of an exam, 1 or 2 hours of exam doesn't test the true knowledge, but if you have a knowledge about the subject, it shows. So that is what the examiner wants to know. So be confident while answering, and if at all you do not know anything, don't give wrong answers. Always say, ma'am, I don't know this. And don't try to cross question cross the examiner by saying that, no sir, it is this, no ma'am, it is this. And the examiner is wiser than you in experience. She or she is an experienced person, and the in anesthesia experience matters a lot, है ना. So इसलिए do not ever cross the examiner. Do not try to say that I read it in this book, I read it in that book. It is wrong. It doesn't give a good impact. Always listen to the examiner and try to answer in a straight manner so that the examiner doesn't go right or left. If you have answered wrongly, the examiner will go to some other direction, and that will complicate the viva. So my one piece of advice is that always stay simple and tubular while answering the questions. If you don't know, say, ma'am, I don't know. And it's not compulsory that you should know everything. If you know the basics of the thing, it is good enough. So please be confident to answer correctly, be confident to answer precisely. This is one, again, very important point that you should have it in mind. And you should present histories. When you practice amongst your friends, you should present history in front of each other. And if you don't have any companion with whom you can share these things, then you have one companion in your room mirror. Please try speaking in front of the mirror. It will show you many of your mistakes. You will yourself realize that, oh, here I'm making a mistake, and you should try to correct that mistake. So this was my, a suggestion, or, a simple talk with you people. And I just mean to say that you can pass the exam very well if you take care of basics. And these 7 days of this program will really make you go through the basics. And if at all you revise these things, well, I hope I can really ascertain you that you will be helped a lot by this course, and you will make smart studies. And my best wishes to you. And with these words, I thank you. And please stick to the program for all 7 days. This is really going to help you. And if I get good feedbacks of this program, we will try to make it an annual event. That's what I am thinking at the moment. And thank you so much. And my best wishes to you. Kindly go through the program with full zeal. Thank you so much.
Thank you, ma'am. Your words of encouragement for the students would, I'm sure, would definitely help them in it and guide them in passing the exams. I would like to invite Dr. Akhilesh sir to brief us about the course of events for the today and further for the next 7 days. Dr. Akhilesh sir.
Thank you, Anupama. I'll just brief you about few things. First is welcome all for joining this program. When you go on the main auditorium page, there is a first is agenda. You can always see the agenda. Then there is a certificate. Certificate link will be active on the last day. You have to click it, put your email ID, and then you can download the certificate. Then there is something called daily quiz. All of you will get a quiz on your mails. So you have to keep on checking your mail, and at the end of the session, this link will be activated. So when the link will be activated, you can give the answers. It will be in a Google form, and it will be checked at the night, and tomorrow you will get the results. And the top scorer who gave all the answers in the minimum time will get the fee refund of 3,000 rupees. So it's a big incentive. And in between also, before tea and before lunch, we will be asking few questions which pertain to the topics you have finished till now. Okay. And the last is daily feedback. So you have to give daily feedback so that, and you can start giving feedback after each lecture. If you click on the daily feedback, you will come onto the Google form, and for every lecture there are 3 points: content, presentation, and overall rating. You have to grade from poor to excellent. So these are the things you should know, and good luck everyone.
Thank you, sir. So for today's session, it is divided into 3 parts. Pre-lunch, we'll have tea break, we have 2 lectures. And after that, there'll be a set of MCQ questions just before the tea break. Then we have a case presentation, long case presentation. Then we have lectures. And before the lunch, we'll have the second set of MCQs. And at the end of the session today's whole program, there'll be another set of MCQ questions. The link for the MCQ questions would be activated on your screen by clicking on the link. Kindly answer in the chat box. The delegates who answer as quickly, and the first two will be rewarded. First few delegates who answer the correct one will be rewarded suitably at the end of the conference. For any queries, kindly put your queries in the chat box. So we'll begin the session at 8:30 a.m. sharp. Please wait for another 2 minutes. I hope everything is clear to all the delegates. If you have any queries, any questions, kindly write it in the chat box.
All the questions will be taken at the end of a lecture. So when you write on the chat box, it will come to us, and then we will display, and you can get the answers immediately after every session.
Yes. Thank you, sir. So I'll read out the questions to the speakers, and the speaker can answer the question at their end. So for the first session, we have very dynamic speakers with us, which will be introduced by the chairperson in another 2 minutes.
भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्.
Thank you everyone for waiting patiently. So let's start with our first lecture for the day. To introduce the speaker, I would like to invite Dr. GP Singh, sir. Sir is a professor and head at KGMU Hospital, UP Lucknow. Sir's area of interest are obstetric anesthesia, geriatric anesthesia, intensive care, and he's also a BLS and ACLS instructor. I welcome you, sir. Kindly unmute and you can share your video.
Thank you. Good morning to all of you. Thank you, Anupumaji, for. I am grateful to all RML team. They have organized such a wonderful assembly, PG assembly. In this, because of COVID, we were having virtual class. I think this will be the first grand physical class for the PGs, and I must congratulate whole RML team. Now we can, without wasting much time, I should go straight away for presentation. First presentation is by Dr. Namita Arora. She is Professor of Anesthesiology at RML Institute, Delhi. Her area of interest is difficult airway and neuroanesthesia, and her topic is pulmonary function test. Dr. Arora, please. Namita
Good
ji,
morning. Good morning, sir. Good morning, everyone.
yeah, good morning.
So, good morning. It's a very, very important topic that we are starting with, pulmonary function test.
Yes, ma'am, you can start.
Some confusion. Yeah. Sorry for the glitch. It's a very, very important topic, pulmonary function test and flow volume loops. So let's get started. It's a typical case scenario here. A 56-year-old male who is obese, chronic smoker, alcoholic, has prolapsed intervertebral disc at L4-5 and is posted for a laminectomy. He has history of breathlessness on exertion, on inhaler off and on, and pulse rate is 98, BP is 150/90, and has a saturation of 96%. And he has occasional bronchi. So we have all seen such cases coming for surgery. And after workup, the first thing we ask for is obviously a pulmonary function test. And the report is like this, and the response is like this of the resident who is doing the PS. It is indeed overwhelming if you don't know what these numbers are, what these graphs are. And then obviously, as you can't interpret, the question is, where is the respiratory physician opinion? But I must tell you, it's not that difficult. If you know the numbers, it is very, very interesting to analyze these numbers and to analyze the graphs. So let's get started. So the objective of my talk would be to discuss the indications of pulmonary function test and the information we derive once the PFT report is in front of us, understanding lung volumes and capacities, bedside PFTs, respiratory lab tests, and an algorithmic approach to PFT interpretation. And finally, we'll have a few case scenarios and looking at the PFT application. So what are pulmonary function tests? They are objective and quantitative measurements of lung function to provide standardized values so as to detect presence, type, and severity of pulmonary disease. So important thing is they are objective and quantitative and can be compared and very easy to be done, easy to perform, and so can be repetitive. So types of PFT can be broadly said to be those that can be done at the bedside with either no or minimal equipment, and respiratory lab tests, which then include spirometry, lung volume studies, and diffusion capacity of carbon monoxide. So these are broadly the indications. We can have a patient with a gross, there are going to be lung volume changes and we want to know the baseline. Then there can be a patient who is a smoker, COPD on inhaler, or an obese patient for either surgery for a bariatric surgery or for any other incident surgery. There can be patients with obvious interstitial lung disease or patients with thoracotomy or upper abdominal surgery or any cardiac surgery. So these are broadly the indications of preoperative PF. So what is the information that we need to derive once we have the PFT report? We want to first detect any significant lung dysfunction in a patient who has cardiorespiratory symptoms. So a patient who complains of significant dyspnea, we want to know if at all there is any significant lung dysfunction, and then want to know the type of lung dysfunction, whether it is obstructive, restrictive, or a pulmonary vascular disease. Then the severity, progression, and reversibility of a pre-existing disease. Like I showed you the case scenario is a known case of COPD. So we want to know how severe is the lung involvement, its progression, and reversibility with bronchodilator, if any. And then finally, the most important thing for us anesthetists is identify patients at risk of peri and post-operative pulmonary complications so that we are able to optimize the pulmonary function test and prepare accordingly for the possible pulmonary complications in the post-operative period. But there are certain contraindications to performing PFT, like patient with frank hemoptysis, with patients with pneumothorax or unstable cardiovascular status like worsening angina, or thoracic, abdominal, or cerebral aneurysm, because there is danger of rupture due to variation in thoracic pressure, a recent eye surgery, recent thoracic or abdominal surgery, and any patient with any open coughs or other communicable disease. So coming to the bedside PFTs, these are simple tests which we all should know and we all should be able to perform in the PAC clinic so that we get fair idea about the exercise capacity and the cardiovascular reserve of the patient and the type of disease he has. So first is Sabrasse's breath holding test, which assesses the cardiopulmonary reserve of the patient. So we ask the patient to take a deep breath and hold it as long as possible and record the breath holding time in seconds. Normally it should be more than 25 seconds, but if it is less than 15 seconds, a severe reduction in cardiopulmonary reserve is there in the patient and we prepare accordingly. Then one can do a single breath count. Take the patient to take a deep breath and count out loud from 1 onwards in a single breath. Normally it is 40 to 50 or more, and it indicates a good cardiorespiratory reserve. However, less than 15 indicates severe impairment. Then one can note the post-expiratory time with a watch and a stethoscope over the trachea so that one knows how long the expiration is. So patient is asked to take a deep breath and exhale maximally and forcefully. Normally this should be 3 to 5 seconds, But as we all know, any patient with obstructive disease, he has obstruction to expiration because of bronchospasm. As a result, he will take much longer to expire the tidal volume in the lung. And so if it is more than 6 seconds, it is indicative of obstructive lung disease. It can also be less than 3 seconds, like in patients with restrictive lung disease, where the tidal volume, the vital capacity itself is reduced. So the volume they have to bring out through normal airways is less, so they bring it out in less time. Then modified Snyder's match blowing test, which is an indication of maximum breathing capacity. So ask the patient to blow a matchstick which is kept at 3, 6, or 9 inches distance with mouth wide open, chin supported, and no head movement. So normally maximum breathing capacity is 80 to 170 liters per minute. However, if it is he is able to blow off the mat at 9 inches, then it is his maximum breathing capacity is surely more than 150. But if it is at 6 inches, it is still maybe on the lower limit of normal. But if only at 3 inches, then it is significantly hampered. Then it's a very interesting and simple device, de Bono's whistle, which is used to measure peak expiratory flow rate. Here, the subject is asked to blow through the hole here. And when he blows through the hole here, a whistle is sounded. And slowly, the hole size is increased, and one can see these graduations. Then the last point at which the whistle stops blowing is actually the peak expiratory flow rate of the patient. And why is it that we measure it? It is a good indicator of large airway caliber. So very, very significant and simple test in asthmatic patients. So one can see, even the patient can assess his asthmatic status and know when it is worsening. Next, again, another device to measure peak expiratory flow rate, and it primarily reflects, again, large airway flow like in asthma. Then Green and Berowitz cough test. Here, the patient is asked to take a deep breath and generate a cough. His ability to cough, its strength and effectiveness is assessed, which is, we all know, very, very important for post-operative pulmonary function. Patient should be able to clear out the secretions from his lung. And normally, for an effective cough, a vital capacity which should be at least 3 times the tidal volume. However, if post-vital capacity is less than 20 ml per kg, or if FE1 is less than 15 ml per kg, and peak expiratory flow rate is less than 2, I think the units are faulty here. So then if it is PEFR is less than 200 ml per minute, then the cough is likely to be ineffective and patient is prone for post-operative pulmonary complications. Then these are certain other tests like blowing a balloon, exercise capacity tests like simple stair climbing, exercise oximetry, 6-minute and 12-minute walking test. We all know, we have heard about it so much during the COVID pandemic, the 6-minute walk test and checking the pulse oximetry. And finally, something called a Wright's respirometer, which we all have used very often in the ICUs to assess the tidal volume and the minute ventilation in the patient. So these are all simple bedside tests which we can use easily in our pre-anesthetic clinic to assess the lung function. Then comes respiratory lab tests. Patients who are found to have significant impairment in the bedside PFT are sent for respiratory lab tests, which include spirometry, lung volume studies, and diffusion capacity of carbon monoxide, which is an indicator of pulmonary alveolo-capillary membrane status. So this is a typical respiratory lab test report. We know that there are certain numerical data and some graphical data. And on the top, as we can see, there are certain parameters, patient parameters that are written, which include name, age, gender, weight, and height. All these are important because that is how the predicted values for that patient are calculated by the software in the machine. So once we have what is predicted for the patient, the actual readings can then be compared with the predicted or the reference values. So these are the patient data. Then we have the numerical data, which clearly is divided into 3 categories: the spirometry, the lung volumes, and the diffusion capacity. So there are columns here which we can see. We have the reference values, then we have the confidence interval, then we have the pre and post, that is pre-bronchodilator and post-bronchodilator, but these both may not always be there. We may have a single reading of the actual reading, that is if we do the test without a bronchodilator. And then percentage of reference is an important column because that is how we know what is the extent of derangement. Then comes the graph. The graphs are the flow volume loops and the volume time graph. I'll come to that later. And there is something called lower limit of normal. It indicates the 5th percentile up to lower limit of normal. If the reading is there, it is considered normal for that person. So spirometry is something which is commonplace now. It was invented by John Hutchison and is now the cornerstone of all PFTs. It only measures lung volume compartments that exchange gas with the atmosphere. So important thing, it does not measure the residual volume as it does not exchange gas. And as residual volume is an integral part of FRC and total lung capacity, hence these two are also not calculable by spirometry. So these are the equipments that are used. Most often a computerized spirometer is available in the respiratory labs. However, portal digital spirometers are also used. So coming to what are the normal lung volumes and capacity. This is a typical graph that we see. It's a time volume graph. And here we can see this graph indicates normal tidal breathing with expiration and inspiration. Then from here, the patient is told to take from the end tidal volume state, patient is asked to take as deep a breath as possible. And so this reaches the total lung capacity. And then patient is asked to forcefully expire to his maximum possible so that he breathes out to his residual volume. After a complete forceful expiration, the volume left in the lung is the residual volume. So here some volumes are measured and some capacities are derived by adding volumes. So this is the tidal volume. And then above the tidal volume, what he can take further is the inspiratory reserve volume, and the tidal volume and the inspiratory reserve volume make the inspiratory capacity. Same way, this is the residual volume, and this, a person who for beyond the normal tidal breathing, what he can bring out is the expiratory reserve volume. So tidal volume and expiratory reserve volume form the expiratory capacity, or also then the volume of air left in the lung after normal tidal expiration is the functional residual capacity. We all use this term very often in anesthesia, the functional residual capacity, that is the amount of air remaining in the lung after a normal tidal expiration. So important things to know are the vital capacity, the functional residual capacity, and the total lung capacity, that is addition of all these volumes. So the normal values are like this for tidal volume, inspiratory reserve volume, and expiratory reserve volume. So 4 volumes and 4 capacities. So this is what a typical respiratory lab looks like. This is the lab in RML. And when spirometry is performed, the patient is made to sit comfortably. Sorry. And his nose is pinched and he purses his mouth around the mouthpiece and then is given instructions and made to give his 3 best attempts, and out of them, the best of the 3 is taken as the PFT reading, and this is the computerized report that comes out. So then this is a typical volume time graph, time on the x-axis and volume on the y-axis. So we can see that once patient starts expiring, initially the curve is very steep and he should bring out almost 80% of the total vital capacity in the first second. This is called the forced expiratory volume. Then the volume that he brings out in 2 seconds is FEV2, similarly FEV3. So FEV1 normally should be around 80%, FEV2 94%, and FEV3 97%. Most of the time, patient is able to bring out full vital capacity definitely in 6 seconds. Then FEV1 to FVC is a parameter which is very often used, should be more than 70%. And then something called forced expiratory flow in 25 to 75%. That is the mid expiratory flow, that is from 25% of vital capacity to 75%. This is used very often because it is considered a very good reflection of the small airway, of the airway caliber, and is effort independent. So this is what is a flow volume loop, which scares quite a few students, but you will very soon know that it is not something to be scared of. So again, the volume here on the x-axis and the flow, remember this is flow. Earlier it was volume and time. Here it is volume and flow. So volume, here the person starts inspiration at the residual volume, which is around 1.5 liters. He takes a deep breath, inspiration, and it ends at 6 to 7 liters of volume or total lung capacity. So he ends his inspiration. As you can see, the curve is very smooth, a gradual increase in the volume, in the flow, which then ceases. So the peak is somewhere in the middle of inspiration, the peak flow. And then patient breathes out, that is the forced expiratory volume. So here, when person is breathing out in expiration, you can see there is a sudden exponential increase in the expiratory flow, which then declines. So sudden increase, so that within 1 second, he brings out 80% of the expired volume. And you can see that the peak inspiratory flow is much less compared to the peak expiratory flow rate, which is more than 10. And the mid expiratory flow is not in the middle, it is later in the down slope. So the whole curve looks very much like a boat with a sail. And a normal curve should be a closed loop, and that is important. If the circuit is not having any leaks, the loop should close. A well-performed maneuver should close the loop. So this is the FVC, like I told you, and this is FEV1. The volume under this is the forced expiratory volume in 1 second. So important thing to know is the down slope, which should be a straight downward slope with no notch. Coming to the numerical data, FVC, forced vital capacity, should be more than 80% of predicted. FEV1 should be more than equal to 80% of predicted. FEV1 to FVC should be more than 70% as per gold criteria. We'll come to that later. Then forced expiratory flow 25 to 75% again should be more than 80%. And the peak expiratory flow rate values are given for the gender. So what are the numerical data like in mild obstructive lung disease? We all know that in mild obstructive lung disease, the vital capacity, forced vital capacity is maintained, but the FEV1, the forced expiratory volume in the first second is reduced because of the obstruction. So here, the dotted line is normal and the blue line is the curve in the obstructive lung disease. So here we can see that there is coving in this. This is because of the obstruction. So whenever you see coving in the forced in the flow volume loop, it indicates obstruction. However, here you can see that the forced vital capacity is maintained, although it is reached later, but it is maintained. So, but FEV1 to FVC is significantly reduced. Like here you can see FEV1 is significantly reduced because of the obstruction. And peak expiratory flow rate is maintained in the mild disease. In severe obstructive lung disease, the FEV1 is significantly reduced. FVC is also reduced, unlike in mild disease. And FEV1 to FVC is reduced, which is the hallmark of obstructive disease. And even PEFR, patient is not able to generate a good peak expiratory flow rate. Here you can see peak expiratory flow rate is reduced. There is significant coving. Even the residual volume is also increased in these patients because of the air trapping. So the curve is starting here, that is, it is starting at a higher volume. What about restrictive lung disease? Here, there is restriction to inspiration, but the airways are normal. As a result, the FVC is reduced. However, the percentage of FEV1 to FVC is maintained. And like you can see, the percentage is maintained. Here, the graph shape is same as the normal, but it is reduced in size and all volumes are reduced. Here, instead of starting residual volume here, it is here because the lung capacity is reduced. Then the tidal volume is reduced. The flow generated is reduced. However, the shape is same. There is no coving here. So the post-vital capacity is reduced. It is from residual volume to this. It is this much, unlike in normal where it is up to 6 liters. I hope it is clear. So volume time graph, this is the comparison. This is normal in an obstruction and in restriction. And flow volume loop, again, the same what I told you, there is significant coving in COPD, and the identical graph, although smaller in size and volume in restrictive disease. So interpretation, obstructive lung disease, first thing we see FEV1, it is reduced. FVC is normal, although in severe obstruction, it may be decreased. And FEV1 to FVC, which is also called Tiffany index, is decreased less than 70%. In restrictive lung disease, FEV1 is reduced, FVC is reduced, both in reduced to the same extent, hence the FEV1 to FVC, that is the Tiffany index, is always greater than 70%. Unless, of course, if there is a mixed picture when there is superimposed bronchoconstriction in restrictive disease. So this is the gold criteria for staging COPD. Stage 1 is FEV1 more than equal to 80%. Stage 2 is 50 to 80%. Stage 3 is 30 to 50%. And stage 4 is when FEV1 is less than 30%. And FEV1 to FVC for all categories should be less than 70% as per the definition of COPD. And whenever a post-bronchodilator PFT is done, and in any increase of more than 12 to 15% in FEV1 is considered significant, and that means bronchodilator is able to increase the caliber, so there is no fixed obstruction but a dynamic obstruction. Coming to the flow volume loops of upper airway obstruction, again very often students get confused in this. So the obstructions can be first divided into something called a fixed obstruction or a variable obstruction. Fixed obstruction is that there is a tight obstruction, and variable is when there is a moving obstruction which gets affected by the surrounding pressures. So any fixed obstruction, whether it is intrathoracic or extrathoracic, is not affected by any of the pressures around. So during inspiration, there is blunting, and so is during expiration. There is no effect of respiratory cycle. However, in extrathoracic obstruction, like a vocal cord paralysis, so what happens during inspiration, there is negative intrathoracic pressure during spontaneous breathing. That transmits negative pressure in the airway, and so already paralyzed vocal cords, they collapse. As a result, during inspiration, there is blunting, and reduction. However, during expiration, because there is positive intrathoracic pressure, the airway pressure also becomes positive and the vocal cords open up and there is no blunting in the expiratory flow volume loop. In tracheomalacia is intrathoracic. As a result, during inspiration, when there is negative intrathoracic pressure, the trachea gets pulled out. And because it gets pulled out, it opens up. So during inspiration, there is no blunting. However, during expiration, there is positive intrathoracic pressure, which further compresses the already soft trachea and causes blunting. I hope it's clear. So coming to lung volumes. This is to measure the volumes which are not taking part in the gas exchange. So mainly to measure the residual volume, FRC, and total lung capacity. So the methods used are helium dilution method, nitrogen washout, body plethysmography. These are all dynamic methods, and radiographic measurements of the chest wall. This is a static measurement, and the principle is that when these gases, helium or nitrogen wash out, helium when given, it equilibrates with the residual volume, and so a initial measured concentration of helium in a closed circuit is given, and the final dilution is measured, which indicates the amount of dilution that happens. Important thing is that patient has to start breathing at FRC, not at after inspiration of tidal volume. And then nitrogen washout, again, there is pre-existing air and nitrogen in the lung. So when patient is made to breathe through a system of 100% oxygen, the amount of nitrogen that is collected is then measured. Coming to normal lung volume. So total lung capacity predicted is this. And so when total lung capacity is measured and it is 80% to 120%, it is considered normal. However, anything less than 80% is considered abnormal, and more than 120% is also abnormal. One needs to look at the residual volume. If the total lung capacity is normal and the residual volume is increased, it indicates air trapping. So it's important to see the ratio of residual volume to total lung capacity, that is the percent of total lung capacity that is occupied by the residual volume. If it is high, it indicates that there is air trapping, because of which a major part of the lung is not taking part in gas exchange. Then coming to diffusion capacity of carbon monoxide. This is important because carbon monoxide easily diffuses through the alveolo-capillary membrane, and so this method is used to study the integrity of alveolo-capillary membrane. Carbon monoxide is highly soluble and high affinity for hemoglobin and not normally present in blood. This is measured as volume of carbon monoxide per minute per unit of pressure across the alveolo-capillary membrane, and is then compared with the predicted value. It is indicative of functional surface area available for diffusion of gases. Again, normal is 80 to 120%, and lung disease that decreases the total area available for diffusion or increases the thickness of the alveolo-capillary membrane, decreases DLCO. Remember, it can either be a faulty membrane, but membrane surface area is not reduced, or membrane surface area is reduced, like in lung resection. Although the existing membrane is normal, then also you may get a falsely low DLCO. So more than 120% with obstructive pattern may be indicative of air trapping. DLCO less than 40% is indicative of severe impairment. And you may get a falsely low DLCO in active cigarette smoking. And there is some low DLCO also in pulmonary arterial hypertension. Then something called DL by VA. VA is alveolar ventilation. So it's a diffusion correction is done. That is to remove any falsely low DLCO, like I told you in lung resection. So DLCO is corrected for alveolar volume. Low DLCO with normal DL by VA indicates the whole VQ gas exchange units have been lost, like in lung resection. So DL by VA is normal. However, a low DLCO with low DL by VA implies a poor alveolo-capillary membrane function. Something called cardiopulmonary exercise testing. It quantifies the functional capacity of a subject to respond to increased metabolic demands of major surgery. It uses 3 measures: peak VO2, anaerobic threshold, and ventilatory equivalent for carbon dioxide. Patients with peak VO2 less than 10 ml per kg per minute or less than 35% are at high risk for perioperative death and cardiopulmonary complications. Coming to algorithm to interpret PFT. FEV1 by FVC is the first value that one should look at in a PFT chart. If FEV1 to FVC is normal, that is more than 70%, then one should next look at FVC. In FVC, if FVC is also normal, then it's a normal ventilatory pattern. Then look at DLCO. It may still have a lower DLCO. So then it is indicative of a thromboembolic disease where all the ventilatory parameters are normal. However, if FVC is normal, but total lung capacity is reduced, it may go in favor of either a non-specific pattern or a restrictive pattern if TLC is also low. So FEV1 is normal, vital capacity low, total lung capacity low, may go in favor of either with low DLCO, pulmonary fibrosis, and normal DLCO like in neuromuscular chest wall or pleural disorders. What happens if FEV1 to FVC is low? We know it's an obstructive pattern. Here, FVC may be normal or may be low. In severe lung disease, again indicates obstructive pattern. Once you get an obstructive pattern, if the DLCO is low, it indicates emphysema and cystic lung disease, that is the alveolar capillary breakdown. But if it is normal, then it goes in favor of chronic bronchitis, asthma, and bronchitis. Coming to a PFT report. So first look at the FEV1 to FVC. It is severely reduced. So definitely goes in favor of obstructive lung disease. FVC is normal. So it is again obstructive lung disease. Then one should look at the total lung capacity and residual volume. Total lung capacity is increased to 117. However, residual volume is much more increased, so it is going in favor of air trapping, and DLCO is 52%, that is significantly reduced, so goes in favor of emphysema. Coming to another PFT, first look at FEV1 to FVC. It is not as per the obstructive pattern as per the criteria. It is more than 70%. Let's look at FVC. FVC is also borderline, up to 80% is normal, so it is borderline. Let's look at the total lung capacity is also reduced, borderline. Residual volume is normal. However, DLCO is significantly reduced, so this is going in favor of a pulmonary disease, a pulmonary vascular disease, because the ventilatory parameters are more or less normal. So the key points are, one should take a detailed history, don't undermine detailed history, thorough clinical examination and routine investigations. Make a habit to perform bedside PFTs in PSC clinic, and be confident in reading and interpreting a PFT report, and hence reduce the burden on a respiratory physician. Thank you.
Thank you, Namita ji, for giving such a wonderful lecture, such a detailed pulmonary function test lecture. I will
Thank you,
comment
ma'am.
on. I will
Dr.
comment
GP
only one
Singh,
thing.
sir, would you like to address the question to ma'am?
I'm not able to read it. Just a minute. Let me see. How many maneuvers must be completed to say it is a valid
I think
PFT?
sir has lost his
Sir is
connection.
muted.
Sir, are you muted?
Yeah, I'm
Can you
unmuted.
unmute yourself?
How many maneuvers must be compelled
Sir, I think
completed
you
to
are
say it is a valid
muted.
PFT test? Namita
We
ji,
can't hear you.
you can't hear me. I'm unmuted.
Audible, sir. Audible.
So, ma'am, we have a question. What are the maneuvers which should be completed before one can confirm that it's a valid pulmonary function test?
Which maneuver should be completed? I don't get the question.
Confirming that it's a valid pulmonary function
I don't
test.
get the question.
How
Who has
many
asked this
maneuvers?
question?
How many
If you can
maneuvers?
be more clear.
Question is not clear.
One
Yeah.
wants to ask that what are the prerequisites of confirming that it's a valid pulmonary function test? Because many a times we see that the test is invalid.
See, it should be performed well, and like I told you, it should be as per the reports that you get should be in sync with the clinical picture that you get. If the clinical picture is not showing significant reduction in volumes, but when a PFT is performed, you don't get good volumes and it shows severe reduction, it indicates that patient may not have performed the test well. Secondly, the flow volume loop should close. That indicates that the circuit was not having any leak. That is, the volume at which a patient starts should end at that volume. And that is why 3 attempts are given for PFT, so that the person, if in one he does not understand, he is getting repeated, and if he is performed well, then all the 3 should be almost similar. I hope it answers the question.
Thank you, ma'am, for informative session. Dr. G, we move on to our next lecture. Dr. GP Singh, sir, will you kindly introduce the next speaker?
Yes. Next speaker is Dr. Meenu Chadda. I don't think she requires any introduction. However, I have to say something about her. She is head of department at CHL hospital. She is senior anesthetist there, and she is pain physician. she has delivered many lectures in as faculty in ISA conference, Spain conference, and she has got number of publications to her credit. She is ex-president of UP chapter, MP chapter ISA, and she has been co-editor of Central Zone ISA. Minuji, please present your. She has to present her lecture, and Minuji, please. Dr. Minu, please.
Good morning, everybody. Now, today we would be talking about two important topics, which are especially important for the postgraduate students. That is monitoring and anesthesia, of which the two important ones are the pulse oximetry and the capnography. Let us take pulse oximetry first. The objectives of this talk would include the introduction, history and development, oxygen hemoglobin dissociation curve, how the oximeter works, limitations and advances. So what is pulse oximeter? It measures the percentage of oxyhemoglobin in the arterial blood. Pulse oximetry, sometimes called the fifth vital sign, is a non-invasive method of measuring the hemoglobin saturation by using a light signal transmitted through the tissue. The American Society of Anesthesiologists and the American Association of Nurse Anesthetists have made assessment of oxygenation a standard for intraoperative and postoperative monitoring. In 2005, an audible alarm for pulse oximeter was added to the ASA monitoring standards. Now let us look at, in brief, at the history of it. The first pulse oximeter was developed by the German scientists in the early part of 1930s by using spectrophotometry. In 1935, Karl Matthias made the first machine which could be legitimately called the pulse oximeter. 5 years later, World War II, it was found that a lot of pilots died because they were traveling in an unpressurized cabins and you could not find out who suffered hypoxemia. So this caused the military to design a pulse oximeter with a mini probe, and that could save many lives. 25 years later, Hewlett and Packard marketed the first pulse oximeter, but the disadvantage of it was that it was very heavy, about 35 pounds, and it used heated temperature. So what had to be done was that the finger had to be changed from time and time, especially in small children, to prevent finger burns. In 1970, Biox is made the small pulse oximeter, which could be handheld, and now it could be mounted on the IV poles. So the nurses could take pulse oximetry, the saturation, as the fifth vital sign. 1980s came the advancement. The microprocessors became smaller. In 1990, they became much more accurate and inexpensive. And in 1995, Nonin developed the first finger pulse oximeter. Now, pulse oximeter is available over the counter in most of the places. And with the advent of COVID, now almost every household has pulse oximeter. Now, what is the purpose of this pulse oximeter? It measures the percentage of oxyhemoglobin in the arterial blood. Now, if these are all the hemoglobin molecules, we see that there are 16 hemoglobin molecules, out of which 8 do not, the blue ones, they do not contain oxygen, while the red ones, they contain oxygen. So those which do not contain oxygen, they are called as reduced or deoxyhemoglobin, while those which contain oxygen, they are called oxyhemoglobin. So out of 16, the 8 contain oxyhemoglobin. So you can say that the oxygen saturation of this patient is about 50%. Now, before we go into the detail, let us look at the oxygen hemoglobin dissociation curve. Now, this is a curve that plots the proportion of hemoglobin in the saturated form on the vertical axis against the partial pressure of oxygen dissolved in plasma in the horizontal axis. Now, the oxyhemoglobin dissociation curve, it has a sigmoid shape and it is made at a pH of about 7.4, which is the universal curve. This curve can be used as a calculator because if you know the percentage saturation of oxygen, that is SaO2, you can find out the partial pressure of oxygen. Now, suppose the percentage oxygen saturation is 90%. Then what you do is that you draw a horizontal line from 90% that is from somewhere here until it hits the curve. And from there, you draw a vertical line down on the y-axis, on the x-axis, sorry. So what you would get here is when you draw from 90 degrees, you would get a partial pressure of oxygen at 60 degrees, 60 millimeter of mercury. So this is very, very important because at a saturation of 90, the partial pressure of oxygen is 60, and that is what is the minimum which is tolerated by a human being. And most human beings don't respond well if the PO2 is below 60 millimeter of mercury. Now, certain factors such as the local prevailing CO2 pressure, pH, temperature, 2-3 dpg, it affects the curve. Now, when the patient hyperventilates, they lower the CO2 levels, that is, the pH is increased. So it causes a left shifting of the curve. While when there is hypoventilation, there is a low pH, that it becomes much more acidic, and there is a right side shifting of the curve. Now, if the patient with who's hyperventilating, when the curve is shifted to the left, presents with a saturation of 90, do you assume that the PO2 would be 60? If you assume that, then that is very incorrect, because now the curve is shifted to the left. So when you draw a horizontal line like this, when you hit the curve and you draw a vertical line hitting the x-axis, you find that now at this pressure, the partial pressure of oxygen is 50. Hence, in these cases, it is very necessary to do an ABG for a correct assessment. Now, how this pulse oximeter works? Every pulse oximeter, it has a probe with 2 light emitting diodes, a light collector, and a microprocessor. Now, these probes, they come in basically 2 types. Now, the finger probe, the one which can be attached on the foot and the bridge of the nose, they use the transmission pulse oximetry. While the probe which is attached on the forehead, especially in small children, it utilizes the reflectance pulse oximetry, and it relies on the fact that the light that is reflected, the reflection occurs at the interface between materials with different reflective indices, and photodiode area needs to be large as possible because the signal is much weaker. Now let us look at, in brief, at the anatomy of the probe. On one side, there are 2 light emitting diodes. The red light emitting diode, which emits visible light with a wavelength of 660 nanometers, while the other light emitting diode emits the infrared light, which is invisible to the eye, and it has a wavelength of 940 nanometers. On the opposite side of the probe is the light collector. This measures the amount of the light that is not absorbed by the finger. Now, when you see the probe, you see only the light that is visible to the eye, that is the red light with a wavelength of 660 nanometer, while the infrared light is also emitting light, but it is not visible to the human eye. Both of these are emitting light at several hundred times per second, and neither light is on at the same time. This is just too fast for the human eye to decipher. Now let us consider the microprocessor and see how it uses the information gathered to calculate the SpO2. When the finger is placed between the probe, the light and the light source and the light collector, some of the light will not pass to the collector and it will be absorbed by the non-pulsatile tissue in the finger, such as the bone and the skin. The amount of the light which passes through will be constant. In the absorption timeline, next we have to consider the light absorption properties of the pulsatile tissues, which for the most part is blood in the arteries. Every time a pulse wave goes through the arteries, the light absorption pattern changes. This changing pattern is represented by the red waves on top of the constant non-pulsatile flow. So this is the waves which represent the pulsatile flow. The probe now has provided the microprocessor with enough information to begin the analysis. Now what this microprocessor is done is that, let us go backward, is first it subtracts the non-pulsatile from the total flow which is calculated, and then you can get the flow through the hemoglobin, and this is where the oxyhemoglobin is, and then the microprocessor calculates the SpO2. Now this calculation involves 2 principles of physics. Now, these are the two principles of physics which are involved. That is the Beer's law, which depends on the concentration of the light absorbing substance. In this case, it is the hemoglobin. The Lambert's law, which depends on the distance the light must travel. And the fact that oxyhemoglobin and reduced hemoglobin absorb red and infrared light in different ratio. Now let's have a look at the Beer's law. Now, first it states that the amount of light absorbed is proportional to the concentration of the light absorbing substance. This is demonstrated in the following image. So finger on the right will absorb, the finger on the left will absorb much more light because of the greater concentration of hemoglobin, while the finger on the right has less concentration of hemoglobin, so there is low absorption. So in the case of high concentration, there is one wave which reaches the light collector, while in low concentration, there are 3 lights which reach. The next principle is the Lambert's law. In this, the amount of light absorbed, it depends on the length of the path the light has to travel. Now let us consider 2 fingers in which we have a constant hemoglobin, which is represented by the blue line. And the finger on the right has much thinner arteries, while finger on the left has a thicker artery. So the light has to travel a greater distance in this, in which the artery is much bigger. The third is that the pulse oximetry consists of red and infrared light emitting LED and a photodetector. And the oxygenated and deoxygenated hemoglobin, they have different light absorption rate. The oxygenated hemoglobin absorbs more infrared light, while the deoxygenated hemoglobin absorbs much more red light. Now, there are certain limitations of the pulse oximeter. Many limitation is it can be less accurate when measuring the SpO2 below 75%. Now, I have just told you how Beer's law and Lambert's law can be used to compute the SpO2. And these 2 laws of physics are based on the fact that the light wave goes straight through the liquid in question. Now, the human blood, it contains RBC, WBC, and other entities that scatter the light waves. So now we know that the Beer's law and Lambert's law can't be applied strictly in these cases. Manufacturers for pulse oximeters, they create calibration table to correct for the scattered light. Human volunteers are taken for this, and they are made to breathe decreasing concentration of oxygen. The arterial blood samples are drawn, and you compare the SpO2 and the arterial blood samples, and you create the calibration tables. Now, since it is the human subjects which have taken into account, it is very difficult to allow the human volunteers to allow them to breathe an oxygen saturation less than 75%. That is why it is said that the accuracy is much less, below 75%. Another thing which is important is the poor peripheral perfusion. It is must understood that either you will not get a reading or you will get an inaccurate reading. Now we know that SpO2 is calculated by the light absorbed when passing through the pulsatile blood flow. Now this pulsatile signal is only about 2%, while the other 98% is the non-pulsatile signal. Now the arteries produce even much less smaller signal if they have poor perfusion. Each oximeter has a limitation beyond which it cannot read the signal. Probably the number 1 cause of poor perfusion is cardiac insufficiency. That is, when the heart is not pumping well, you will have poor perfusion. Hypovolemia is another cause which can occur intraoperatively due to loss of fluid. Then hypotension, which again cause poor peripheral perfusion. Similarly, hypothermia, cardiopulmonary bypass, peripheral vascular disease, especially the Raynaud's disease, where there may be poor pulses, infusion of vasoactive drugs, trauma and bleeding, where there may be a lot of bleeding, and it may result in hypovolemia and hypotension. So it may result in poor perfusion. There are certain methods how you can correct it is by application of vasodilating cream, digital nerve blocks, which may cause vasodilatation, administration of vasodilators, and warming the hand. You can do it by putting a glove filled with warm water and putting it in the hand. Now, how the method to improve, now, how do you know, in this case, how will you know that the SpO2 reading is correct? You have to check the size of the plethysmograph, because SpO2 reflects the changes in volume, while the arterial line reflects the changes in the blood pressure. So you will get, if you get an irregular graph, it shows that there is change in volume and the SpO2 is low. Looking at this, the manufacturers have come up with another entity, which is the perfusion index. This is the ratio of the pulsatile blood flow to the non-pulsatile blood flow or the static blood flow in the peripheral tissue. It can be calculated by perfusion index is AC upon DC into 100, while AC is the pulsatile blood flow, DC is the non-pulsatile blood flow, and low perfusion index means peripheral vasoconstriction, and high perfusion index means peripheral vasodilatation. Another factor which can cause some problem is the light, the ambient light. The light collector collects light from red and infrared light source along with the light present in the room, which can also reach the light corrector. The microprocessor smartly tackles this problem. When the red light is on, it records the red pattern of the red light. When the infrared light is on, it records the pattern of the infrared light and the ambient light. And when both the lights are off, it records only the ambient light. Now the microprocessor, it just subtracts the ambient light from the red and infrared light to get the ratio. The problem only occurs when the ambient light is too strong and the microprocessor is unable to digest the problem, especially if there are strong surgical lights or a fiber optic cable is used. Now the best is to cover the hand in which the pulse oximeter is put with a sheet or something so that the ambient light does not interfere with the reading. Now we know that a pulse oximeter is an indirect non-invasive way to check the body's oxygen level. However, anything that can create a barrier between the nail bed and the infrared beam of the oximeter can affect the reading. Apart from fancy nail art and gel or acrylic nails, there are certain colors which may interfere with the readings of the pulse oximeter. They may be blue, green, black, dark red, or purple. Now, with the use of ICG, which we use for laparoscopy, we sometimes give intravenous dyes to the patient. Now, use of dyes such as methylene blue, indocyanine green, or indigo carmine, they may also alter the pulse oximeter reading. Now, limitations. Now, we know that pulse oximeter does not monitor ventilation. They do not tell us about the arterial CO2. Now, just because that the SpO2 is 97%, it does not mean that the patient is doing well. The most common example would be an emphysematous patient who's in a hypoxic drive. Now, the SpO2 needs to be between 85 to 90%, but to maintain a normal CO2 level. But if the SpO2 is 97%, it may cause an increase in the carbon dioxide. Certain abnormal hemoglobin, such as carboxyhemoglobin, which is formed from carbon monoxide and hemoglobin, and methemoglobin may also alter the SpO2 readings. Nowadays, the new pulse oximeters have been developed, which take these abnormal hemoglobins into account. Now, movement of the probe. The accuracy is also questioned during the movement of the probe. We know that the pulsatile flow, which creates the signal, is only about 2%. Now, when the patient moves his finger, the blood in the artery and the veins, they move, creating a noise. Since both red and infrared signals may be interpreted as noise, you can get a light absorption ratio of 1:1, which is interpreted by a microprocessor as an SpO2 reading of 82%. Manufacturers have tried to solve this problem by lengthening the average time, which would allow the calculation of the accurate SpO2. Now, there have been certain advances in the pulse oximeter. Now, I would like to call it as a fair weather friend because it does not perform well in the cases of poor peripheral perfusion or when the hand is in motion. Now, Massimo has used a signal extraction technology, which makes the assumption that in addition to the arterial blood volume changes, the venous blood volume also changes every time the patient breathes or moves. The SET uses filters
and 5 proprietary signal processing algorithms. And they claim to provide accurate SpO2 during poor peripheral perfusion and movement. Now, the routine pulse oximeter uses the standard red and infrared light for the calculation to the ratio of the optical densities. And these optical density ratios are used by the microprocessor to calculate the SpO2. Now, we know that venous blood flow is at a relatively low pressure, so shivering or tapping of the probe may create a noise, and there may be a signal to noise ratio, which may be 1:1, and this can overwhelm the conventional oximeters, and it can give a fixed value of about 82%. So the advantage is that but we know the importance of SET is that it is a platform for calculating the accurate perfusion index. So it uses the noise cancelling filters, the proprietary algorithms, and isolates the noise to get an accurate pulse signal. So it is a platform for calculating an accurate perfusion index, which is the ratio of the pulsatile blood to the non-pulsatile blood. Perfusion index is a non-invasive measurement of peripheral perfusion. So you have to choose the optimal site of probe placement, which gives us the highest and the most stable perfusion index. Because of this, there have been certain clinical applications of perfusion index. Now, if an increase in the perfusion index shows that epidural or general anesthesia has initiated the peripheral vasodilatation, which occurs before the onset of the anesthetic effect. A detection in the spike of perfusion index is a successful onset of anesthesia. Conversely, no increase in perfusion index may be warning of an anesthetic failure. Perfusion index can also be used for pain management, especially in patients who are unable to communicate. And in small children, the low perfusion index is a measure of acute illness, especially in neonatal acute care. Potential future application of perfusion index is to predict the success of reimplanted body parts, restoration of peripheral perfusion after cardiopulmonary bypass, and estimation of volume status in trauma patients. Now, there is other advanced thing which has come up, which is the pleth variability index. This represents the dynamic changes in the perfusion index during a respiratory cycle. Now, looking at this graph, we can see that the graph is very irregular. At certain point, the perfusion index is very high, while at certain point, the perfusion index is very low. So the pleth variability index can be calculated by PI max minus PI minimum divided by PI max into 100%. So it is represented in percentage, and it depends on the changing balance between the intrathoracic airway pressure and the intravascular fluid volume. Now, since it is based on the fact that it depends on the intrathoracic pressure and the intravascular pressure, the high intrathoracic pressure, which occurs during the asthmatic attack, it can monitor the severity of the attack and monitor the response to therapy. The trending of pleth variability index is that it monitors the hydration of surgical patient, and rising pleth variability index may indicate hypovolemia. Now, Massimo has come up with another technology. They use 7 wavelengths of light rather than the the additional wavelength. They allow the calculation of other hemoglobin, that is the carboxyhemoglobin, methemoglobin, in addition to oxyhemoglobin and the pulse rate. So to conclude, I would say that despite all the problems and limitations, pulse oximeter remains the standard of care in all clinical situations, and it's useful for all patients under anesthesia. Does the use of pulse oximeter prevent complications? Yes, because the early warning of hypoxic event help the anesthesiologist to take remedial action before the irreversible organ damage occurs. Now, does the use of pulse oximeter actually help save life? A closed claim analysis was done by the ASA in 1980, and they found that it really helps, and that is why it is formed as a part of basic monitoring during anesthesia since 1989. So intelligent use of pulse oximeter can help save life and prevent disasters due to hypoxic event. So I would just like to end by saying that as the blindfold anesthetist walks unknowingly towards the cliff of hypoxia, whether due to problems of inspired gas, equipment failure, underventilation, or abnormal pulmonary shunting, the protective hand of pulse oximetry sentry stops him from falling over the edge. Now, the another important thing is the end tidal CO2. Now, what we will be covering in this lecture would be the terminology, the ASA guidelines, CO2 production and absorption, technology, physiology, normal capnogram, key applications, and the advances. Now, what is capnometry? It is the measurement and display of CO2 in a digital analog monitor. Maximum inspiratory and expiratory CO2 concentration during a respiratory cycle are displayed. Capnograph is a graphic display of instantaneous CO2 concentration versus time or expired volume in a respiratory cycle. Capnogram, their CO2 waveforms, they can be of two types. The FCO2 can be plotted against the expired volume, which is the volume capnogram, or against the time, which is the time capnogram during a respiratory cycle. Now, PaCO2 is the partial pressure of carbon dioxide in the alveoli. PaCO2 is the partial pressure of carbon dioxide in the arterial blood. PETCO2 is the partial pressure of carbon dioxide at the end of expiration. A-ETPCO2 is the arterial to end tidal CO2 tension or pressure difference or gradient. PVCO2 is the partial pressure of carbon dioxide in the mixed venous blood. Now, in 1970s, there was explosion of medical malpractice in youth, and there were a lot of lawsuits filed in US for anesthesia accidents. So, looking at this, in 1985, a Harvard Risk Management Committee headed by John Eichenborn created a set of anesthesia standard, which later became a template for subsequent efforts. In 1989, as we have said, ASA standard included pulse oximetry as part of monitoring. In 1990, ASA standard used capnography. In 1999, it was found to be a standard for every patient receiving general anesthesia, including those with mask anesthesia. In 2011, capnography formed a part of minimum mandatory monitoring. Now, why capnography? Now, pulse oximeter is a direct monitor to reflect the state of oxygenation of the patient. Capnography is an indirect monitor and helps in differential diagnosis of hypoxia to enable remedial measures to be taken before it results in irreversible brain damage. Capnography provides information of CO2 production, pulmonary perfusion, alveolar ventilation, respiratory patterns, and elimination of carbon dioxide from the anesthesia circuit and ventilator. Capnography has been found to be effective in early detection of adverse respiratory events. SpO2 and EtCO2, they have together found that it prevented 93% of avoidable anesthetic mishaps. So capnography also facilitates better detection of potential life-threatening problems than clinical judgment alone. Now, let us look in short at the composition of air. The air is a mixture of oxygen, nitrogen, carbon dioxide, water vapor, and certain inert gases. Now, in this graph, let us look at the percentage of gases present during inspiration and expiration. Now, we see that the oxygen changes from 21 to 17%, while carbon dioxide changes from nearly 0 to 4%, while the nitrogen and the inert gases, they remain the same. How this works, the methods to measure the carbon dioxide, it include infrared spectrography, Raman spectrography, mass spectrography, photoacoustic spectrography, and chemical calorimetric analysis. The infrared method is the most widely used and most cost effective. The infrared absorption is commonly used principle for capnography, and it is based on the fact that the CO2 molecule is absorbed infrared light at specific wavelengths, with the amount of energy absorbed being directly related to the CO2 concentration. Now, when the infrared light beam, it passes through a gas sample containing CO2, the electronic signal from the photodetector, which measures the remaining light energy, can be obtained. The signal is then compared to the energy of the infrared source and calibrated accurately to reflect the CO2 concentration in the sample to calibrate the photodetector's response to a known concentration of CO2 stored in the monitor's memory. Now, there are basically two types of capnography. They may be the mainstream, in this which the CO2 sensor is located between the endotracheal tube and the breathing circuit, and the side stream, in which the sensor is located in the main unit and CO2 is aspirated while a sampling tube connected to a T-piece adapter located between the endotracheal tube and the breathing circuit. Now, let us look at the various advantages and disadvantages of the capnography. The side stream has the advantage because it is easy to connect, no problem with sterilization, can be used in awake patients also when you give regional anesthesia, easy to use when the patient is in unusual position such as in the prone position, can be used in collaboration with simultaneous oxygen administration via nasal prong, as I've said, especially in regional anesthesia. The disadvantage is there is delay in recording due to movement of gases from the endotracheal tube to the unit. Sampling tube obstruction can occur. Water vapor pressure changes may affect the CO2 concentration. Pressure drop along the sampling tube affects the CO2 measurement. And deformity of capnogram may occur in children due to dispersion of gases in the sampling tubes. In the mainstream, the advantages are there is no sampling tube, no obstruction, no effect of pressure drop, no pollution, no deformity, no delay, and suitable for neonates and children. The disadvantages, there were a lot of disadvantages with the older ones, but the newer ones have overcome these advantages. Like the older ones, they were heavy, so they caused a considerable traction on the endotracheal tube, while the newer are lightweight. There is a long electric cord, but it is also lightweight. Facial burns used to occur with the earlier version, but it is now eliminated. However, the sensor window may clog with secretions, difficult to use in abnormal position, and disposable sensors are generally used. Now, the respiratory cycle. Now, this consists of inspiration and expiration. And to understand capnography, you have to understand oxygenation and ventilation, which are two different mechanisms, but both rely on the respiratory cycle. The oxygenation relies on the inspiratory phase, and it refers to the amount of oxygen which is available and utilized, while ventilation relies on the expiratory phase, and it refers to the amount of CO2 produced during the metabolic cycle of the cells and exhaled from the body. So determination of oxygenation can be done invasively by the ABG and non-invasively by pulse oximetry, while of the ventilation can be done invasively by the ABG and non-invasively by the EtCO2 monitoring. Now, at the end of the inspiration, we know that there is no rebreathing. The airway and lungs are filled with CO2-free gases. The CO2 diffuses into the alveoli and equilibrates with the end alveolar capillary blood. The actual concentration of CO2 in the alveoli is determined by the VQ ratio. The alveoli with the higher ventilation, that is the high VQ ratio, has lower CO2 compared with alveoli with a low VQ ratio. As one moves proximally in the respiratory tract, the concentration of CO2 gradually decreases to zero. The volume of CO2-free gas is known as the respiratory dead space, as there is no exchange of oxygen and carbon dioxide between the inspired gases and the blood. As the patient exhales, the CO2 sensor at the mouth will detect no CO2, as the initial gas would be from the dead space, and as the exhalation continues, the CO2 concentration rises gradually and reaches a peak because of the CO2-rich gases from the alveoli make their way into the CO2 sensing monitor, which is connected at the patient's mouth. At the end of exhalation, the CO2 concentration decreases to zero, and the patient starts inhalation of the CO2-free gases. Now, let us look at the components of the capnogram. The components are the inspiratory segment, which is the phase 0, expiratory segment, which is phase 1, 2, and 3, alpha angle and beta angle, and the phase 4. Now the phase 0, this is the phase 0. It represents the dynamics of the inspiration after phase 3 is complete. Now after this phase 3 is complete, the descending limb, it makes a right angle and returns rapidly to the baseline. This represents the inspiratory phase during which the fresh gases, that is the CO2 free gases, are inhaled and the CO2 concentration falls to 0. Now the alpha angle. Now this is the alpha angle which occurs between the phase 2 and phase 3, and it is nearly 90 degrees, and it increases as the slope of the phase 3 increases. This is an indirect indication of the VQ status of the lung. Now the beta angle is the angle between the phase 3 and phase 0, and this is mostly 90 degrees, and it can be used to assess breathing. During rebreathing, there is an increase of the beta angle from 90 degrees. As rebreathing increases, the horizontal baseline of the phase 0, it increases, so this angle can increase. Sometimes you can also see a terminal upswing can be seen at the end of the phase 3, which is the phase 4. Now this occurs especially in obese patients and in pregnant patients where the thoracic compliance is reduced. This is because the slow alveoli empty out more evenly, and increase in PCO2 is spread more evenly over the tidal volume. Now the expiratory phase, now this is the phase 1, which is the anatomical dead space. Then there is the phase 2, which is the anatomical dead space and the alveolar dead space. And phase 3 is the alveolar plateau. Now there are basically two types of capnograms, that is the volume capnogram and the time capnogram. When the CO2 concentration can be plotted against the time, it is the time capnogram, while when it is plotted against the volume, then it is the volume capnogram. In the respiratory cycle. Now the volume capnogram has only the expiratory segment, while the time capnogram has both the inspiratory and the expiratory segment. Now the advantages of time capnography is it is simple and convenient. It can monitor the non-intubated patient because it does not require a ventilator and can be used to monitor even spontaneous ventilation. This is because it uses both mainstream or the side stream sensor. It can monitor the dynamics of inspiration and expiration, while volume CO2 monitors only expiration. The disadvantage is it causes a poor evaluation of the VQ status of the lung, because VQ status of the lung is more accurately reflected in the slope of phase 3 in a volume capnogram. It can't be used to estimate components of the physiological dead space, although the time capnogram grossly can be related to tidal volume and its components. The physiological dead space, cardiac output, components of tidal volume can't be determined from a time capnograph as it is recorded. Now let us look at some of the graphs of capnograph. Now this is very important in your day-to-day life. Now first one is the normal capnogram. Now this consists of a baseline, an upstroke, a plateau, and a downstroke. Now as I have earlier said, that this is the dead space, this is alveolar dead space plus the alveolar gas, this is the alveolar plateau, and this is the inspiration. Now the second graph is that which occurs in bronchospasm or there is any obstruction. In this, the alpha angle has increased. That means that the alveolar plateau is not achieved because of some obstruction. Any partial obstruction in the respiratory tract causes this, and thus the end tidal CO2 increases. This is also known as the shark fin pattern. You can see that it resembles a shark fin-like pattern, and it can occur in any kind of obstruction, bronchial asthma, COPD patient, or an endotracheal obstruction. The next graph is what occurs in the hypoventilation. Here the EtCO2 value, it decreases, but the graph, pattern of the graph, it remains the same. This is because the CO2 production is increased, or the CO2 is not going out of the blood, that is not getting exchanged. It occurs in the hypermetabolic state like hyperthermia, fever, shivering, hypoperfusion, etc. So as I've said earlier, the graph remains the same, but the value has increased. The next graph is that of the hyperventilation. In this, the EtCO2 value decreases. In this case, the metabolism has decreased and the CO2 is going out very fast. So EtCO2 value decreases, or the perfusion is affected or increased, as it may occur in hypothermia or hyperventilation. Now, normally in the expiratory gas, there is CO2, while the inspiratory gas, there is no, or in the alveolar dead space, there is no CO2. But if CO2 occurs in the inspiratory gas or the alveolar dead space, the baseline value of CO2 will increase. This occurs in rebreathing and may occur especially intraoperatively if the unidirectional valve of the circuit gets incompetent, the CO2 absorber is exhausted, or fresh gas flow is not adequate. So this is the graph of rebreathing. The next graph is that of a curare cleft. Now this depression which occurs is known as the curare cleft. This occurs when there is incoordination between the patient's ventilation and ventilation by the ventilator. That is, the patient starts spontaneous breathing on ventilator. Intraoperatively, it occurs when the patient comes out of the effect of the muscle relaxant and there is return of spontaneous respiration. Giving a dose of muscle relaxant would simply solve this problem. Now, the next two graphs, they are of the cardiac arrest and the return of the spontaneous circulation during cardiac arrest. So they show the importance of using EtCO2 during CPR. If there is a return of spontaneous circulation, then there is pulse and there is increase in the cardiac output. Now, if the patient is dead, there is no pulse or cardiac output. During CPR, the EtCO2 is equal to cardiac output, which indicates the return of the spontaneous circulation. Now, what are the clinical applications of capnogram? They can be from the numbers, that is PEtCO2 of value of capnography, which may increase or decrease. From the lines and curves, that is the shapes of the capnogram, as we have said, there may be abnormal shapes of the capnogram which may occur. And from the AETCO2 gradient or difference, that is the alveolar dead space, there are three important applications from it. It can monitor the PaCO2, monitor the alveolar dead space, and monitor the clinical progress of a critical patients. Now, we know that CO2 is produced in the body by cellular metabolism, conveyed by circulatory system to the lungs, excreted by the lungs, and transported by the breathing system. Therefore, changes in the respired CO2 may reflect alteration in the metabolism, circulation, respiration, airway, or breathing pattern. Now, there are certain applications, special applications of EtCO2, especially in pediatrics. The mainstream is much more accurate than side stream one. Children, they have a relatively high respiratory rate and a smaller tidal volume. So a low volume CO2 is produced in neonates and infants, which is like a sine wave type of capnogram, which may occur during spontaneous ventilation where there is no clear alveolar pattern. A distal PEtCO2 is used if the child is less than 12 kg and during use of partial rebreathing circuit. Now, this is of great importance, especially during laparoscopy, because it serves as a non-invasive monitor of PaCO2 when CO2 is insufflated and therefore can be used to adjust ventilation. It may help in the detection of accidental intravascular CO2 insufflation. A transient but a rapid rise in EtCO2 is an early sign of venous CO2 embolism. However, if the embolism is large enough to cause pulmonary outflow obstruction, resulting in decreased cardiac output, the PEtCO2 decreases, thereby increasing the alveolar dead space as well as the EtPCO2 difference. It may also help in the detection of complications of CO2 insufflation, such as pneumothorax and hemorrhage. Now, in thoracic anesthesia or one-lung anesthesia, the capnograms with an increased phase 3 slope due to large spread of VQ ratio, as in the lung disease. The initial part of the slope is represented by the areas which are ventilated with a high VQ ratio, while the latter part is represented by the areas which are poorly ventilated with a low VQ ratio. Biphasic capnogram, that is the phase 3 of the capnogram. It represents, this is the biphasic phase 3 of the capnogram. It represents the mixed alveolar gas at the CO2 sampling site. Therefore, if the lungs have distinctly different VQ ratio and the exhalation time constant, then biphasic waveform can be seen as in the lateral decubitus position. This can also be seen following a single lung transplant. Reverse phase 3 capnogram may occasionally be seen. The slope of phase 3 can be reversed in patients with emphysema, where there is a marked destruction of the alveolar capillary membrane and a reduced gas exchange. Now, what happens during sedation? Pulse oximeter is a monitor of oxygenation. Supplemental oxygen can mask apnea or hypoventilation. So evidence shows that procedural sedation is associated with undetected apnea or hypoventilation. Certain physicians sometimes use propofol during endoscopic procedure, and this can cause apnea and hypoventilation. So it is mandatory to use an EtCO2 when you are giving sedation, especially in remote locations. Now, capnography has a great role to play in ICU, especially for the confirmation of the endotracheal tube, monitoring the patients during position change. As we know that a lot of ICU patients, they need a lot of position, and kinking or obstruction of the tube can occur during change of position. So it would monitor that the tube is properly placed. Then assessment of the cardiac output. The percentage decrease in the end tidal CO2 is directly correlated with the percentage decrease in cardiac output. Also, the percentage decrease in CO2 elimination is correlated with the percentage decrease in cardiac output. Increase in cardiac output and pulmonary blood flow results in better perfusion of the alveoli and results in the rise of the EtCO2. Capnography can be used as a prognostic indicator during CPR. It can detect the presence of pulmonary blood flow even in the absence of major pulses, and can also rapidly indicate changes in pulmonary blood flow by alteration in cardiac rhythm. Thus, capnography in CPR provides a feedback to optimize chest compression during CPR. Monitoring EtCO2 during CPR may detect unrecognized fatigue induced inadequate chest compression that can result in less than desirable cardiac output. During trauma and resuscitation, it is a marker of the pathophysiological state encountered since it reflects the cardiac output. It may also predict a major outcome from major trauma. Capnography is an important non-invasive monitor for ventilation. It can be used to optimize ventilation to get a desired level of PaCO2. If the patient has COPD or an unstable cardiac output, the EtCO2 may not be a perfect guide to ventilation. Then it can be used for detection of the inadvertently placed gastric tubes in the trachea. During percutaneous dilatation tracheostomy, it can be used to confirm the intratracheal cannula placement prior to the tracheostomy. It is very important in the diagnosis of acidosis because metabolic acidosis is compensated by hyperventilation, leading to a decrease in PaCO2 and thus causing a decrease in the EtCO2. Now, capnography and CPR. Now, we know that if there is no trace, it is in the endotracheal tube is in the wrong place. So, AHA recommends use of capnography not only for the confirmation of tracheal tube, but also to monitor the effectiveness of chest compression during CPR. To optimize the chest compression for an effective CPR, you should have a value between 10 to 20 millimeter of mercury. And if the value is less than 10 millimeter of mercury, it is associated with a poor outcome. Now, there was an audit which was done by the Difficult Airway Society, and they came to the following conclusion that major complications of the airway management occur in 3 places: operation theater, emergency room, and the ICU. The risk of encountering major airway complication in ICU is about 66 times more than operation theater because continuous capnography is not used. Capnography should be used in all patients for intubation, irrespective of the location. Routine use of continuous capnography in all patients, whether intubated or with tracheostomy. If you do not use it, you have to state the reason why you're not using it. You should train all the staff for identification of abnormal waveform, and it should be a checklist for intubation and tracheostomy preparation. Now, just in short about the advances of this thing, Now, capnography is based on the principle that CO2 molecules absorb infrared radiation at specific wavelength. The capnograph contains special photodetectors tuned to these wavelengths that enable the calculation of CO2 levels in a breath sample. Now, the microstream employs unique laser-based technology called as molecular spectroscopy as the infrared emission source. The advantage is it is very efficient even at low flow because of the short light path. Sample cell is reduced, so it can be used in neonates. The advances in mainstream, the sensor has become lightweight and has a variety of adapters to monitor adult, pediatric, and neonate patients. The ultra-compact micro-rotor technology measures the CO2, nitrous oxide, and fine anesthetic agent, and it can be mainstream or side stream. So to conclude, I would say that capnography can monitor the airway, breathing, and circulation. Capnography and measurement of PET CO2 will be augmented in the future by relatively new measurement methodology, including the study of oxygen kinetics at a future direction. So to end, I would say that patient monitoring and the equipment to support it are vital to caring for patients in the operating room, intensive care unit, emergency department, and in acute care settings. Thank you.
Thank you, madam, for detailed and vivid lecture on capnography and pulse oximetry. And there is no doubt about the importance of pulse oximetry and monitoring and in day-to-day life of the anesthesiologist and intensivist. Thank you very much for giving such a detailed lecture.
Thank you, sir. Thank you.
In chat box, so I think we can end the session.
Thank you, sir. We do not have any question. Thank you, ma'am. Thank you, Dr. G. for sparing your valuable time for our conference. Thank you, ma'am.
Thank you.
So because of the paucity of the time, we are skipping the tea break for now, but we'll be flashing the MCQ questions by clicking on the link on your screens. The link will be activated. There are 2 MCQ questions. The answer to the MCQs will have to answer in the chat box. And the ones who are answering first will be awarded accordingly at the end of the conference. After 2 minutes, we'll be beginning with our next session. Thank you, everyone. So we are beginning with our next session now. Shalu, can we have the slides?
Yeah. Alok, can we have the slide?
Yeah. Thank you. So our next session is a live case presentation, a long case presentation on a patient of COPD posted for laparoscopic cholecystectomy. To moderate the session with us, Dr. Medha Mahota ma'am, Ma'am is a director professor at UCMS and GTB Hospital, Delhi. Ma'am's areas of interest are obstetric anesthesia and trauma management. We welcome you, ma'am. Also moderating along with ma'am is Dr. Amit Kumar.
Thank you.
Dr. Amit is assistant professor in anesthesia at All India Institute of Medical Sciences, New Delhi. And his area of interest are difficult airway, simulation, patient safety, and oncoanesthesia. We welcome you, Dr. Amit.
Thank you, ma'am.
And to present the case, we have our third year postgraduate student, Dr. Avinash. So this will be a live case discussion between the moderators and the postgraduate. The case, the whole case presentation will be summarized in the end by Dr. Medha. Over to you, Dr. Medha, ma'am.
Thank you, Dr. Anupama. Thank you very much. I think we will, without wasting any time, we will just start with the case discussion. Dr. Avinash, are you ready? Dr. Avinash? Can you start?
Sir, please unmute
Please
yourself.
unmute yourself.
Morning, ma'am.
Hello, good morning. Can we start with the case that you have taken?
Yes, ma'am. Here is a 60 years old male patient named Ramesh from Narayana, New Delhi. He's an auto driver by occupation. He came with the chief complaints of pain in right upper abdomen since 2 months.
You can share your screen, Dr. Avinash.
Ma'am, you're able to see, ma'am?
Yes, please go ahead.
Here's a 60 years old male patient named Ramesh from Narayana, New Delhi. He's an auto driver by occupation. He came with the chief complaints of pain in right upper abdomen since 2 months. History of presenting illness. Patient was apparently all right 2 months back, and he developed pain in right upper abdomen, which was sudden in onset, intermittent, moderate to severe in intensity, dull aching, non-radiating, affected his daily activity, and aggravated post fatty meals, and relieved on taking medication, and used to wean off after several hours. No history of nausea, vomiting, epigastric pain, abdominal distension, bloating, fever. No history of yellowish discoloration of eyes, skin or urine, skin itching, white stools. He underwent an ultrasound at local hospital, which was suggestive of gallstone disease, and was referred to RML for further management. The patient also complains of intermittent.
Okay, so he is a known case, diagnosed case of gallstone.
Patient also complains of intermittent cough expression since last 6 years, which was associated with mucoid, white, non-foul smelling, non-blood tinged around a tablespoon in quantity expectorant. Cough with expectorant was more in the morning. There is no seasonal or postural variation in cough. No history of weight loss, loss of appetite, evening rise of fever. He consulted local physician for the symptoms and was decreased with cough syrup and inhaler. He gives history of 2 episodes of increased cough, expectoration, fever, and breathlessness 2 years back and 6 months back, and was admitted to a local hospital for a week.
Okay, Dr. Avinash, so just go back to your previous slide. Yes, you said cough is, you asked him about the cough. Cough is more in the morning. So what is the, what does it indicate?
Ma'am, usually chronic bronchitis, the patients have a cough more in the morning, ma'am. So asthmatic patients can also have, but these patients will be having more in the morning, ma'am. Cough with expectoration, chronic bronchitis patients.
Okay, and what is the importance of knowing about seasonal variation and postural variations?
Seasonal variation with cough is more common in asthmatic patients, ma'am. And postural variation with cough is more common in chronic bronchiectasis and lung abscess.
Okay, okay, go ahead.
He was on oxygen therapy via face mask and intravenous medication in both the admissions. There was no history of ICU admission or any ventilator support. He was discharged from hospital after a week and was advised inhaler with medication. Initially, he was on single inhaler, that is a meter dose inhaler of salmeterol after first hospital stay. And now presently, he is on 2 inhalers, that is meter dose inhaler of salmeterol and tiotropium therapy.
So did your patient tell you the names of these inhalers?
Ma'am, he got the inhalers along with him, ma'am. Because of that, I got to know that he was taking 2.
All right. Okay.
Patient has also developed breathlessness from the past 3 years. He becomes breathlessness and walks slower than the people of same age on level ground. Breathlessness is more during bouts of cough and relieved on taking rest. He also complains of on and off whistling sounds during bouts of breathlessness. There is no history of nocturnal awakening with breath. He's a chronic smoker. He's a chronic cigarette smoker since 40 years, smoking around 1 pack per day, that is 20 cigarettes per day.
Okay. You have said he walks slowly than people of same age. What does this mean?
Ma'am, this according to MMR's modified medical research classification, he belongs to grade 2, ma'am. Grade 2 classification, ma'am.
Okay. And why did you ask about this history of nocturnal awakening, breathlessness on lying down? Why is it this?
Ma'am, to rule out any cardiac involvement, ma'am. Cardiac patients can have PND, orthopnea, common in cardiac patients. So to rule out these symptoms, I took this history.
Okay, and what is pack years?
Ma'am, number of pack of cigarettes smoking into number of years of smoking multiplied by number of years of smoking per day.
How many pack years has he smoked?
Ma'am, 40 pack years, ma'am. He's smoking about 1 pack per day. That is into 40 years. That is 40 pack years.
So does it have any significance?
Ma'am, it helps in assessing the postoperative pulmonary complication, ma'am. More than 40 pack years signifies that patient can have postoperative pulmonary complication.
Okay. And one more thing, did you ask about history of blood in sputum? History suggestive of hemoptysis?
No, ma'am, there was no history as such, ma'am. Hello? Hello? Hello?
Did you ask about that?
Ma'am, there was no history of any blood.
Go ahead. Is my voice clear?
Some issue is there, ma'am. Like I'm not able to hear properly, ma'am.
Okay, my voice is not clear.
Now it was clear. No, again gone.
Can you hear me now?
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Yes, ma'am.
Okay. All right, go ahead.
Past history. There is no history suggestive of diabetes, hypertension, tuberculosis, asthma, or coronary artery disease. There is no past history of any known allergy or any blood transfusion. No history of any surgery or previous anesthesia exposure. History. He is on meter dose inhaler salmeterol 2 puffs BD since last 2 years and meter dose inhaler tiotropium 2 puffs OD and which was added 6 months back and not on any oral drugs presently. Patient is compliant to treatment and is on regular follow-up. Family history. There is no significant family history of any respiratory or other any systemic diseases. Personal history. He is a chronic smoker. He has no other addictions. He is vegetarian by diet. Sleep is normal and undisturbed. Bowel and bladder normal and regular. He belongs to lower middle class family according to modified Kupuswamy scale. Coming to general physical examination. Patient is examined in sitting position. He is conscious, oriented to time, place, and person. He is sitting comfortably. No nasal flare or use of accessory muscles of respiration. Weight was 60 kg, height 170 centimeters, BMI is 20.7 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, pedal edema, and lymphadenopathy. JVP is not raised. Vital parameters, patient is afebrile on tick. Pulse rate is 80 beats per minute, measured in right radial artery, good volume, normal character, normal condition of vessel wall, and all peripheral pulses are palpable. Blood pressure was measured in right arm, just that 130 by 80 mmHg, measured in sitting position. Respiratory rate is 16 breaths per minute, regular, abdominothoracic type. Airway examination. Airway examination was done in sitting position. There is no visible craniofacial deformity. Both nares look normal. Mouth opening was more than 5 centimeters.
You can just tell us, Dr. Avinash, you can just tell us whether there is any abnormality with the airway examination or not, because we are short of time.
No, ma'am.
Okay, go ahead then.
Distances,
Are
all the
this within normal?
ma'am, all the distances were under normal limit.
Okay, go ahead.
Abdominal examination, ma'am. On inspection.
Any positive points here?
No, ma'am.
Any positive?
No, ma'am. No, ma'am.
Go ahead.
Respiratory system examination. On inspection, chest is barrel in shape. Trachea appears to be in center. No suprasternal or intercostal recession. Bilateral chest wall movements appear symmetrical during respiration. No use of accessory muscles seen. No audible wheeze or stridor. No dilated veins, pulsation or scars over chest wall or back. On palpation, all findings of the inspections were confirmed. Chest expansion is bilaterally symmetrical. No tenderness or bony deformity. Chest expansion on full inspiration is 4 centimeters. Tactile vocal frequencies bilateral equal and decreased. On percussion, resonant sound all over lung fields present. On auscultation, vocal resonance decreased all over lung fields. Vesicular breath sounds present over bilateral lung fields. Slight decrease in bilateral air entry all over lung fields. No rhonchi and crepitation. Side pulmonary function test. Cough test was negative. Wheeze test was negative. Sabre's breath holding test was 17 seconds. Forced expiratory time test was 6 seconds. Single breath count test was 22.
So can you tell us how do you do forced expiratory time test?
We ask the patient to inhale maximally, ma'am. After that, I'll keep a stent over the trachea and I'll ask the patient to expirate maximally. During the start of expiration, I'll start the stopwatch, and at the end of the expiration, I'll start the stopwatch and stop this stopwatch. The time duration I'll measure, ma'am. If it is less than 3 seconds, it indicates of restrictive lung disease. 3 to 6 seconds is normal. If more than 6 seconds, it indicates obstructive lung pathology.
And do you know about Snyder's match flow test?
Yes, ma'am. Snyder's match flow test. We ask we keep a lighted lamp at about 6 inches from the patient at the level of mouth. We ask the patient to blow the candle without pursing the lips. If the patient is able to blow the candle, then it indicates FEV1 of more than 1.6 liters and maximum breathing capacity of more than 100 liters per minute. If the same test can be repeated at 3 inches and 9 inches, if the patient is able to blow at 3 inches, then it indicates maximum breathing capacity of 50 liters per minute. If he's able to breathe, if he is able to blow the candle at 9 inches, that indicates maximum breathing capacity of 150 liters per minute.
Correct. Okay, go ahead.
Cardiovascular system examination. On inspection,
any positive points or any significant findings?
No, ma'am.
Go ahead. Go to the next one. Everything is
CNS exam. Yes, ma'am.
Any positive points here?
No, ma'am. No, ma'am.
Okay, then go ahead. All right.
Yes,
so you have taken your history and examination, done the examination thoroughly. Okay.
Yes,
so now on the basis of this history and examination, what is your provisional diagnosis?
And my provisional diagnosis is a 60 years old male, chronic smoker with gallstone disease, with very chronic obstructive pulmonary disease without exacerbation, controlled on medication.
So how did you arrive at this diagnosis?
Regarding the COPD on history, patient gives a history of about smoking 40 pack years and history of dyspnea and breathlessness since last 6 years and 6 years. There are 2 exacerbation around 6 months back and 1 year back, and he's on inhaler therapy. And on examination, there is bilateral decreased air entry with bilateral decreased air entry, and on inspection there is a barrel chest art. So my diagnosis will be most probably chronic COPD, chronic obstructive pulmonary disease. While for gallstones, he was having right upper abdominal pain and was done ultrasound in the RML hospital and was diagnosed as gallstone. So this patient is having a gallstone disease with query COPD.
Okay. So what is COPD? You are saying query COPD. What is COPD?
And according to Gold's classification, it's a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway or alveoli involvement due to chronic exposure of noxious particles, noxious gases or particles.
Mm-hmm. So it can be of 2 types, huh?
So it can be of 2 types. It can be of either chronic bronchitis or emphysema, ma'am.
So can you differentiate between these 2 conditions?
Ma'am, in chronic bronchitis, the mechanism of airway obstruction is decreased luminal size because of inflammation and increased secretion. While in emphysema, it's because of the loss of elastic recoil. Dyspnea is moderate in chronic bronchitis, while in emphysema it's severe. PaO2 level is less in chronic bronchitis compared to emphysema. Because of this, they are called as blue bloaters. The diffusing DLCO is decreased in emphysema while compared to chronic bronchitis. Cord pulmonary features are more common in chronic bronchitis compared to emphysema. Prognosis is poor in chronic bronchitis compared to emphysema.
Okay. So you have written query. You are saying query. This is query COPD. So how can you confirm your diagnosis?
Ma'am, we can confirm the diagnosis by doing spirometry, ma'am.
Okay. So can you tell us the classification of COPD on the basis of spirometric findings?
Ma'am, post bronchodilatory, if FEV1 by FVC is less than 0.7, then it is called as COPD. After this, assessment of airflow limitations are done according to Gold's classification. Gold 1, that is mild, which indicates FEV1 of more than 80%, more than or equal to 80%. Gold 2, that is moderate. Here, FEV1 is 50 to 79. Gold 3, that is severe. Here, FEV1 is 30 to 49. While Gold 4, that is very severe. Here, FEV1 is less than 30.
Okay. And you said your patient is on 2 types of inhalers. So otherwise, how are these patients treated?
Ma'am, usually...
can you summarize the treatment of COPD patients?
Yes, ma'am. Initially, we ask the patient to stop smoking, ma'am. These patients, after this, according to bronchodilators and anticholinergics, long-acting anticholinergics are added. According to Gold's, they are classified as A, B, and C, A, B, C, and D. In A, if MMRC classification of 0 to 1 with less than 0 to 1 moderate exacerbation, they are considered as group A, ma'am. In group B, if MMRC classification of more than 2 or equal to 2 with 0 to 1 exacerbation, they are in group C, more than 2 exacerbation with or more than 2 moderate exacerbation or more than 1 or equal to 1 hospitalization with MMRC of 0 to 1, they're considered as group C. In group D, MMRC of classification of 0 to 2 or more than 2 moderate exacerbation or more than 1 hospitalization, they're considered as group D. In group A, we add a bronchodilator, while in group B, we add a long-acting beta agonist or LAMA. While in group C, we add a LAMA. While in group D, we add LAMA with LABA along with inhaled corticosteroids.
What is LAMA? What is
the long-acting? The long-acting beta agonists are called as LABA, and long-acting anticholinergics are called as LABA.
Examiner may not be knowing about these short forms. You should say the complete thing.
And after this, patients will be on mucolytics, ma'am, and antibiotics for the chest infection. They can be on long-term oxygen therapy if PaO2 is less than 55 Hg, or hematocrit is more than 55, or history or patient suggestive of long-term cor pulmonale. Annual vaccination should be done with influenza and pneumococcal for these patients. Hello? 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 Hello?
Yes, sir. Yeah, yes, sir.
So ma'am's connection seems to be lost. So how do you prepare these patients?
So we go for a 5 prongs approach, sir. Initially, we ask the patient to stop smoking. For losing of secretion, for the dilation of airway, we continue on bronchodilators. For respiratory exercises, and we ask for respiratory exercises, we ask the patient for incentive spirometry and deep breathing exercises. We start on antibiotics if any chest infections are there, and we educate and motivate the patient for doing respiratory exercises.
So what investigations would you ask for in these patients?
Sir, I'd like to get a complete blood count, which include hemoglobin, TLC, and platelets. I'd like to get a liver function test.
For complete, what will you see in complete blood
Sir?
count?
Sir?
What will you see in complete blood
Sir,
counts?
in these patients, there can be raised hematocrit, sir, because of polycythemia. In TLC, there can be raised TLC because of any infection. Platelet, because these patients are undergoing a surgical surgery. Because of that, I would like to get a platelet count.
Next.
I would like to get a liver function test for this patient, sir. I would like to get a renal function test with serum electrolytes. I would like to get ECG, spirometry, chest X-ray for this patient, and an
Spirometry
ABG
for.
to confirm
Significance of each one of them.
So serum electrolytes I would like to get because these patients are on beta 2 agonist, sir. So because of that, there can be hypokalemia. So I'd like to get serum electrolytes. Regarding LFT, the albumin level of less than 3.5 milligram indicates increased post-operative pulmonary complication. There is a risk of post-operative pulmonary complication. Chest X-ray features of COPD can be seen on chest X-ray, like flattening of diaphragm, horizontal place slips, hyperinflated lung fields, or a bulle can be seen. And a spirometry to confirm diagnosis and for assessing the severity of COPD.
Can you show the slides?
For this patient, hemoglobin was 16.4 grams, platelet was 1.9 lakhs, TLC about 4,800, renal function, serum electrolytes and LFT were normal, and cerebroalbumin was 3.8. In chest X-ray, chest X-ray, there was hyperinflated lung fields with flattening of diaphragm, horizontally placed lips, and a tubular heart was present. And in spirometry, ECG was normal. In spirometry, there was a moderate obstructive lung disease pattern with FPC of predicted was 80%, FEV1 was 57 predicted, FEV1 by FPC was 55% predicted, and any ABG showed pH of 7.32, PCO2 of 48, PO2 of 85, and bicarb 24.
Okay. Sorry for the interruption. I'm back. Can you hear me now?
Yes, ma'am.
Yes, ma'am.
Okay. So you have shown a chest X-ray. What does it indicate?
In COPD patients, there will be hyperinflated lung fields. They can be flattening of the diaphragm, horizontally placed ribs. They can be tubular heart for this patient. So I would like to get a chest X-ray for this patient.
Okay. And how did you classify it as moderate obstructive lung disease pattern?
According to Gold's classification, ma'am, FEV1 by FVC is less than 0.7 and FEV1 is 57, which is coming under the range of 50 to 80. So it's coming under moderate obstructive lung disease pattern.
Okay. All right. Dr. Amit, go ahead, please. What were you discussing?
I was filling in. Yes.
Yeah. No. Go ahead, please go ahead. So he told you about the investigations, which will be required for this case. Yes, and he has shown us the
He told
investigation.
about preparation of the patient.
Okay. So he has prepared the patient. All right. So he's posted for, this patient is posted for, I think, laparoscopic cholecystectomy.
Yes, ma'am.
Okay. So he has told about the preparation part. All right. So now what will be the concerns?
They can be
anesthetic concerns.
They can be patient-related factors, disease-related factors, and surgical-related factors, ma'am. In patient-related factors, the patient is a chronic smoker. Age is about 60 years, and have associated comorbidities like hypertension, diabetes, heart diseases. While in surgical factors, this is a laparoscopic surgery, and because of the positioning, the positional changes can occur, ma'am, and the duration of the surgery matters. While in disease-related, these patients have, because of the COPD, these patients have poor exercise tolerance, hyperreactive airway, preoperative and preoperative infections, recent exacerbation of bronchial asthma, and these patients can go for post-operative pulmonary complications also.
Yes, they can also have bronchospasm intraoperatively. They can have
Yes,
hypoxia. Then if bullae are there, then they can have pneumothorax.
They can be
these will
pneumothorax.
also be the concerns.
Okay.
Perioperative concerns will include all these things also. Okay. So now how will you anesthetize this patient?
On the day of the surgery, I'll cross-check the consent and entry of the status. I'll prepare all the emergency drugs and anesthesia drugs. I'll check the anesthesia machine. I'll prepare the difficult APPEC card with adequate size mask and laryngoscope with a tube of 8 to 8.5. After this, I'll take the patient. I'll check the brain circuit, and the defibrillator will be kept inside the OT. I'll take the patient on the OT table. I'll attach all the standard ASM monitors, that is ECG, NIBP, and pulse ox. I'll take a wide bore. I'll take a wide bore cannula. After this, I'll start IV fluid, single lactate, 500 ml. After this, I'll be starting pre-oxygenation. Along with this, I'll be giving injection midazolam, 0.5 to 1 mg. After this, I'll be giving injection fentanyl, 120 micrograms slowly.
Just a minute. Can you say again? Yeah.
Ma'am, I'll be giving injection midazolam, 0.5 mg per 0.5 mg, ma'am. After this, I'll be giving injection fentanyl, 120 micrograms slowly. I'll be pre-oxygenating the patient for 3 to 5 minutes. After this, I'll be giving injection lignocaine, 60 mg. Hello. After this, I'll be giving injection lignocaine, 60 mg. After this, I'll be giving injection propofol in a titrated dose, about 2 mg per kg. After this, I'll check ventilate. And I'll be giving injection vecuronium, 6 mg. After this, I'll be.
What is the advantage of giving propofol here?
Ma'am, propofol has a bronchodilatory effect, along with decreases the airway reflexes, and it helps in preventing post-operative nausea vomiting. So I'll be giving propofol, ma'am. compared to like ketamine and thiopentone. Ma'am, fentanyl actually it helps in post-operative. It help fentanyl to avoid it. I'll be giving it for analgesia part, ma'am. Fentanyl along with
Ma'am, there is a disturbance. I think you have joined with two devices.
Yeah. I'll do something. Sorry.
So what are the different drugs you can use during induction? Means induction agents, and what are their advantages, disadvantages? Which one would you prefer?
Sir, I'll be sir, propofol, ketamine, and thiopentone are the inducing agents, sir. Propofol, because it has a better suppression of laryngeal reflex and helps in preventing post-operative nausea vomiting, and it has a bronchodilatory effect. While I'll be using propofol, but I'll be avoiding ketamine and thiopentone because ketamine increases the sympathetic tone, while thiopentone, the laryngeal reflex is not attenuated and may cause histamine release. Because of these things, I'll be avoiding ketamine and thiopentone.
So ketamine, is it absolute contraindication?
No, sir, as such, it's not the contraindication.
So in patients with cardiovascular involvement, you may avoid. Okay. So other relaxants, which relaxants would you be using?
I'll be using vecuronium, sir, 0.1 mg per kg. I'll be avoiding atracurium because it releases histamine. Histamine releases there. Because of that, I'll be avoiding atracurium.
Over to you, ma'am. You've joined it.
So sorry, there's so much disturbance occurring from my side. Okay, so okay, you have induced anesthesia for your patient. So now, how will you maintain anesthesia?
For maintenance, I'll be using inhalational agents. Sevoflurane I'll be using them with nitrous and oxygen of 50% and both 50% each.
Okay. Okay. So you had given these agents, and did you give something to obtund the laryngoscopic response? Did he talk about
lignocaine?
Is it important to give?
Yes, ma'am. 90 seconds before intubation, I'll be giving.
Why is it important?
Ma'am, these patients have hyperreactive airway, ma'am. Because of this, it can be laryngospasm or bronchospasm while intubating only.
So it is important to give. Yes, lignocaine. All right. Before 90 seconds before intubation. Okay, so you have done the endotracheal intubation and you have started your gases and you are maintaining anesthesia. Now what will you do before handing over to the surgeons?
Ma'am, I'll be placing a Riles tube and a temperature probe before giving the patients, and I'll be taking an extension line because both the arms will be tucked to the patient's body, so I'll be taking an extension line also. Okay,
so why is it important to put a Riles tube?
Because, ma'am, these patients, because of for the surgeon, it will be helpful, ma'am, because to deflate the stomach and for easy visualization of the upper abdomen, for them, it will be easy for them to visualize.
Yes, for visualization. Plus, it is very important to put a Riles stomach to avoid injuries. When they're putting in the trocar, at that time, the injuries can occur if the stomach is inflated, and even at the time of handling later on also, when they are doing the surgery. All right. Okay, so you will hand over to the surgeons, and now the surgery will start. Okay, see, first tell me what is auto-PEEP?
Ma'am,
because you are ventilating your patient, so you should know how to ventilate and what all problems can occur.
Ma'am, for ventilation strategies, I'll be keeping a tidal volume of 60 ml per kg, frequency about 10 to 12 breaths per minute, I ratio about 1:2.5 or 1:3, PEEP about 5 ml.
No, what is auto-PEEP?
Auto-PEEP for these patients have high risk of auto-PEEP because before the end of the previous expiration, the next inspiration starts. because of which there is a breath stacking inside the alveoli, which causes increased airway pressure, that is called as atopy. At the
So
end of expiration,
what harmful effects can occur due to atopy?
Ma'am, there can be barotrauma, VQ mismatch, hypoxia, or there can be hemodynamic instability also can occur because of atopy.
How hemodynamic instability? What will happen?
Ma'am, because of the enlarged alveoli, this compresses on the capillaries, pulmonary capillaries. Because of this, there is a back pressure on the pulmonary arteries, because of which there is a back pressure over the right ventricle. So the cardiac output, everything will decrease.
And venous return will also decrease.
Venous return also.
So venous return is decreasing. There is right heart strain due to pressure on the pulmonary artery, plus barotrauma, volutrauma. All these problems can occur because of this. So what can you do to reduce the chances of, or reduce the risk of all these problems?
Ma'am, I'll be keeping the expiratory time more, ma'am, for these patients. I ratio of about 1:2.5, 1:3 will prevent an atopy, ma'am. And I'll be keeping the tidal volume of lower tidal volume also.
No, basically you have to prolong the expiration, so that the next inspiration does not start before the previous expiration is complete. So you have to increase the duration of expiration. For that, you give slow rates, all right? And as you said, you change your ratio. What else can be done? What else?
Intraoperatively, other than this.
Then if there is bronchospasm, you will have to correct that. That will also help. Okay. And then if you apply external PEEP, that will also take care of it to a certain extent. By application of external PEEP, the airways will remain open in the end of expiration. So breath stacking will not occur. All right. Okay. So now you have handed over to the surgeons and they have started the surgery. What will they do? What will
they will insufflate the abdomen.
Yes.
So they will start insufflate.
So then you should know what are the various effects of pneumoperitoneum on the body. What are the pathophysiological effects? So can you just enumerate all of them?
Ma'am, on the cardiovascular system, there can be biphasic effect of cardiac output, ma'am. There can be, if the abdomen pressure is less than 15 mmHg, there can be increased cardiac output, increased stroke volume, ma'am, and increased peripheral vascular resistance. If the abdominal pressure is more than 15 mmHg, then it can cause decreased cardiac output. Because of the hypercapnia itself, there can be increased sympathetic stimulation and increased cardiac output. While in respiratory system, there can be decreased.
Listen, cardiac output is okay. What happens to the blood pressure? What happens to the heart rate?
Ma'am, heart rate can remain normal, ma'am, but blood pressure can, like biphasic response can occur if depending on the abdominal pressure. If it is less than 15 mmHg, there is increase in blood pressure. While if there is a more abdominal pressure, like more than 15 mmHg, it can decrease the cardiac output.
See, blood pressure usually increases. Okay, there is an increase because there is increase in systemic vascular resistance. So blood pressure usually increases, but yes, in lab chole, you will make the patient put him in anti-Trendelenburg position. So if venous return is reducing, patient is already hypovolemic, with head up position, then hypotension can also occur, but usually there is rise in blood pressure. And can arrhythmias also occur?
Yes, ma'am. Because of the CO2, the patients can have arrhythmias also.
There can be bradyarrhythmias, vagal stimulation due to peritoneal stretching when they are putting in the Veres needle at that time also. So there can be bradyarrhythmias, but sometimes tachyarrhythmias can also occur because of hypercapnia, hypoxia, all those problems. But bradyarrhythmias are very, very common when they have started insufflating. Okay. Now come to the respiratory effects.
In the respiratory system, because of the pneumoperitoneum, there is a decreased lung compliance and increased peak airway pressures. There is increased work of breathing. There can be endobronchial intubation also.
Okay, endobronchial. And what happens to the FRC?
FRC decreases, ma'am.
There can be atelectasis also, VQ mismatch.
VQ mismatch and shunting can also occur.
So all these things can occur. Then there can be endobronchial intubation also. Although it is more common in laparoscopies being performed in Trendelenburg position, but here also when they have insufflated gas, then tube position can change. And that is why it is very, very important to recheck your tube position after creation of pneumoperitoneum. Okay. All right. So these are the effects, and what all complications can occur due to pneumoperitoneum and during laparoscopic surgeries.
Pneumothorax can occur, pneumomediastinum, subcutaneous emphysema, pulmonary embolism. Because of the trocar insertion, there can be any injuries also can occur.
Injuries can occur due to vessels or due to even abdominal organs. So all those things can occur. All right. Okay, so you will take care of all these things. And now suddenly, during surgery, you see that airway pressures have gone up and you can hear wheezing in the circuit. What will you do?
First,
you don't have to show anything else, no? So you can stop sharing your screen. Yes.
I'll be giving 100% oxygen. I'll auscultate the patient, ma'am. There are decreased bedtimes. With raised the pressure set. Patient might be having bronchospasm. During that time,
you will
giving 100% oxygen.
So first, you should be able to diagnose bronchospasm under anesthesia. Okay. So you have auscultated. So what did you find? Well, what is expected?
Ma'am, bilateral decrease with added sounds can be present.
You can hear rhonchi. The air entry may be reduced. In very severe spasm, there may not be any air entry. What else? Then what will happen to tidal volume?
Tidal volume will increase.
And can you notice something on the capnogram?
There will be steep rise of angle, like alpha angle goes on increasing.
Shark fin appearance. You had a lecture.
Shark fin appearance.
So like this, you can diagnose bronchospasm under anesthesia. Now, what are the various common causes of intraoperative bronchospasm?
Ma'am, light plane of anesthesia, because of
yes,
any surgical stimuli can also cause a bronchospasm.
Yes, under light plane of anesthesia. Yes. So that is very important to keep these patients in adequate depth of anesthesia.
Any drug allergies or anaphylaxis can also lead to bronchospasm.
Yes, allergy, anaphylaxis, then exacerbation of asthma or COPD.
Or any aspiration can also cause
airway swelling. Okay. And what are the other causes of wheezing? You heard that wheeze coming. So can there be some other causes also besides bronchospasm?
Other causes, endobronchial intubation can cause.
Can there be something
or
wrong with
obstruction? Tube obstruction can also cause the.
Yes, there can be kinking of the tube, obstruction due to misplacement of the tube. All right, endobronchial just here. What else? Then there can be some problem with the circuit.
Circuit kinking or HME filter blocking can also cause raised peak. There can be pneumothorax also.
Yes. Yes, pneumothorax or
pneumothorax can also cause peak airway pressures.
And pulmonary edema, aspiration. So all these problems can present like this. Okay, now suppose the patient has developed bronchospasm now. So how will you manage? You said you
Ma'am,
will. Go ahead.
Ma'am, I'll be giving 100% oxygen, ma'am. After this, I'll hand ventilate and I'll confirm by auscultate bilaterally, and I'll increase the depth of anesthesia and ask the surgeons to stop. After this, I'll be giving beta 2 bronchodilators, beta 2 agonist bronchodilators, salbutamol, 6 to 8 puffs, metered dose inhaler, ma'am. This will be my first line of management. If it didn't subside, then I'll be going to second line, which include ipratropium bromide, 0.5 mg nebulization, ma'am. After this, I'll be adding magnesium, 5 mg per kg, and I'll be giving over 20 minutes. Otherwise, I can give hydrocort 200 mg. If it didn't subside, then I'll go for ketamine 10 to 20 mg bolus. After this, an infusion of 1 to 3 mg. If it didn't subside, then nebulization with adrenaline, 1:1,000.
So all these options are there. Yes, you will not give everything simultaneously, but all these options are there. And depending on the response, you can give any one of them. Now from here, one more question. I just, it came to my mind. When you were talking about the treatment of COPD, you said bronchodilators can be given, beta 2 agonist and anticholinergics. So in COPD, which bronchodilator is more effective? Beta 2 agonist or anticholinergic?
Ma'am, for symptoms, for exacerbation, we add on anticholinergics, ma'am. For symptoms, we add bronchodilator, like beta 2 agonist.
They both can be used, but
both can be used.
For COPD patients, anticholinergics are more effective, whereas beta 2 agonists are more effective for bronchial asthma. And what is the reason? That also you should know. Why anticholinergics? They have better efficacy in COPD. Do you know the answer?
Ma'am, it acts on the M3 receptors.
It acts by blocking the vagus nerve mediated bronchoconstriction, which is a major component of bronchospasm in COPD. That is why they are very effective in COPD patients. All right. Okay. So you have, you have managed your bronchospasm well, and now surgery is over. All right. They have removed the gallbladder. So what will you do now?
Ma'am,
Hello, I think I can't hear.
Yeah, same here, ma'am. Can't hear. I think his connection is poor. No.
Yeah, this is a major problem in online activities.
Ma'am, smoking is still remaining.
Acha, that actually I was not here at that time. So, yeah, we will discuss it. That is very, very important. Let him come back.
I think, ma'am, he got disconnected. We'll just wait for a minute, ma'am. We'll make him join again.
Yeah, sure. And Dr. Amit, you must have discussed why he wants all those investigations, huh? The logic.
Yes, ma'am. Yes, ma'am.
Okay.
That has been covered.
Yes, thank you. Yes, thank you. We can yes.
Ma'am, I'll be giving port site infiltration about 0.25% of BPO, ma'am. I'll ask the surgeon to remove all the CO2 along with there should not be any blood or secretions left in the stomach because it can cause a post-operative shoulder pain for these patients. And I'll be.
What did you say in the stomach? What is that?
Any blood secretions or blood or any secretions left over, I'll be ask the surgeon to clean it up, ma'am. While
the peritoneum, you mean to say, huh?
Yes,
okay, not in the stomach, in the peritoneum. Okay, all right. They have done that. So will you give something else also? You have given infiltration in the port site. Then antiemetic?
Ma'am, injection MSET I'll be giving, ma'am, 0.1 mg per kg for this patient.
Because PONV is a major concern in laparoscopic surgeries. Okay. Okay. So, right, you have given all these things. Now, how will you extubate? What precautions will you take?
During extubation, I'll be extubating in the deep plane of anesthesia, ma'am. And I'll be giving injection glycopyrrolate initially before giving injection neostigmine, ma'am. Because the neostigmine can cause bronchospasm while extubating itself. So
otherwise, also we always add an anticholinergic to the neostigmine. So that is a routine practice, right? Okay. Now, one or two more. One thing Dr. Amit just told me that we have not discussed the effects of smoking. So that is something very, very important that we should not leave that. Just quickly, can you cover that aspect for the benefit of everyone? What are the effects of smoking on the body, and for how long smoking should be stopped?
Effect of smoking can, because the phases, in gaseous phases, the nitrous, carbon dioxide, carbon monoxide are the main factors, while in particular phase, the nicotine is the main factor, ma'am. On CVS, because of the nicotinic action, there is increased sympathetic stimulation, and aortic and carotid baroreceptors are set higher level. Because of this, there is increased BP, heart rate, and increased consumption of myocardial O2, ma'am. While in carbon monoxide can also cause arrhythmias. There is left shift of oxygen dissociation curve because of carboxyhemoglobin. On respiratory system, because of the irritant aspect, this causes increased secretion. Ciliary motility gets decreased. And there is because of the decreased surfactant, also, it causes a decreased surfactant level also. While in GI system, it can cause decreased gastroesophageal sphincter tone. Because of this, it can cause aspiration also.
Aspiration. What are the common effects? Secretions will increase, mucociliary function will reduce, immune function will be affected. So all these are basically the important ones. Effect of catecholamines. Okay, for how long you should ask the patient to stop smoking?
As long as the patient is able to stop, we need to ask the patient to stop. Ideally, 12 to 24 hours, because of the carboxyhemoglobin level decreases. So it's better if he stops for at least 12 to 24 hours.
But ideally, for how long it should be stopped?
6 to 8 to 12 weeks, ma'am. Because the mortality and morbidity.
Post-op pulmonary complications, the risk of post-op pulmonary complications decreases after stopping smoking for 6 to 8 weeks. But okay, actually, you can say at 1 week this will happen, at 4 to 6 weeks this effect will come. Okay, you can classify accordingly. But yes, whatever time is left before surgery, if it is a purely elective surgery, you can ask him to stop it for 6 weeks or 8 weeks. But whatever time is available before surgery, during that time, it should be stopped. You should always ask your patient to stop smoking. And what about post-op pain relief? Can you quickly just tell us how will you provide post-op pain relief to this patient?
I'll be giving multimodal analgesia with injection paracetamol 15 mg per kg. I can give port site infiltration with injection bupivacaine 0.25%, ma'am. Otherwise, I can go for tap block or electrospinal block. Or intraperitoneal local anesthetic can also be given.
But if you are planning to give intraperitoneal infiltration, then
calculating the dose.
Yes, you should be very careful about the toxicity part because you need large doses for that. Okay. Now, one or two very important questions. See, you intubated trachea of this patient. Now, can you do this surgery with LMA, supraglottic devices? Can it be done?
Ma'am, it can be done, ma'am, but I will prefer ET2 because LMA has decreased airway irritation while inserting also, ma'am. But these LMAs, what we are using is second generation LMAs, ma'am, which has a ceiling pressure about 30 to 35. as these COPD patients have decreased lung compliance, and these might require higher pressures for achieving a tidal volume. So they can be air leak and gastric insufflation can occur. So I'll be preferring ET tube compared to an LMA.
Okay, so you should be able to talk about the advantages and disadvantages of both techniques. So with endotracheal tube, definitely it is preferred by most of the people, and because it provides optimal control of ventilation. And intraoperatively, during ventilation, I think we did not talk about the adjusting ventilation after pneumoperitoneum. Did we talk about it? I don't think so. So you need to increase minute ventilation. When they have insufflated carbon dioxide, you increase minute ventilation by 10 to 25% to wash out that extra carbon dioxide. For that, you generally increase the rate, respiratory rate. Okay. So here we can achieve optimal control of ventilation when an endotracheal tube is there. All right, you can increase ventilation and peak. You can give high peak airway pressures, like patient can tolerate high peak airway pressures. All right, so that is the problem with the LMAs. Another thing, endotracheal tube, it prevents aspiration. There is no risk of aspiration. Whereas with LMAs, okay, now second generation are available and they are supposed to be quite safe. Many people are using LMAs for laparoscopic surgeries, which is not wrong. It can be used. But yes, when you compare the two techniques, ET tube is definitely safer. But yes, LMAs can also be used. These are not contraindicated, especially the second generation ProSeal LMA. This has been used in many studies. And many people are routinely using it because there is esophageal vent through which you insert the catheter and risk of aspiration is minimized. And they also allow use of slightly higher airway pressure as compared to other original LMAs, like previous generation LMAs. All right, so it can be used. But yes, if you are given a choice between the two, that is perfectly fine that you prefer to use an endotracheal tube. Now, can you do this surgery under regional anesthesia? Because many people say that, like, it is always considered safer, regionally considered safer for COPD patients, because you need not put in a tube, there's no risk of bronchoconstriction. So can you do this surgery under regional anesthesia?
Ma'am, there are certain advantages and disadvantages by using regional anesthesia, ma'am. The main disadvantages are like we need a higher block, ma'am. The expiratory and inspiratory capacities are decreased because of the higher block, and the patient won't be able to cough out because of the abdominal muscle dysfunction, and there can be atelectasis also. So I'll be preferring general anesthesia over the regional anesthesia.
Yes, definitely regional anesthesia is not a good choice in this situation, because one thing, what is the level of block that is required for regional anesthesia for laparoscopy? It is around T4. And we say that in COPD patients, we should not give a block level higher than T6 because of impairment with all these expiratory functions. Peak expiratory flow, expiratory reserve volume, all these are decreased if a block level is more than T6, so which results in inadequate cough. So one thing, the level of block is very high. Then the patient will have discomfort, shoulder tip pain when pneumoperitoneum has been created. So for that, the patients need very high doses of sedatives. So again, very high doses of sedatives and analgesics are bad for these patients. They are very sensitive. Okay, COPD patients are sensitive to ventilatory depressant effect of sedatives, plus elderly patients are even more sensitive. All right, so we do not want to give so much sedation to them, and we do not want to make them so uncomfortable also. Plus their impairment of expiratory functions. So it is not a good choice. It is always better to give GA to these patients than regional. So I think there are many more questions, but only 19 or 20 minutes are left. So I think Dr. Amit, you should summarize the entire thing, and then we can answer questions if there are questions in the chat box.
Yes, ma'am. I've already given the pre-recorded.
Okay.
Good morning, everyone. I thank Dr. Emry Kaur ma'am for the opportunity, and let's summarize the case. Starting with the definition of COPD given by Global Initiative for Obstructive Lung Disease, COPD is a common preventable and treatable disease which is characterized by persistent, not fully reversible respiratory symptoms and airflow limitations caused due to airway or alveolar abnormalities, which in turn are caused by significant exposure to noxious particles or gases. So COPD includes chronic bronchitis, which is cough for 3 or more months for 2 consecutive years, where other causes of chronic cough are excluded, whereas emphysema is a pathological term characterized by permanent enlargement of air spaces distal to terminal bronchioles. There's a term asthma COPD overlap syndrome, which is seen in chronic asthma, which is characterized by chronic cough with airflow reversibility with the bronchodilators. Let's differentiate chronic bronchitis and emphysema. The mechanism of airway obstruction in chronic bronchitis is decreased lumen due to mucus and inflammation, while it is loss of elastic recoil in emphysema. Dyspnea is severe in emphysema. FEV1 is decreased in both. PaO2 is decreased more in chronic bronchitis, while PCO2 is increased in chronic bronchitis. Diffusing capacity is decreased predominantly in emphysema. Hematocrit is increased in chronic bronchitis. Cor pulmonale is more seen with chronic bronchitis. Prognosis is poor with chronic bronchitis. Coming to the symptomatology, COPD is characterized by dyspnea, cough, and sputum production. So the dyspnea can be assessed using MMRC questionnaire, classifying into grade 0 to 4. Risk factors of COPD are cigarette smoking, occupational exposure to dust, chemicals, gold or coal mine exposure, textile industries, indoor and outdoor pollution, low birth weight, alpha-1 antitrypsin deficiency. The diagnosis of COPD is made in a patient with symptoms of dyspnea, cough, and sputum with risk factors by spirometry, which is required to establish the diagnosis. There is a refined ABCD assessment tool given by Gold, wherein spirometrically confirmed cases, that is post bronchodilator FEV1 by FVC less than 0.7, are assessed for airflow limitations by FEV1 percentage predicted and classified into Gold 1, 2, 3, and 4, that is mild, moderate, severe, and very severe, and further assessed for symptoms and risk of exacerbations, and grouped into group A, B, C, and D. Say a patient is Gold grade 4, group B, that means the patient is having FEV1 percentage predicted of less than 30%, whereas his MMRC scale is more than 2, and in last 1 year he has had 0 or 1 exacerbation, not leading to hospital admission. So coming to a few facts about smoking, WHO has described tobacco as the only legal drug that kills many of its users when used exactly as intended by the manufacturer. One cigarette emits 2 milligrams of nicotine, which is absorbed radially by alveolar membrane, which enters the cerebral circulation in 20 seconds. With increasing doses, stimulant effect of nicotine is diminished and has sedative and depressant effect. Half-life of 30 minutes, and cotinine, which is an active metabolite, remains in the bloodstream for up to 20 hours. The main component gaseous phase is carbon monoxide, which shifts oxyhemoglobin curve to left due to decrease in 2,3-DPG, and in particulate phase it is nicotine, which is similar to acetylcholine and plays a role in cerebral neurotransmission. The beneficial effects of smoking cessation with time course are: in 12 to 24 hours, there is decreased carbon monoxide and nicotine levels. In 48 to 76 hours, carboxyhemoglobin levels normalize and ciliary functions improve. In 1 to 2 weeks, there is decreased sputum production. In 4 to 6 weeks, PFTs improve. In 6 to 8 weeks, immune function and metabolism normalizes. In 8 to 12 weeks, decreased overall post-operative morbidity and mortality is seen. COPD is treated with smoking cessation inhaled long-acting bronchodilators, long-acting anticholinergics, and inhaled corticosteroids, mucolytics, and antibiotics against chest infection whenever indicated. Long-term oxygen therapy is required in patients with PaO2 of less than 55 mmHg, hematocrit of more than 55%, and evidence of long-term cor pulmonale. Annual vaccination with pneumococcus and influenza is indicated. Diuretics are indicated in patients with cor pulmonale or right heart failure, and in severe cases, lung volume reduction surgeries and lung transplantation may be required. So treatment according to Gold 2020 booklet. So according to the groups A, B, C, and D, in group A, a bronchodilator is required, which may be short or long acting, and increasing drugs are required through B, C, and D, wherein group D requires LAMA or LAMA plus LABA or LAMA LABA plus ICS. So anesthetic considerations in patients with COPD undergoing lap cholecystectomy. Patients related factors are chronic smoking, age of more than 60 years, comorbidities like hypertension, diabetes, heart disease, obesity, sleep apnea, etc. So COPD related factors which has to be considered, which can result in increased post-operative pulmonary complications are poor exercise tolerance, unexpected dyspnea with decreased breath sounds, recent exacerbations of bronchial inflammation, preoperative infection, hyperreactive airway, cor pulmonale. Surgical factors which must be considered are laparoscopic surgery, pneumoperitoneum and its systemic effects, possible complications like bronchospasm, endobronchial intubation, pneumothorax, pneumomediastinum, subcutaneous emphysema, pulmonary embolism, positioning related considerations. Surgical expertise and duration of surgery becomes important in severe COPD. So the investigations required are complete blood count, wherein HB might be increased in chronic bronchitis, TLC might be increased in infections, RFT and LFT are required. Then ECG, right atrial enlargement, right axis deviation, RVH may be seen. On ABG, hypoxemia and CO2 retention may be seen. Spirometry is required to confirm the diagnosis and assess severity. Chest X-ray, flattening of diaphragm can be seen with hyperinflated lung fields and sometimes with bulle. In severe cases, 2D echo may be required, and it may show pulmonary hypertension, right ventricular and atrial enlargement. So the preoperative preparation will be 5-pronged approach: smoking cessation, loosening of secretions with the hydration, mucolytics, dilatation of airways, respiratory exercises and measures for motivation and education of patients, and antibiotics to treat infections. Coming to the anesthesia management, in pre-medications, these patients have increased sensitivity to respiratory depressants like opioids and benzodiazepines. Short-acting anxiolytics may be given in very anxious patients. So the choice of anesthesia would be regional anesthesia whenever possible, while in cases like laparoscopic surgeries, upper abdominal surgery, general anesthesia is preferred, which allows controlled ventilation, oxygenation, and CO2 elimination. IPPV overcomes the decreased lung compliance, decreased FRC, and increased resistance. Excellent muscle relaxation can be achieved. Comfort to the patient in case of prolonged surgery, while there are risks of laryngospasm, bronchospasm, cardiovascular instability, barotrauma, and hypoxemia. Monitoring ECG, NIBP, high ABP in case of severe COPD cases, and pulse oximetry, capnography, temperature monitoring must be instituted. Coming to the induction of general anesthesia, in pre-oxygenation, the timing may be increased. There is a role of CPAP and propped up position in these patients for proper pre-oxygenation. In opioids, fentanyl and remifentanil are preferred over morphine, which may release histamine and has prolonged ventilatory depressant effects. In induction agents, Propofol has better suppression of laryngeal reflex. It is a bronchodilator and decreases PONV, and so is a preferred agent of choice. While ketamine is a bronchodilator, but there is increased sympathetic tone, thiopentone may not attenuate laryngeal reflexes and may cause histamine release. So the intubation response has to be attenuated. It may be with IV lidocaine or other agents, and gentle laryngoscopy has to be done within 15 seconds. Adequate plane of anesthesia has to be maintained with additional boluses of propofol before laryngoscopy. In muscle relaxants, we have to avoid atracurium, which may release histamine, and other agents may be safely used. In inhalational agents, sevoflurane and halothane both are bronchodilators and non-pungent, but halothane sensitizes myocardium to catecholamines. Isoflurane and desflurane both are airway irritants. Nitrous oxide can be used, but caution must be executed in cases with bulle and pulmonary hypertension. Inhalational agents attenuate HPV and increase shunting. This must be considered. So the aim of ventilation in these patients would be to minimize dynamic hyperinflation and IP, maximize alveolar gas emptying. We have to set tidal volume of 6 to 8 ml per kg, especially if bullas are present. We have to decrease. We can decrease it further towards 6 ml per kg. Slow inspiratory flow rate has to be kept. Prolonged expiratory time with a slow respiratory rate of 6 to 10 per minute, and preserve humidification with the use of HME filters or low fresh gas flow. So this is a flow time curve showing expiratory limb not touching the baseline and showing air trapping or auto PEEP. Coming to laparoscopic surgery considerations, pneumoperitoneum causes cardiovascular and respiratory effects in cardiovascular system, biphasic effect on cardiac output, increased SPR, increased PVR, increased blood pressure. There is minimal effect on heart rate, and cardiac arrhythmias may be caused in respiratory system. PCO2 will increase. There is decreased FRC, auto PEEP might be there, and there is increased shunting and antibronchial intubation might be caused. The positioning for lap cholecystectomy is reverse Trendelenburg with right side tilt up, and it decreases the venous return, decreases CVP, decreases cardiac output, decreases MAP. So the intraoperative complications which we should anticipate are bronchospasm, endoscopic port placement complications, endobronchial intubation, pneumothorax, pneumomediastinum, subcutaneous emphysema, pulmonary embolism, etc. So coming to bronchospasm, it is a reversible bronchial smooth muscle constriction in response to noxious stimulus. The causes are airway irritation in lighter planes of anesthesia, anaphylaxis, misplacement of endotracheal tube, gastric content aspiration, exacerbation of asthma or COPD. So on suspecting bronchospasm, we have to switch on 100% oxygen, hand ventilate, stop the surgery, consider allergy and anaphylaxis, call for help. Then immediate management would be deepen anesthesia, check tube position, it might be blocked or misplaced, eliminate breathing circuit with manual resuscitator, exclude laryngospasm in non-intubated patients, and drug therapy, which is discussed on next slide. So secondary therapies to address underlying causes are optimize mechanical ventilation, treat anaphylaxis, consider pulmonary edema, pneumothorax, pulmonary embolus, foreign body, consider abandoning surgery, request a chest x-ray and transfer the patient to CCM with therapy. The drug therapy are first line drug therapy, salbutamol meter dose inhaler, 6 to 8 puffs repeated as necessary, can be nebulized or given intravenous also. And second line drug are ipratropium bromide, magnesium sulfate, hydrocortisone, ketamine, epinephrine in severe cases, nebulized or intravenous. So reversal of neuromuscular blockade, we must consider neostigmine may provoke bronchospasm, and glycopyrrolate must be given before neostigmine. Deep extubation may reduce bronchospasm, but care must be taken in difficult airways. In emergence, it may be prolonged, especially in severe COPD. In postoperative care, vigilant monitoring must be instituted, and ICU care is must in high-risk cases. Avoid respiratory failure, bronchodilator, nebulization, mucolytics, and antibiotics must be continued. Chest physiotherapy, incentive spirometry, and deep breathing exercises should be continued. Early ambulation must be attempted with the use of multimodal analgesia, such as the use of epidural, different blocks, NSAIDs, and paracetamol. Thank you.
Thank you, Dr. Amit, for nicely summarizing the session. Ma'am, do we take the question? There is one question which is there. Can we use nitrous oxide for lap surgery as it was mentioned in the discussion? Dr. S.U. Suresh Kumaran wants to know.
Okay, see, nitrous oxide can be used, but yes, if there are bullae on X-ray chest, then it should be avoided because there is a risk of rupture of those bullas and then pneumothorax. Otherwise, it is okay. And another thing, if the patient has pulmonary artery hypertension, then again it should be avoided. In all other conditions, it can be used. Or sometimes the patient may be so hypoxic that you need to give higher concentrations of oxygen, higher strengths of oxygen. So these are 2 or 3 conditions where it should be avoided. Otherwise, it can be safely used.
Thank you, ma'am. I think that answers the question quite well. I thank you, ma'am, for nicely moderating the session. I thank Dr. Amit for summarizing it in a very well manner. And we thank our postgraduate student, Dr. Avinash, to keep his calm and to have answered the questions in a very calm manner. And it's an art in the exam. There are lots of stresses, but to tide over that and answer well in the exam is an art. I hope our postgraduate students who are listening would benefit from this particular session. Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you. Thank you for the opportunity.
So now moving on, before our next session, we would like to announce the answers for the previous quiz. The answer to the first question, DLCO value may decrease in all except. The answer is the bronchial asthma. The same question, uniform waves occur all due to except. The answer is fall in the saturation. We have 2 winners, Dr. Ajita Priya and Dr. Praveen V. Reddy. I congratulate both the winners. You will be rewarded accordingly at the end of our conference. Now moving on to our next session. Dr. Sunil Katyal is busy with something in his some urgent work. So we have our head of the department, ma'am, Dr. M.D. Kaur, ma'am, who will be chairing our next session. The next session is an equipment session. There are 2 lectures on it. All types of endotracheal tubes and fiber optic bronchoscope. I request Dr. M.D. Kaur, ma'am, to kindly speakers and begin this session. Over to Dr. M.D. Kaur, ma'am. Ma'am is the head of the department in our hospital, ABVIMS and Dr. Arnell Hospital.
Thank you, Dr. Anupma. And the next speaker is Dr. Ruchi Gupta. She is a professor and head department of anesthesia and pain medicine at Shri Guru Ramdas Institute of Medical Sciences and Research, Amritsar. And her areas of interest are low backache, musculoskeletal pains. She seems to be specializing in pain management. And towards her achievement, she has organized 8 regional and 2 national anesthesia conferences. She has 70 publications in various national and international journals and more than 100 presentations authored and co-authored, 28 sessions and delivered 21 guest lectures at various national and zonal conferences. So I invite Dr. Ruchi Gupta to start her talk. Dr. Ruchi Gupta.
Good afternoon, my dear resident fellows and friends. Today I'll be talking about the endotracheal tubes, basically the questions which are asked in the exam. And, this is a usual question which we asked in the exam. And the history component of it is not asked as a first thing in the exam. This is usually a last question, or if you want to give more marks to the candidate, then they should know a little bit of history. And so, the ending should be very good by the resident. And the use of the endotracheal tube has been reported as early as 1542 by Vesalius, and he, intermittently blowed into the reed that were passed into the aspera arteria of an animal whose thorax was opened. What is aspera arteria? Aspera is it's a tube in front of the esophagus, and arteria was a trachea, the name for the trachea. And Pug, another surgeon, constructed an air pipe, which he used a coiled wire and wrapped a soft leather over it, and is used. Another important thing which occurred was in 1667 by Robert Hooke at the Royal Society in London. He used his dog. He kept his dog alive for an hour by ventilating his lungs and pair of bellows and tied into the trachea. And after he finished the surgery, after he finished the demonstration, the dog got up and he just, shoved off his water, and everybody clapped for this man. And after that, there were a lot of tubes. You can see different people designed different tubes for better purpose. The two questions which are asked very important: when were the cuff tubes invented, and when were the uncuffed tubes were designed? So the Sir Magill and Robotham, they were the British Army unit surgeons during war 1920. They passed uncuffed red rubber tubes through nose blindly for their plastic surgery and reconstruction of head and neck injuries. And here they use inhalation anesthesia instead of insufflation anesthesia. And in 1928, endotracheal cuffed tube was introduced by Water and Goodall. However, this question is very rarely asked, but you should know that 1910, Christine, a Berlin physician, had advocated direct laryngoscopic intubation with Christian otoscope. But in 1920, Chevalier Jackson introduced the laryngoscope. So what is an endotracheal tube? It's a device that is inserted through larynx into the trachea to convey gases and vapors between the breathing system and the lungs. It is a gold standard piece of equipment for securing airways. It protects lungs from aspiration of foreign bodies, and glottic reflexes are bypassed with this piece of equipment. This is something which is asked: what are the constituents of endotracheal tube? You should know. If you can't even remember much, but little bit you should know that are initially designed red rubber tubes. They had natural rubber or synthetic rubber. The natural rubber was polymer of isoprene, and it had an accelerator. Accelerated speeded the reaction, allowed reaction to take place at a lower temperature. Then there was a vulcanizing agent. It provided strength, elasticity, durability, and resistance to change in temperature. There was a plasticizer, which provided flexibility and smoothness. There was a stabilizer, which provided heat stability and prevented degradation. There were antioxidants, which protected polymer during drying and deterioration by oxygen. There were fillers, which provided hardness and rigidity and resistance to heat and chemicals. There were ultraviolet and coloring agents used, and the same thing were used in synthetic rubber also, which was unsaturated hydrocarbon monomers, which were combined to form polymers. The most commonly these days used tubes are polyvinyl chloride. They are by the polymerization process of monomer units of vinyl chloride. They also have stabilizer, plasticizer, coloring agent in place of vulcanizing agents. They have colorants and lubricant as well as the fillers. So they ask, do you know of any other material which can be used for the tubes? So you should know, yes, silicone, nylon, Teflon, polyethylene, and in laser, so some metallic component. Silicone tubes, which are the most commonly after PVC, they are and red rubber, they are most commonly used out of these four. And high density polydimethyl silicon with pure silica provides the strength and vulcanizing agents. Along with vulcanizing, they are medical grade, autoclavable, do not stick to the tissue. Reactions, secretions clog less. They are not wetted by fluid, but then they are not widely used because they are expensive and they're softer. The Teflon tubes, they are polytetrafluoroethylene, pure polymer without additives. And they are slippery, non-wettable, non-adhesive. But the tubes irritate tissues by rubbing, and they're expensive. Nylon are tough, resilient, unaffected by, but these tubes are rigid and rough surface, causing high tissue toxicity. Polyethylene polymer, they are medical grade, do not cause adverse reaction, and they're resistant to chemicals, sterilization by ETO. They're rigid and tend to kink. This is another very important question which is asked on the tube. They show you the tube and they say, what is this written Z79IT? So this is tissue testing of the tubes. And this IT means tissue implantation testing. The tube is cut into small strips and implanted into the paravertebral muscles of rabbit. Mind it, this is not mouse, but the rabbit, along with 2 negative control. Animals sacrificed and tissue examined under microscope for inflammation. Z79 is American National Standard Institute. That was a committee which was formed. And according to that standards, this is labeled. And its counterpart in Europe is called CE. So some tubes you will find that the CE written, which is Conformite European, and this is a European standard by MHRA. But see, Britishers are not as stringent as Americans. So this in this tissue testing, and so C cannot be taken as guarantee for clinical effectiveness of the device. But other cell culture testing, they sometimes ask you very less. IT Z79 is mainly asked, but you should know there are chemical reactions which are direct or indirect. The direct one is cell culture testing or sterility test, pyrogen test, long-term implantation test. They check the inflammation, latent toxicity, and carcinogenicity activity. Whereas indirect solvent testing, the polymer is dissolved into the solvent, and this solvent is injected in the mouse intradermal or intraperitoneal for acute toxicity testing, or even used for cell culture system. Now, once a tube is given to you, so how do you describe that tube? It is described from, you have to hold the tube and say, this is a patient end, this is a machine end. And from patient end, you should start that it has a tip, bevel edge, then there is a Murphy's eye. This is a Murphy's eye here. There's a cuff, which is high volume, low pressure cuff. There are depth marker black marks. Then there are precision calibrations. There is a inflating lumen, and then there is a inflating tube with a pilot balloon and spring-loaded valve. And then there is a 15 millimeter connector, and there is a radiopaque line. This radiopaque line is opposite to the bevel edge, and it is a little deficient at the Murphy's eye. And this whole thing can be detected in the X-rays, radiographs. So another question is asked, you just talked about the bevel, what is angle of bevel? And so angle of bevel is the angle between this here, bevel as well as the straight, longer part of the tube. And this angle in oral is 45 degrees with radius of curvature of the tube. This is called radius of curvature, and this is 14 centimeter. And in nasal tubes, this radius of curvature is 20 centimeter, and angle of bevel is 30 degrees. So these tubes are, right-sided. They come as right-sided and left-sided because this, this angle of bevel helps in, that right-sided is put through the right and left-sided is put through the left, and so the, they pass along the nasal septum. But more commonly used tubes are oronasal tubes. And they have a 30 degree angle of bevel and radius of curvature 14 point minus 2 centimeters. So why is there a bevel edge? So because if usually it is left-sided and you can see the tube entering the vocal cords. So that is the advantage of bevel facing leftwards. And then there's a Murphy's eye. What is a Murphy eye? It's a cut made on the opposite to the bevel edge. So once bevel edge gets stuck up with the tracheal wall, sometimes because of the cuff pressures and whatever reason, the ventilation can go continue through the Murphy's eye. That was an idea behind it, but it has its own negative points that, fibroscope, your forceps, your bougies, they can get stuck up and cause a lot of problem. And then they ask you, do you know any other tube tips? Yes, there are a straight tip and there is a curved tip. And in curved tip also, there is a Parker flex tubes, which have a different, slightly different shape. And they all help, in preventing, if you see that vocal cords, the tip can get obstructed at the vocal cord. So this curved tip helps in preventing that problem. So they sometimes give you both the tubes, the cuffed and the uncuffed. They say, what is the difference in the tube? So the cuffed tubes, have a cuff which prevents the risk of aspiration, better monitoring, and the high ventilating pressures can be used, and they decrease OT pollution. Overinflation, injuries to cord, and children, whenever cuff is required, their tubes are smaller, difficult suctioning, increased resistance can be there. But in uncuffed tubes, cause less trauma to structures, especially nasal intubation. Size is large enough should be large enough to provide effective ventilation, not oversized to cause pressure on the mucosa. Uncuffed tubes allow a leak between the tube and the tracheal wall, but disadvantages, chances of aspiration are more with the uncuffed tubes. So when you're talking about the cuff, the next question can be, what are the ASTM standards, which are, so ASTM standards say that the tip from tip to patient end of the cuff, this distance should be fixed. They specify the distance, and they say this cuff should not be too near or covering the Murphy's eye. And we had seen these endotracheal tubes, which were high pressure cuffs or otherwise also, they used to, with repeated use, initially we were not disposing them off when they came, and we were reusing them after sterilization. These cuffs used to become very loose and they used to cover the tip and causing obstruction. And this is sometimes, the solution used to be suddenly we wanted to change the tube and we deflated and patients started getting ventilated. So we knew this is a cuff problem. And then this high pressure cuffs, what are the two types of cuffs? Low volume high pressure cuff or high volume low pressure cuff. And they put less pressure on the tracheal mucosa or tracheal wall. You can see here. The other type of cuffs, which you can say they can be transparent or opaque. Usually high volume pressure cuffs are transparent, and low volume cuffs, high pressure cuffs, are opaque. The pediatric cuffs and adult cuffs, the difference is the pediatric cuffs are softer, shorter, and they are very pliable. And the single cuff or double cuff, single cuff is normally all the tubes have. Double cuffs are used for VAP prevention strategies, where the cuffs are inflated alternatively, or they can be they are present in the laser tubes. And foam cuffs, they are Bivona foam cuff tubes, are used for laser surgeries. And gill cuffs, which are not used anymore, they were initially used when on inhalation, they used to expand like fish gills. And when during exhalation they used to collapse. So as a result, the aspiration used to occur. There were chances of aspiration, so that tube went into disrepute. So now next question comes in, what is inflation system? So inflation lumen, so ASTM standard says that this inflation tube should not, which is embedded in the tracheal tube itself, should not encroach the tube lumen, or neither it should bulge outside. So the inflation tube which is outside, that was a lumen, this is tube which is outside. The outer diameter should not be more than 2.5 millimeter and attached to the tube at a very small angle. So that is something which is standard. And the pilot balloon should have a name indicated, the number of the tube, size of the tube indicated here. Then there is a one question which comes that if by chance the patient is struggling and this pilot inflation tube gets caught up in that bandage, and patient is struggling, and you try to remove it and it got pinched up here, what do you do? So there are 2-3 options. One is just give a nick here, and in nick and blade. And sometimes, there's not much time to get a blade and give a nick. Patient is struggling. So you do the laryngoscopy, look at the cuff, and this can be punctured with any needle or spinal needle. So there, that cuff is brought to the vocal cord so that there's no vocal cord injury. And that's how. Another mechanism which has been described is, making a sleeve here. Just lift the sleeve, make a V-shaped sleeve, cut and lift it. So another thing which has been described, just cut it in a V shape and move the slack. Then next comes the inflation valve. It is a spring loaded, and where, once you remove that, this spring just closes the backflow by when the syringe is removed. Whereas the red rubber, it used to be either clamp. When, many a times we used to have that problem. This stopper, which was plugged here, caused problems. It used to be loose, or it used to come out, and tube used to deflate, and we used to have a problem. So clamps were put, and sometimes these clamps crushed the tubes, and deflation sometimes became difficult. So they could be plugged with other materials which were used. And pilot balloons. Another ports which were available are suction ports, which is usually lies the opposite side of the inflating tube, and it lies above the cuff. So this is for the VAP prevention strategies. And stimulation we'll be discussing later. So what is the cuff pressure? Recommended cuff pressure is 20 to 25 centimeter water. And what is the reason? Everybody knows that nitrous oxide diffuses into the cuff, but other reasons could be pressure from nearby surgical procedures, altitude, oxygen diffusion into the cuff, change in head position, cuffing, straining, muscle tone changes, and decrease was hypothermic bypass. And what is the way to reduce this? There was one way, intermittent inflation and deflation, which was quite risky, allowing minimal leak and minimal occlusive volumes. This also, does not, this is a good strategy, which we still use it, but it's not that good. Using cuff pressure monitor. It is expensive. You can see here, it is expensive, but it is not proven perfect. Fill the cuff with oxygen and nitrous. It is quite messy. And then filling saline or methylene blue for laser surgeries. Balloon system. This is a lens blue system. The second photograph. So that was a lens pressure regulating system. The next one is a cuff to reduce nitrous oxide, is a thin wall pilot balloon. This picture, my cursor is not coming. So the third picture, you can see that's a thin pallet. So the cuff and they balance, because a thin wall, it gets, excessive pressure gets converted to that side towards the pilot balloon. So the pressures, they stabilize. Or the bivona foam cuff, which doesn't, the diffusion and other things don't affect this kind of a tube. And then a question is asked that, what are the problems encountered with the cuff? You can see in the upper picture, as I already mentioned, the cuff this was, we saw it in PVC tubes, but it used to be more common, also common with the red rubber tubes. Then there could be external herniation. There could be internal obstruction by internal herniation of the cuff, which has been reported. So next thing was another marking, that is length marking, internal and outer diameter marking. Sterility, do not reuse and use once. Tissue testing, that is, we have discussed in details, and trademarks, oral versus nasal. Then radio opaque marker we have discussed, and the black marks is where, it's a depth markers. And this could be single mark, as you can see, and this helps in, this should be just visible outside the vocal cords. If there are two, one should be seen going inside and one should be, and so the cuff should be, larynx should be somewhere in between the two. And the uncuffed tubes, you can see this whole thing as a black, and this black thing, this one, it should be just visible here. So what is a tube length? How much? This is another question which is asked. How much, where do you, at the angle of the mouth, how much is should be the length? Because too long, can cause endobronchial, too short can cause accidental extubation. So one way is to check the black mark. And in children, they say newborn should be fixed at 9 centimeter, 3 months, 10, 1 year, 11, 2 years, 12. And no, children more than 2 years, age divided by 2 plus 12. In adults, it is usually 22 to 24, average is 23, women 18 to 22 at the angle of the mouth. But if you're using a nasal tube, add 5 into it. And if you want more accurate, then this formula is there. Tube size. So tube size is very, very important for the children. 3 months or younger, internal diameter 3 millimeter, 3 to 9, 3.5, more than 9, age in years, plus 16 by 4. If children were below 6 years, age in year by 3 plus 3.75, some write 3.5. Above 6 years, age in years by 4 plus 4.5. If age, height, and weight is known, you can accurately calculate it. But when it is not known, age is not known, then the tip of the little finger, distal little finger, is taken as an external diameter of the tube. So for adults, it is, for adults, internal diameter 7 to 8, and for females, and 8 to 9 for males. Smaller diameter is easier to insert, but increased resistance. Larger are low resistance. They lower the resistance, lower the risk of occlusion, but difficult to insert, and higher incidence of sore throat because they press on the tracheal mucosa. Although we know that this problem, it comes in the adults because correlation is poor between age, race, height, body surface area, tracheal shape, and size. Because a heavy, long, tall person can also have a short neck, or even a short height person can have a longer neck. So there can be differences in that. And also because different manufacturers have different tube circumferences for the same ID. Specialized tube, it could be reinforced preformed microlaryngeal. So whenever there is, you should know that these are the various tubes. Microlaryngeal tubes through LMA, jet ventilating laser. So these are the various names of the tubes, like flexometallic, RA tube for microlaryngeal tubes, ivory Potex tubes, laryngectomy tubes, and so on. And you, before picking up these tubes, you should know what is to be answered. If you have picked up a flexometallic tube, in addition to whatever we have talked, you should say that it has a metal, or nylon spiral wire reinforcement. It is covered internally and externally by either rubber, PVC, or silicone. If it is a rubber, then it will be very soggy and it doesn't have any shape. But PVC tube usually and silicone tube usually maintain their shape to some extent. The spirals do not extend on the tip and the connector side, proximal and distal line. And so the connectors are bonded to the tube. In the situation where they were not bonded, they used to be kinking. And the advantage is, even if they are, coiled and things, they don't get compressed. That is why used for head and neck surgery, tracheal surgery. They're useful in submental and retromolar intubations. And portion outside can be moved away from the surgical site without bending it. So what are the problems of the flexometallic stellate? Sometimes because they rotate, especially inside the latex tube. So it becomes very difficult to intubate them. Unintentional extubation due to recoil tendency, nasal intubation impossible. Tube cannot be shortened, and once bitten, it increases the resistance and they don't get back to the normal shape, and that increases the risk. So RA tube, the first thing they will, if you pick up a RA tube, they will ask what is a RA tube means. It's a ring Edward Elvin. That name you should know. These were the 3 scientists who designed this tube, and it is a South Pole tube or the North Pole tube. And there is a mark here, and these marks should come for South Pole near the teeth, and in the North Pole it should come near the nostril and the tip of the nose. And this point, there is a this tube enters proximal to distal to this point, so that even if you have to cut, and there's a scissor mark also marked over here, and in case of emergency, when you want to do a suction and you are not able to straighten the tube, so this is cut here, and connector can be connected and suction can be done, and you can save the situation. and they're useful for oral surgery and prone positions. And what are the problems? And because there's a difficulty in passing suction catheter and tube offers more resistance, but there can also be a problem of more tube going inside intraorally, going endobronchial or coming out, and causing in a short patient, so they can be accidental extubation. Microlaryngeal tube, if you pick up, they are usually from 4 to 6 size. The cuff diameter is 8 millimeter internal tube diameter size cuff is there. It helps in keeping the tube in the center. They use for laryngeal surgeries and the larynx where it is very narrowed because of the tumors, because of the papillomas and vocal polyps or whatever. And it gives a good length for intubation, but it cannot it can be used for through supraglottic devices also. But disadvantage is there is an incomplete exhalation and occlusion, and cannot be used for selective endobronchial intubation because the cuff size is quite big, and cannot be used for laser surgeries too. So next comes the laser resistant tubes. You should pick up the tubes only if you are doing the surgery. But if you are doing the surgery, then there are very different types of tubes which are used: laser shield tube, laser flex tracheal tube, Sheridan laser tube, Norton tube, Bivona foam tubes, and laser tubers. Naturally, your institute will have those tubes with you, so you are using those. But one thing is very important, that all laser tubes cannot be used for all kinds of lasers. And so you should be very specific in telling each tube, like the tube which you have kept it there, that it is used for what type of lasers. And moreover, once you have picked up this tube, this laser are resistant, but they do catch fire if more energy is used. So you should know how to handle the fires and what steps to be taken, airway problems, everything that you are doing should be known to you. So these are the various tubes. You should know which type of tube which is used it's compatible to which kind of lasers. EMG reinforced tracheal tubes. This is designed to monitor recurrent laryngeal electromyogram during surgery. Wire reinforced tubes, and it has a full stainless steel wires near the cuff to monitor the pressures. And we use these tubes quite often. And laryngectomy tubes are also used. We have a very good ENT department which makes us use all these tubes. But this is a photograph from the net. It is a J-shaped tube with the cuff very near to the, and here it is showing a bevel edge, but the tubes which we have, if they don't have a bevel and the cuff is very near, and because they are introduced through the tracheostomy stoma, and they are stitched or fixed on the chest. And this helps in we conduct the whole surgery through it. So what are the problems used for tracheal tube? Disconnections, leaks, kinking, external kinking, internal kinking, obstructions, foreign bodies, distal obstruction. Foreign bodies are also very common in red rubber tubes. If you are given a red rubber tube, then they will ask you what are the disadvantages. Not only the cuff you have to talk about because it is opaque, so the foreign bodies you cannot know. So they can be foreign body dislodgement into the trachea or airway obstruction. And accidental extubation and endobronchial. Problem with the use of tracheal tube, red causes repeated use, causes kinking, external compression, foreign body entrapments, as I just mentioned. Then distal obstructions can be there because of the cuff. And PVC, whilst they get softened with warming, and there is a kinking possibility. Reinforced tube, inadvertent endobronchial, accidental extubation, kinking, and same is true for the preformed tubes. Thank you so much. So, good evening, everybody. I would like to, can you hear me? Hello, can you hear me?
Yes, ma'am.
Yeah,
Yes,
I would like to add up one correction in this presentation, that for nasal tube, right-sided will have a left-facing bevel, because when you are introducing, the bevel should face the septum, and the left-sided should have a right-sided facing bevel. And another thing which I wanted to say was the minimal leak is done in the children. For adults, it's no leak technique which we use. And third thing, one question which because of the time paucity I could not add up in the presentation was, what do you do if there is an obstruction? That is, sometimes examiners ask that kind of a question, that whenever there is an obstruction, you should disconnect the tube from the circuit and ambu the circuit, ambu the tube. So if the obstruction is, towards the, if we are not able to ventilate, then the problem is from tube to patient end. But if you are able to ventilate, that means the obstruction was near the machine end, towards the machine end. Stuck valves and other problems could be there. But now if you are, you can't ventilate, and now you have to determine whether it's a tube obstruction or patient obstruction. So what do? You put a suction catheter through it. If you are able to put a suction catheter, if you're not able to put a suction catheter, anyway, the obstruction is in the tube. But if you are able to put the suction catheter through it, there is a secretions, blood or whatever, you are able to suck, and then you can ventilate again. That means the tube problem was there. But if after doing everything, you are still not able to do the ventilation, that means the problem is in the chest. It could be, asthmatic attack, bronchospasm, and various other problems, some aspiration or some foreign body or other problem. So this is one small question is asked when we talk about the obstruction. So any questions, you can just put it in the chat box. I'll be happy to.
We don't have any questions, ma'am. Thank you, ma'am.
Okay, thank you. If you have, please do tell me. I'm there. So
yes, ma'am. If we receive the questions, we'll forward the questions to you. So to introduce our next speaker, I invite Dr. ma'am to introduce the next speaker.
Right. Our next speaker is Dr. Shweta Mamre. She is an associate professor at Lokmanya Tilak Municipal Medical College and General Hospital, Sain, Mumbai. And her areas of interest are obstetric anesthesia and trauma anesthesia. Welcome, Dr. Shweta Mamre. You can, she will be speaking on fiber optic bronchoscope, something very important for every PG to understand, because it is more, you can have it as a theory question and you can be asked in Viva as well. Thank you so much. Dr. Shweta Mamre.
Good afternoon, everyone. I'm Dr. Shweta Mamre. I'm Assistant Professor at Lokmanya Tilak Municipal Medical College and General Hospital at Sain, Mumbai. Our hospital is very famously called as the Sain Hospital. So today I'm going to conduct an equipment session on fiber optic bronchoscope. So where is fiber optic bronchoscope used in our hospital? 1, it is used in the operation theater. 2, it is used in the ICU for bronchoalveolar lavage, bronchial biopsy, and clearance of tenacious secretions in patients on long-term ventilation in the ICU. We will majorly be covering where fiber optic bronchoscope is used in the operation theater. So indications for fiber optic intubation. Either there is a definitive history or an anticipated difficult intubation, or for confirmation of position of airway devices like the W-lumen tube or the endotracheal tube depth. In cervical spine injury or vertebrobasilar insufficiency patients, when these patients are posted for elective surgery and one wants to avoid neck extension, which is otherwise necessary during direct laryngoscopy. Failed intubation. Can we use fiber optic bronchoscope in cases of failed intubation? Yes, we can. The plan B of a failed intubation, according to Difficult Airway Society guidelines, is to insert a second generation supraglottic airway device. Provided the ventilation and oxygenation are taken care of, one can insert a fiber optic bronchoscope through the supraglottic airway device and then attempt railroading and a smaller size of endotracheal tube through it. Fiber optic intubation modes. There's always a confusion whether it should be an awake intubation or asleep intubation. If it should be done through the nasal route or the oral route. We will cover each of these separately. Coming to asleep mode of fiber optic intubation. What are the indications? It is done in pediatric patients or uncooperative patients where cooperation is hindered either because of a language barrier or because of a developmental barrier. And as I had mentioned, in cases of failed conventional intubation, wherein a supraglottic airway device is inserted and one can pass a fiber optic bronchoscope through it. What are the hazards in pediatric patients and uncooperative patients who are put to sleep or anesthetized before the fiber optic intubation? 1. Airway muscle tone is lost. 2. Respiratory function is depressed. Can we tide over this problem? Yes, by using endoscopy mask where spontaneous ventilation is augmented with pressure support ventilation of 10 centimeters of water. Coming to fiber optic intubation through supraglottic airway device. Here also, the upper airway is stented with the supraglottic airway and hence one can easily pass a fiber optic bronchoscope through it. Now coming to awake fiber optic intubation. Remember that adequate time is necessary in such cases for anesthetizing the airway. We cannot do an awake intubation in an emergency. So when would you opt for an awake fiber optic intubation? In suspected difficult direct or videolaryngoscopy and intubation with or without suspected difficult ventilation with face mask or supraglottic airway. What does this mean? Laryngoscopy is difficult, intubation is difficult, and ventilation is also difficult through a face mask or a supraglottic airway. When can we encounter all these three problems together? In patients with oral tumors. Again, a difficult laryngoscopy and intubation with or without significant risk of aspiration. Which are these patients? Either pregnant patients or patients with morbid obesity, or increased risk of desaturation, as in patients who have suffered from a road traffic accident with thoracic trauma and have now come to the elective OT for mandibular fixation. Their FRC is going to be less and hence they are at an increased risk of desaturation. Again, even our morbidly obese patients are at an increased risk of desaturation, and in them too, laryngoscopy and intubation can be difficult. So all these are our candidates for awake fiber optic intubation. What are the 4 P's of awake fiber optic intubation? The first P is psychological preparation. Second is preventing aspiration. Third is pre-oxygenation. And fourth is pharmacological preparation, which has 2 parts. One is sedation, the other is airway anesthesia. Coming to the first P and the main cornerstone of a successful awake fiber optic intubation. Remember, my dear students, a patient who comes to the hospital to undergo a surgery is filled with complex emotions, the most common of which are anxiety and fear of the unknown. Pre-anesthesia checkup is the first time that anesthesiologist meets the patient. This is the time that one should seize an opportunity to build a rapport with the patient. Convince him why awake fiber optic intubation is in the best interest for a safe anesthesia. Once the patient perceives us as empathetic and understanding doctors, half the battle is won. Hence, psychological preparation forms the main crux of successful awake fiber optic intubation. Next is preventing aspiration by using our drugs like pantoprazole and metoclopramide. Pharmacological preparation also involves using anti-sialogogues. Why is that so? Drugs like glycopyrrolate, they will ensure good visibility and better quality of topical anesthesia. How is that? Our saliva, respiratory secretions dilute the topical anesthetics which are deposited into the patient's airway. Hence, for better quality of topical anesthesia, a dry airway is preferable. If one is contemplating doing a nasal fiber optic intubation, one should use vasoconstrictor nasal drops like oxymetazoline. Pharmacological preparation, step 1 is sedation. In order to achieve a better cooperation of the patient, to allay his anxiety, sedation is essential. Dexmedetomidine by far is now the wonder drug, which causes conscious sedation with minimal respiratory depression, and it also has an anti-syllagogue effect. Fentanyl and midazolam are suitable alternatives. Propofol has also been used in incremental doses, but one should always remember it can cause loss of airway muscle tone and respiratory depression. Now coming to the main pharmacological preparation, which is the airway anesthesia. As we can see, the nose and nasopharynx is anesthetized by the trigeminal nerve. The mouth and the oral cavity and the oropharynx are anesthetized by the glossopharyngeal nerve. And the airway above and below the vocal cords is anesthetized by the two different branches of vagus nerve. The nose can be anesthetized by topicalization or simply nebulizing the patient with 4% lignocaine. The oropharynx can be anesthetized by an invasive glossopharyngeal nerve block or a simple non-invasive technique where the patient is asked to gargle with 10 ml of 2% viscous lignocaine. Above the vocal cords, we need to perform a superior laryngeal nerve block. For below the vocal cords, we need to block the recurrent laryngeal nerve. One can also anesthetize this part by SAGO technique. What do you mean by SAGO? Spray as you go, wherein an epidural catheter is passed through the working channel of the fiber optic bronchoscope. A 2 ml syringe is attached to this epidural catheter and it is filled with local anesthetic like 2% lignocaine. As the anesthesiologist advances the fiber optic bronchoscope, he simultaneously sprays the local anesthetic both above and below the vocal cords. Now, topicalization of the nasopharynx. This can be done by using cotton tip swabs, which are dipped in local anesthetic, or by using neuropatties. Neuropatties are commonly seen in neurosurgery OTs. These patties can be dipped in a local anesthetic solution and then inserted into the nostrils using forceps, or by a nasal mucosal atomization device. This device is fitted to a 2 ml syringe filled with 2% lignocaine. As you push the plunger, the local anesthetic becomes a fine mist which spreads into the nasal mucosa and gets absorbed. Lubricated serial sizes of nasopharyngeal airways. The nasopharyngeal airways are lubricated with lignocaine jelly, so it helps in anesthetizing the nostrils. It also helps in serially dilating the nasal airway. Coming to the invasive glossopharyngeal nerve block for oropharyngeal anesthesia. What does it block? The posterior third of the tongue, the anterior surface of epiglottis, and the vallecula in between. By itself, it does not aid in performing fiber optic intubation. However, when the tongue is pulled out in order to insert the fiber optic bronchoscope and the tube over it, this block helps in preventing retching. What are the landmarks? It is generally done through an intraoral route at the base of the palatoglossal and the palatopharyngeal folds. But remember, for the intraoral approach, one needs an adequate mouth opening. A major portion of this area is also blocked by a non-invasive technique, where one just asks the patient to gargle with 10 ml of 2% viscous lignocaine. Now coming to superior laryngeal nerve block. The internal branch of superior laryngeal nerve supplies the airway above the vocal cords, and it also supplies the posterior surface of the epiglottis. This branch crosses the greater cornu of the hyoid bone. The anesthesiologist asks the patient to slightly extend the neck. That makes the hyoid bone prominent. He then presses on the contralateral cornu to make the ipsilateral cornu prominent. Once the ipsilateral cornu is made prominent, a 25 gauge needle attached to a 2 ml syringe filled with 2% lignocaine pierces the skin to hit the greater cornu of the hyoid bone. Once it hits the bone, the needle is walked inferiorly and 2 ml of 2% lignocaine is injected on either side to block the superior laryngeal nerve. Next comes the recurrent laryngeal nerve. Oh, that's so easy. Why? Because the landmark is this cricothyroid membrane. this is exactly the point where cricothyroidotomy is also performed between the thyroid cartilage and the cricoid cartilage. So again, one would insert a 25 gauge needle attached to a 5 ml syringe filled with 2% lignocaine. But do we directly inject? No. Once you have pierced the skin, the first step is to aspirate for air to confirm that it is intratracheal. The second would be to inject the local anesthetic. As the local anesthetic enters into the trachea, it makes the patient cough, and this beautifully spreads the local anesthetic below the vocal cords. Now, keep calm and be ready for general anesthesia, for emergency airway. A surgical airway kit should always be ready in case there is some airway catastrophe, and for systemic toxicity of local anesthetics. Although it is known that most of the local anesthetic, which is used for topicalization and for airway anesthesia, is either lost to the atmosphere or it is diluted by the patient's secretions, and very less of it is absorbed. However, one should keep a very low threshold to pick up the early signs and symptoms that suggest systemic toxicity of local anesthetics. One should calculate the total dose of lignocaine to be used pre-hand. It should not exceed 5 ml per kg in case of plain lignocaine and 7 ml per kg in case one is using adrenalized lignocaine. Setting up the scene now. Part 1. It would be to first set up the difficult airway trolley. Difficult Airway Society has recommended this color-coded difficult airway trolley, in which the green drawer, which is the plan A, consists of all our laryngoscopes and endotracheal tubes. Plan B, in case of a failed conventional intubation, is to insert a supraglottic airway. So all the supraglottic airways should be in the yellow drawers. And plan C or D is face mask ventilation with airways until cricothyroidotomy is done. So it should contain our surgical airway kits. Now, devices to aid fiber optic intubation. Why do we need airways for oral intubation? One, to prevent damage to the fiber optic bronchoscope by the patient's teeth. And second, to keep the fiber optic bronchoscope in the midline so that it gets automatically directed towards the vocal cords. First is the Olympus bite block. Now, this does not help in keeping the fiber optic bronchoscope insertion cord in midline, but it has a shorter length. Hence, it is more comfortable in an awake patient. Williams airway, on the other hand, has a longer length, and hence it keeps the insertion cord in the center. But the problem is the upper portion is completely closed, and hence while withdrawing the Williams airway over an endotracheal tube, it can cause tube dislodgement. Ovasapien airway. The Ovasapien airway has a ridge posteriorly which is open, hence it can be easily removed over the fiber optic bronchoscope and does not cause dislodgement. For nasal intubation, one can use the Patil-Syracuse mask. It has two ports. One is a standard 15 millimeter connector port to which the anesthesia circuit is connected, and the other is the endoscopy port. It has a silicone seal, so it will permit ventilation of the patient all throughout, and it will also permit insertion of the insertion cord of fiber optic bronchoscope, and also it will allow the endotracheal tube to pass through it while maintaining ventilation at all times. Now coming to the anatomy of the fiber optic bronchoscope. It largely consists of two parts, the upper body and then the thin insertion cord. The body has various parts like the eyepiece. This eyepiece is connected to the camera so that the image can be transmitted to the monitor, the diopter ring, which is used for focusing, light source attachment, and a suction or working channel port. What can we do through this? Suctioning can be done, installation of local anesthetics can be done, and also supplemental oxygen can be passed through this. Next comes the insertion cord. It has three parts. One, it carries the fiber optic bundle for image and light transmission. It carries the suction and working channel port. It also carries the wires which are necessary for bending the tip. Now setting up the scene, part 2. Here we are setting up the fiber optic bronchoscope system. It has to be first sterilized. One should check the tip movement. Suction valve should be attached and suction available. Light source attached and operational. Connect the bronchoscope to monitor if using a screen and ensure correct orientation. defog the tip of the scope and white balance, focus, lubricate the scope, and load the ETT. Oh, this is a very busy slide. And how do we remember all this? Can we remember it like this? Shweta Mamre is a lovely teacher. S for suction, M for monitor, L for light source. We'll check all these three. And last, we would check the tip. The tip we'll check for defogging, white balance, and focus. Okay. Now the flexion lever, it moves the tip of the scope from 6 o'clock to 12 o'clock in one plane. This is a neutral position. When we press the lever downwards, it causes flexion. When we press it upwards, it causes extension of the tip. Now, next is to railroad. Once we have checked the tip, the next step is to railroad the endotracheal tube over the fiber optic bronchoscope and secure it at the top with a piece of a tape. Line up the fiber optic shaft. Know where the tip points before it disappears from the view. Stand on a short stool so that it keeps the fiber optic bronchoscope shaft always straight. Avoid bending, avoid twisting. In case one needs to twist the tip, other than the flexion and the extension position, which can be done with the flexion lever, rotate the body instead. As we can see here, our anesthetist is standing on a short stool so that the fiber optic bronchoscope shaft remains straight. She's holding the body of the fiber optic bronchoscope in her left hand with her index finger on the suction, and behind her thumb is on the lever. With the dominant hand, she's guiding the insertion cord and also helping to insert a bronchial blocker through it. Here's a short video of fiber optic bronchoscope being done. The bronchoscope is inserted into the nose or the oral intubating device, and one has to follow the patent passage until the epiglottis is seen. And the cords come into view. The cords have to be maintained in the center of the screen. Now, keeping the cords in the center, one should then advance the fiber optic bronchoscope to see the carina. See, right and left bronchi are nicely seen. Once that happens, we would then railroad the endotracheal tube over the fiber optic bronchoscope and position the tip 3 to 4 centimeters above the carina. While withdrawing the scope, one should check for the black line to be there at the cords and also the cuff. Once the scope is withdrawn, one can then confirm the position of the endotracheal tube by bilateral chest auscultation and capnography before inducing general anesthesia. We hope to see this happy sight, wherein the cords are right in the center of the screen, the tube passes across the cords, one can see the right and left bronchi, and then the scope is withdrawn. And when you connect the circuit, we hope to get a nice capnogram before inducing general anesthesia. So now is the time that we will put the patient to sleep. So my friends, finally, when you put your patient to sleep, after he and you have jointly conquered this mammoth task of intubating the difficult airway, the halo of the OT lights around your head would seem no less than a divinely thing. So my dear students, here's wishing that in your anesthesia career over this lifetime, you conquer many difficult airways and practice safe and successful anesthesia. Thank you very much for listening to me. And let me take this opportunity to thank the APPEC 2022 team and the seniors of RML Hospital for giving me this opportunity to talk today. I enjoyed preparing for this lecture. I hope you enjoyed my lecture just as much. Thank you.
Thank you, Dr. Shweta Mamre, for this. Thank you, Dr. Shweta Mamre, for this beautiful presentation.
Thank you, madam. Thank you.
It was actually well presented. PGs must have been benefited a lot because both these presentations, Dr. Ruchi Gupta and Dr. Shweta Membre, I must thank you because our motive was to have a PG kind of a presentation and not a conference type. So, which I think both the talks have fulfilled. And my gratitude to both of you for joining the program as faculty. Thank you so much. And this fiber optic, the video of fiber optic bronchoscope, I really like because it is very educative for them to follow. Another thing that I want to say that though we say that fiber optic bronchoscope is for the difficult intubations, however, PGs must try their hand on the normal airway first. Because once we, we practice our hand on normal airway for 10, 20 times, then only we can handle the difficult airway through fiber optic bronchoscope. This is my take for the PGs. Thank you so much. And we finish this.
Ma'am, I would like
this
to
talk.
Hanji,
Yes, Dr.
PGs should know that fiber optic is a peacetime equipment. It's not a wartime. If you're in a situation, so do not use fiber optic at that situation. It has to be pre-planned for difficult intubation.
Exactly. This is what I also meant, that we must practice well. We must be well aware. Technical support must be there. And, we should not be using it when we are not at a peace. So this is how we should be using fiber optic bronchoscope, but it does help, in difficult situations. And once, we have these video laryngoscopes and fiber optic bronchoscopes with us, then, difficult airway becomes so simplified. Right. Thank you so much. Thanks a lot for the next session.
Thank you, madam.
Thank you, ma'am. Thank you, Dr. Shweta. Thank you, Dr. Ma'am, for the wonderful session. We do not have any questions, so we are moving on to our next session. So in between, I would like to answer a question which was directed to Dr. Amit, which was what was the role of temperature monitoring? So he has answered by his WhatsApp chat. So temperature monitoring is advised if a procedure is lasting for more than 30 minutes, depending upon the surgical duration anticipated. I hope it answers the question. So moving on to our next session, it's a short case presentation. It will be a live presentation. This session will be moderated by Dr. Vanna Talwar ma'am. Ma'am is professor and consultant at VMMC and Safdarjung Hospital, New Delhi. Ma'am's area of interest is critical care. We welcome you, ma'am.
Good afternoon, everyone. At the outset, I'd like to congratulate the APPEC.
Ma'am, you're muted.
Pardon? Can you hear me?
Yes, ma'am. Yes, ma'am.
Yes, I'd like to congratulate the organizers for organizing this wonderful PG assembly, which is the second time in a row, and it's, I'm sure, going to benefit a lot of postgraduates. So I've been given the topic of chest tube management. So the postgraduate allotted is Dr. Nidhi. So I think she is going to start with presentation of the case scenario, and after that we'll take it forward for the discussion. So Dr. Nidhi, can we have the case, please?
Yes, ma'am. We'll start just in a while. Thank you, ma'am. Dr. Nidhi will be presenting the case, and Dr. Hema SR will be also pitching in as and when needed.
Good afternoon, ma'am. Good afternoon, ma'am. I'm presenting a case history of Rahul, 26-year-old male, who was received in emergency department of RML hospital with history of car accident. His car was hit in a divider and the car hit the steering wheel.
Can you change the slide, please, Nidhi? Please change the slide accordingly.
Yes, ma'am. He had complaints of chest pain and difficulty in breathing. Acute onset pain on right side of chest, which was sharp and stabbing. no radiation. It was worsened after coughing and deep breathing, and there were no relieving factors. No history of loss of consciousness, vomiting, or ENT bleed was noted, and no history of any limb fracture was noted. On examination, patient was conscious, oriented to time, place, and person. BP was 100 by 60 mm Hg, measured on right arm in supine position. Pulse was 120 per minute, normal in rhythm, volume, and character. There was no radial or radiofemoral delay. Respiratory rate was 28 per minute. Saturation was 92% on room air. Pallor, icterus, clubbing, cyanosis, and edema were absent. The patient was afebrile. On examination of respiratory system, there was use of accessory muscles. The chest movement on right side were diminished. Trachea position was midline. There was tenderness over the right side of chest. Tympanic note on right side of chest was hyperresonant. And on auscultation, breath sound were decreased on right side. Other system examination, CVS, S1, S2 were heard, and there was no murmur or added sound. Abdomen was soft. There was no guarding or rigidity. CNS, normal higher mental functions, and all reflexes were within normal limits. On investigation,
Just take a break here, Nidhi. And can you just summarize for our viewers, what are the positive findings on history and examination?
Ma'am, on history, the patient had chest pain and difficulty in breathing, and the pain was right-sided. It was sharp and stabbing and worsened on coughing and deep breathing. Other than that, ma'am, there was tachypnea, 28 per minute. Oxygen saturation was 92% on room air. And on examination, use of accessory muscles was present. There was diminished chest movement on right side, and there was tenderness and hyperresonant tympanic node.
So what all is it going towards? First, there's history of trauma. The trauma is followed by pain on the right side of the chest. Why do you think this patient is having pain chest? What could be the causes of pain chest?
Ma'am, in this patient, it is a blunt injury to the chest, which is leading to sudden right-sided chest pain. And the pain is sharp and stabbing and sudden because of the injury.
What could it be because of? Injury to which part of the, what can it be because of the pain?
Ma'am, since it's a blunt trauma, there are chances that it is a rib injury which has injured the pleura as well.
We don't know if it has injured the pleura, so it could be just in the skin, subcutaneous tissue. The patient.
Yes, ma'am, it can be trauma to skin, subcutaneous tissue, muscular, ribs, or even the cardiac and lung injury.
It's on the right side, so I would say it's more likely to be lung and the pleura. So
Yes,
if you think that the pain is due to the pleura, what do you think it's due to, the parietal pleura or the visceral pleura? Which is
it is because of parietal pleura, ma'am, because visceral pleura doesn't have nerve sensations. So it is parietal pleura, ma'am.
About the other positive findings, the tachypnea, the tachycardia, the decreased air entry on the right side of the chest, the hyperresonant note, and decreased auscultation, decreased chest movement. What all is this indicating? So we're all
ma'am, since the tone is hyperresonant,
a provisional diagnosis based on this history and examination.
Ma'am, most probably it is pneumothorax, since there's hyperresonant node, and it can or cannot be associated with hemothorax, ma'am, on the right side of the chest.
Okay, so you're right. So it could be patient is having pneumothorax because on the chest we have a hyperresonant note, we have decreased sounds, we have a history of trauma, we have pain chest. Now, how are you going to diagnose it further? Do you have any other modalities for confirming our diagnosis of pneumothorax?
Yes, ma'am. After auscultation, we can go to the diagnostic techniques. That is, X-ray can be done preliminary, which can be followed by USG, ultrasound e-fast.
X-ray chest of this patient?
Yes, ma'am. We have done the X-ray chest of the patient, and we found that 5th and 6th rib were fractured on the right side of the chest, and pneumothorax was there, ma'am.
Can we see the X-ray? Can we show the X-ray?
Yes, ma'am.
So can you explain to our viewers what are the findings on X-ray chest which are leading towards the diagnosis of pneumothorax?
Ma'am, there's visible visceral pleural edges there, line beyond which there is no lung margin, and there's a radiolucent space, ma'am. And the lung is...
So the most important things are that there's a visceral pleura, the edge is seen.
Yes, ma'am, visceral pleura edge is there on the X-ray.
There are no lung markings there. Okay.
Yes, ma'am.
And the lung is collapsed.
Yes, ma'am. Lung is collapsed.
And the patient might have had a mediastinal shift. In this particular case, there's no mediastinal shift, but otherwise you'd find rib widening, you'll find the white visceral line, you'll find collapse of the lung, there's absence of lung markings, there's shift of the mediastinum. So all this leads to a diagnosis of pneumothorax. Apart from the X-ray, is there any other modality of management of investigation which can be done at the bedside itself? Even an X-ray might take some time, but something
Yes,
which
ma'am.
is done at the bedside in the emergency room?
Ma'am, bedside ultrasound can be done and it has high sensitivity and specificity to diagnosis of pneumothorax. We can do bedside USG.
So you are saying that the E-fast was positive. What do you mean by that? Can we have a look at the ultrasound of this patient?
Yes, ma'am. This is the ultrasound of the patient. In case of pneumothorax, ma'am, there is no lung sliding and absence of comet tail appearance is seen in a patient with pneumothorax in bedside ultrasound, ma'am. And barcode sign is seen.
Okay, so normally what sign is seen on the lung? On the M mode, normally we see the?
Ma'am, normally there is lung sliding and stratosphere sign is seen.
Yeah, so there's absence of lung sliding, and you might see a lung point, which is the point at which the normal lung changes into the lung where because of the pneumothorax, there's no movement of the lung. And when
Yes, ma'am, the junction between the sliding lung and the non-sliding.
And here on the M mode, as we can appreciate, instead of the seashore sign, we have the barcode sign. So this goes towards the diagnosis of pneumothorax. Now, can you tell me something about what are the various types of pneumothorax?
Ma'am, it can be primary spontaneous pneumothorax. It can be traumatic pneumothorax and tension pneumothorax can be there, ma'am.
So what about traumatic pneumothorax? What are the types of traumatic pneumothorax? Like, why do you think your patient has a pneumothorax subsequent to trauma? Is it, does it depend on the type of injury? Because we've said that the patient had an accident with the car, the steering wheel. So does it depend on the type of injury? Is that important?
Yes, ma'am. Since it's a blunt trauma and the ribs are fractured, it has formed a one-way path for the air to enter, and that had led to pneumothorax.
So I think I will differ here, Nidhi. The trauma may be a penetrating trauma or a blunt trauma. This was not a penetrating trauma. Penetrating trauma, you might have a stab injury, you might have a gunshot. So there it'll usually 80% of the time, the pneumothorax will be associated with a hemothorax. But this was a blunt trauma. So here the cause is probably going to be your patient has fractured ribs. So probably it's because of fractured ribs that it's causing a visceration of the, it's lacerating the visceral pleura. So that is the reason for your patient to have pneumothorax. And what is a life-threatening kind of pneumothorax? Does your patient have a life-threatening pneumothorax?
No, ma'am. Life-threatening is tension pneumothorax is the type of life-threatening pneumothorax because it is
pneumothorax.
What, ma'am?
Does your patient have a tension pneumothorax?
No, ma'am. We cannot be sure, but as a X-ray, we don't think it's a tension pneumothorax. It's not
pneumothorax. Your patient is hemodynamically stable.
Hemodynamically stable, yes, ma'am. And there's no mediastinal shift on.
No mediastinal shift. So what happens in a tension pneumothorax? Because that is what we are scared about. What happens in a tension pneumothorax? Because a trauma or any trauma can lead to a tension pneumothorax, and we need to intervene before, right?
Yes, ma'am.
Pneumothorax.
Yes, ma'am. In tension pneumothorax, ma'am, through the one-way pathway, the air keeps on entering and the lungs is further collapsed. And gradually it leads to mediastinal shift and the other side of lung is also collapsed. So the patient deteriorates.
Yeah, right. So it's not only collapse on one side of the chest, the other lung also collapses. In addition, there's a mediastinal shift. So the air compresses not only the lung, but it can compress the heart and the superior and the inferior vena cava, which are entering into the heart. So that is the reason for the hemodynamic instability, right? So I don't think our patient has a tension pneumothorax, but he definitely has a pneumothorax. And what is the next? Now, what are we going to do? How will you manage this patient? This patient is in the casualty. You've done an ultrasound. You think there's a pneumothorax based on your ultrasound and the previous history examination. Now, what is your management going to be?
Management may first we'll do the primary survey of the patient. Which includes if there's a visible hemorrhage, then we control that, and then followed by A, B, C, D, E will be followed, ma'am. Airway, breathing, circulation, disability, and exposure of the patient. Vital monitoring will be done throughout. Patient will be oxygenated with face mask with 6 liters per minute oxygen. IV cannula will be secured and blood grouping and cross matching will be done, and routine samples will be sent. IV fluid will be administered and the patient will be prepared for chest tube insertion.
Is oxygenation of this patient important? He was given oxygen at 6 liters per minute. What is the benefit of giving oxygen to a patient with pneumothorax?
Firstly, the patient has 92% on room air oxygen saturation, so it is better that we support the oxygenation.
How is oxygenation going to help? What do you think how is it going to help?
Ma'am, since one of the lung is collapsed, so
what it will do is it will cause some denitrogenation.
Yes, ma'am. It will
When the
cause
oxygen reaches, it will cause denitrogenation. So it will create a gradient between the air which is trapped in the pleura and the alveolar which is there in the tissue capillary. So it will create a gradient for nitrogen. And that is how the nitrogen will get absorbed. So it's very important to give oxygen to this patient, monitor the vitals, secure an IV line, and prepare this patient for chest tube insertion. Now, why do you want to insert a chest tube in this patient? What do you think are going to be the benefits of chest tube insertion?
And for the re-expansion of lungs,
yes,
we need to insert the intercostal drain in the patient.
Anything else? Anything else the chest tube is going to be useful for? There's a negative pressure in the pleural space. So
yes,
now
ma'am, to maintain the
pressure. So it will restore, it will drain the air of the fluid, whatever there is. Right now, we don't know if there's a hemothorax in addition to a pneumothorax. So it will drain out the air and the blood or fluid, whatever is there. It will restore negative pressure in the pleural space. And third, it will lead to re-expansion of the lung. So those are the benefits of putting in a chest tube. Now, what are the normal pressures in the pleural space? And how are they made?
Ma'am, normally the lung pressures are negative, and it is -4, nearly -4 at the apex and -8 at the base of the lung.
What about inspiration and expiration? What happens in inspiration? Is it more negative in inspiration compared to expiration? And why is there a negative pressure in the pleural space? Because
ma'am, it is more negative during inspiration, and it is because of the tendency of lung to recoil, that there is a negative pressure between the chest wall and the lungs.
Right. So because of the natural elastic recoil of the lung and the fact that the parietal and the visceral pleura are adherent to each other at the hilum, this maintains the negative pressure in the pleural space, which is -8 centimeters of water during inspiration. Yes. So it's more negative during inspiration because during inspiration, the diaphragm contracts, the external intercostals contract, and the intrathoracic volume increases. So based on the Boyle's law, the intrathoracic pressure decreases. And that is how the air comes in. And during expiration, the opposite happens. The pressure increases in the thoracic cavity and the air goes out. And during expiration, it is -4 centimeters of water. So that is what has happened. Now the pleural pressure, which is normally negative, has turned positive because of the presence of air or fluid. And that is why we need to put a chest tube there and restore the negative pressure so that it doesn't increase the intrathoracic pressure further and lead to a tension pneumothorax, right? Now, what are the other indications of putting a chest tube, Nidhi? So one of the indications, as we are saying, pneumothorax, that's a very important indication. What do you think are the other indications for inserting a chest tube?
Other indications are first is pneumothorax, then hemothorax, chylothorax, empyema, post lung surgery, thoracoscopy, thoracotomy, and that's it.
Right. So it's basically when you want to remove air or fluid. Air is pneumothorax. Now, fluid might be blood, it might be chyle, it might be an empyema, it might be pus. Then post-operatively, when you cardiac surgery, esophageal surgery, when you might want to inject some sclerosing agent, as part of therapy, even that. So those are the indications for chest tube insertion. Okay. Now, what preparation are you going to do before putting the chest tube? Now, a patient is ready for chest tube insertion. We've discussed why we want to put a chest tube, what are the indications for putting chest tube, and what preparation are you going to do for putting the chest tube?
Ma'am, first the procedure will be explained to the patient and consent will be taken.
Right.
And then the patient will be positioned in supine position with the arm behind the shoulder.
Anything else you want to take a consent? Anything else you want to do?
Explain the procedure and consent.
Of course, that is part of consent. So you need to just maybe 1, 2, 3. So take consent from the patient, continue to give oxygen to the patient.
Yes, vital monitoring has to be done throughout the procedure.
You might want to have an ultrasound because ultrasound increases your chances of having your chest tube in the proper place. It's very important to give some local anesthetic. It's a very painful procedure. You might want to give sedation to the patient. So you would want to prepare the patient for putting in a chest tube. All these things need to be ready before we put a chest tube inside the patient. Okay. Now, the position, you want to tell us about the position of the patient? What is the position?
Yes, ma'am. The patient will be placed in supine position with the ipsilateral arm abducted and behind the head of the patient, and the patient will be laid comfortably.
Okay. So it's basically supine with that side of the body elevated by putting in a folded towel or a pillow, and the arm can be on the head just to take it away from the site. And
to expose the
site of insertion. Can we just put it anywhere? What side do we put it on, the right side or on the left side? If we need,
it is.
Can you let our viewers know that?
Yes, ma'am. ICD is placed in the triangle of safety, ma'am, the boundaries of which are edge of latissimus dorsi, fifth intercostal space or the nipple line, and the base of axilla. This is a triangle.
So which intercostal space are we talking about when we are putting in a chest tube?
Ma'am, it is either fourth or fifth. Fifth is the most preferable.
Intercostal space in the which line? In the
anterior to mid axillary line.
Yeah. So you can say in the mid axillary line, maybe
in the mid axillary line. Yes.
And the base is at the level of the nipple. Anteriorly, it's formed by the lateral edge of the pectoralis major. Posteriorly, it's the latissimus dorsi. The upper part is the base of the axilla, and the lower part is the nipple line. So you need between the fourth to the fifth intercostal space in the mid axillary line at the level of the nipple. And this is known as the triangle of safety. If you put it more posteriorly, then maybe the patient may be uncomfortable with it. If you put it more anteriorly, you will damage the intercostal muscles because they are thicker there. So in this area, the muscles are thinner. So therefore, this is the area. Now, is our chest tube insertion point, is it any differ? Does it differ in a pneumothorax compared to a pleural effusion? Is it any different? I thought that we put it in the second intercostal space in pneumothorax. Is that correct?
Ma'am, we can put it in the second intercostal space in mid-clavicular line, ma'am.
No, we need to be very clear. Can we put it? What is the recommendation? On the trauma guidelines, what is the recommendation? See, the recommendation for pneumothorax and pleural effusion is the fourth to fifth intercostal space in the mid-axillary line, right?
Yes, ma'am.
It's only in children that it should be put in the second intercostal space in the mid-axillary line. So in children, it can be different. It is different. But in adults, irrespective of whether it's a pneumothorax or it's a pleural effusion, it's to be put in the fourth to fifth intercostal space, right? So should we put it at the superior border of the rib or the inferior border of the rib? Is that important?
Ma'am, it should be put on the superior border of the rib, ma'am, because on the inferior there are intercostal arteries and artery veins and nerves are there on the inferior border of the rib.
Right. So
to avoid the injury.
Bundle, which is there on the inferior border of the rib, inferior border of the rib. Therefore, the chest tube insertion should be done on the superior border of the rib. So these are the things which we have to keep in mind. What size chest tube would you like to put, Nidhi?
Ma'am, in pneumothorax, it is preferable to put a 24 to 28 French intercostal drain in adult patient.
Adult sizes are usually 24 to 32. And 32. The smaller size, the better. For a pneumothorax, you may like to put the smaller size, right? Can you tell us something about the technique of insertion?
Sorry, ma'am?
We have a slide on the technique of insertion. We can let our viewers know.
Yes, ma'am. Insertion of chest tube. First, local anesthesia will be, first the painting and draping of the patient will be done, followed by which local anesthesia will be inserted, will be given to the patient, and then scalpel will be taken, and a horizontal nick will be made on the superior border of the rib, and blunt dissection will be done.
Intercostal space on the superior border of the rib. And this we are talking about the blunt dissection technique. We may also have the Seldinger technique, we have the trocar, but usually what we follow is the blunt dissection technique. Right. Dissection. After making a nick with the scalpel, then
we'll do blunt dissection with the scissors, and we'll use our finger to guide the intercostal drain in the pleural cavity, ma'am.
See, before after you've made your nick, then you go in and you puncture the parietal pleura.
Puncture the parietal.
Puncturing the parietal pleura, just dilate the parietal pleura. Then use your finger as a sweep. There may be some adhesions, there may be a blood clot. So to break that, use your finger as a sweep. Okay. And then your chest tube is ready, your chest drainage system is ready. The distal part should always be clamped. The distal part should always be clamped. Okay, so that air doesn't enter while you're putting in the chest tube. And then with the proximal part, using your finger as a guide, you insert the chest tube. Where should you insert the chest tube? Does it differ in a pneumothorax versus a pleural effusion?
Yes, ma'am. In a pneumothorax, it is placed anteriorly and superiorly, while in pleural effusion, it is placed posteriorly and inferiorly.
Right. And if we have an ultrasound, then it's always better because we know the exact position. So that increases our success rate. Okay.
Yes, ma'am.
So now, before we put in our chest tube, of course, we've got our chest drainage system ready. And can you let us know what are the components, what are the various components of the chest drainage system?
Pleural chest drainage system includes one chest tube with multiple holes in it, a long flexible connecting tube, and a drainage system with one vessel. And
so can you tell us something about the chest tube?
Chest tube is nearly 20 centimeter and it has multiple holes in it.
Right. 20 inches long. It is 20 inches long with 4 to 6 eyelets. Why the eyelets?
So that if one or more of them is blocked through continuous drainage of the air or fluid.
What else does the chest tube have? What is it made of? What is the material? Usually, what is it made of?
Usually, it is made of PVC, polyvinyl chloride.
Silicone, but most of the times we are using PVC. It's 20 inches long. It has 4 to 6 eyelets. And importantly, it has a what line? It has
a radio opaque line so that it is visible on X-ray.
Radio opaque line. What is the use of the radio opaque line? Why is it there?
Ma'am, so that it is visible on X-ray. And
there might be a break in the radio opaque line near the eyelet so that you can identify that the eyelets have got to be inside the chest. You can identify where the eyelets are. So there may be a break in the radio opaque line. Now this chest tube after insertion, we connect it to the flexible tube.
Connecting tube.
First, we put it in with the tube clamp, and our tubing is ready. The drainage system is ready, so we unclamp it and we connect it to the flexible tubing. Can you tell me something about the flexible tubing?
Ma'am, flexible tube is 180 centimeter long.
Yes.
Connecting at one end to the chest tube and other side to the drainage system.
What should be the diameter of the chest tube or of the flexible tubing?
1 centimeter.
Yeah, approximately you may remember it as 1 centimeter. Why is it 1.8 meters long, the flexible tubing?
Ma'am, because it is a gravity dependent drainage. So it is better to have a long flexible tube because the patient will reposition.
How much should it be below the level of the patient? Your drainage system, how much below the level of the patient should it be?
100 centimeter.
Right. So why is the tubing 1.8 meters long then? You're right.
Because the patient repositions if he moves or he lies in the lateral position.
The patient gives the patient to move around in the bed. And also if the patient takes a deep breath, then the water, what is there in the drainage system might be inhaled by the patient. So to give that flexibility, the tubing is 1.8 meters long, right? Now, what are the components of the closed drainage system?
Ma'am, it includes one collection chamber one water seal chamber, and a suction control. This is in 3-bottle drainage system.
Let us start with the single bottle drainage system, which is the one which we most commonly use. Can you let us know what is the single bottle drainage system? What are the parts?
Yes, ma'am. In the single bottle drainage system, one bottle is used both for connecting to the patient and the underwater seal, ma'am. One end of which is connected to the patient, and other is connected, like it goes into the atmosphere on this, or the suction can be connected to the other end.
Anything else you want to add? What is the function of the underwater seal?
Ma'am, underwater seal acts as one-way valve so that the outside air does not enter back into the lungs.
Yes. So what is important is that the underwater seal acts as a one-way valve so that air and fluid can come out but not go back into the patient. And there is a small tubing there which will vent the air into the atmosphere. Now, how much should the underwater seal be? How much of the tubing should be dipped in the water?
2 centimeters.
2 centimeters of water. What should be the level of the water? How much water should I put when I'm connecting my patient to the chest drainage system? I need to know how much water to fill in the
2 centimeters.
No, the tubing is down by -2 centimeters of water. So I have to put some water in the bottle, right? So how much water should be there in the bottle? 100 ml, 200
ml, 100 ml.
So we need to know that, you see. Yes, so the tubing is 1 centimeter in diameter. It's 1.8 meters long. The tube should dip 2 centimeters into the water. The amount of water should be 100 ml. Okay, and it should always lie 1 meter below the level of the patient. Now, what is the disadvantage of the one bottle system?
In one bottle drainage system, since the single bottle acts as collection and underwater seal both, so when the level of the fluid rises, it causes more resistance to the drainage and increases the work of breathing to the patient, ma'am.
So therefore, we have the
2-bottle system.
A 2-bottle drainage system. So can you tell us about the 2-bottle drainage system?
Ma'am, in 2-bottle drainage system, there's one trap bottle in which the fluid or air is collected, and a second bottle is used as underwater seal, which is connected to the atmosphere.
The collection chamber is separate from your underwater seal. So your underwater seal does not get disturbed. Otherwise, if you have too much of drainage, then you might have to keep on emptying the drainage bottle, or else it's going to increase resistance. So the tubing should be dipped only by -2 centimeters of water. So here that part is taken care of. The collection chamber is separate to the underwater seal. But what are the problems with this? Why do we need a 3-bottle drainage system?
Ma'am, in case we need to apply suction, it is not
Why would
good
you
enough
have to apply suction to the patient?
for faster drainage and.
But can we apply suction to the lung? Would it not cause a hematoma, or would it not cause invagination of the tissues? Why would we just apply suction to the lung? Are we applying direct suction to the lung?
Low continuous suction can be applied by 3.
Where would it needed be? Why would you apply suction to the patient is my question. So if you have a lot of air, if there's a continuous air leak, you might want to use suction. Okay. So because that will form a proteinaceous deposit, it'll be like a foam on the collection bottle. So you may not be able to see it properly. So you might want to apply a low suction. So therefore we have the 3-bottle drainage system. So can you tell us about the 3-bottle drainage system?
In 3-bottle drainage system, there's one trap bottle or the collection bottle. Second bottle is the underwater seal bottle, and the third one is manometer bottle, to which the suction is applied, and the distance below water is equal to the negative pressure generated when suction is applied.
So the third bottle here is the most important bottle. That is the one which is used to apply suction. And how much should the tubing be dipped into the water in the suction bottle?
It should be equal to the negative pressure in the lungs.
No, the tubing should be dipped by 20 centimeters of water in the bottle, so that you're limiting the amount of suction you're applying to the lung. So the tubing, the third bottle which we are seeing, the manometer bottle, in that the tubing should be dipped by 20 centimeters of water into, it should be dipped into water by 20 centimeters, so that is the continuous suction which is applied to them. You want to limit the amount of suction. You don't want to apply a direct suction to the lung. Otherwise, it might cause a re-expansion pulmonary edema. It might lead to a hematoma. So you want to limit the suction you want to apply. So the amount of suction which is applied to the lung, we need to understand, depends upon the amount, the length of tubing by which it dips into the water. And that is kept constant at 20 centimeters of water. Is that correct? And you
Yes,
can apply the smaller tubing to the suction. And how much suction should you apply? So that you can just see the bubbling happening in the manometer bottle. Okay. So that is what is the advantage of the 3-bottle drainage system. Now, what is the disadvantage of the 3-bottle drainage system?
3-bottle drainage system, it is very difficult to manage because since there are multiple connections, there can be leakage or disconnections.
Right.
It is heavy and difficult to, in case of transportation, it becomes difficult.
Leakage. So it seems a little impractical to use it. So therefore, what can be done? What else is available to us now? If we want
integrate
advantages of the 3-bottle, but we don't want it to be so cumbersome. We want a portable device. So now we have, what is this?
Integrated chest drainage unit is there, ma'am, which combines has all the functions of 3-bottle system, but is less cumbersome. It is easy to.
It has all the 3, meaning it has the underwater seal, it has the collection chamber, and it has the suction chamber. So all 3 can be used together. Of course, it is expensive. It may not be freely available to the patients we have in government hospitals, but otherwise it is freely available. So an integrated chest drainage unit can be used if we need to use the 3-bottle drainage system in lieu of that. Okay. Okay, so now we have our chest tube in. We've connected the patient to the flexible tubing. We've connected to the single bottle drainage system because we have a pneumothorax. We don't have any fluid coming in. We don't have a pneumothorax here. But if we do, then we can still monitor the blood which is going to come out into the bottle. But we would need to empty the bottle as soon as we get some. As soon as it starts filling, so that the tubing is dipped only by 2 centimeters of water. So can you tell us what are the contraindications of chest tube insertion, Nidhi?
Ma'am, first is if there's a local site infection, there's a coagulopathy. In case of patient who has pleural bleps or in diaphragmatic hernia.
The presence of a pleural bleb?
Ma'am, in those cases will cause more trauma to the patient then.
It's a bulla which you have. So bulla is in the lung. It's not in the pleural space. You put in a chest tube there, what is going to happen? Don't you think it will create a bronchopleural fistula?
Yes, ma'am.
Bronchopleural fistula. So if you have a bleb, you're not going to put it. It's a contraindication. Or if there's a coagulopathy, or the patient does not give consent.
Negative.
Or if there are multiple. So you can, sometimes on ultrasound you see that there are adhesions. So you're not able to put the chest tube. Okay, or if there's infection at the site. Right? Now, what are the complications of putting in a chest tube?
Ma'am, there can be injury to surrounding organs, surrounding structures, nerve, vascular injury can be there, hemorrhage, blockage of the tube, re-expansion.
You think? Why would there be hemorrhage?
In case we injure some intercostal arteries or something, although we are putting it in triangle of safety, but there are still chances of injury.
Right. Okay. Anything else?
Re-expansion pulmonary edema can be there.
You tell us something about re-expansion pulmonary edema?
Ma'am, in case when
not happen.
Ma'am, when there's a rapid re-expansion of lungs is done, more than 1 to 1.5 liters of air is drained in less than 1 hour, then it leads to re-expansion pulmonary edema.
Yeah, so there are some things which we need to be careful about. If there's a lot of fluid, if we are draining 1 to 1.5 liters in half an hour, or the pneumothorax has been there for 3 days, or there's a collapse, which has been a little long-standing collapse, or you apply directly a high suction to the lung, it might cause a re-expansion pulmonary edema. What will happen? How will the patient manifest it?
The patient will have dyspnea, cough and hypoxemia, and the patient will not improve clinically.
Yeah. So this is something definitely which we have to avoid. Anything else? Any other complications? Can the tube be malpositioned?
Yes, ma'am. It can
Be malpositioned. Where all do you think it can be malpositioned? We are aiming at space. Where do you think it can be malpositioned? Can it go into the lung?
it can go directly into lungs, or if placed for
into a vessel? It could be malpositioned. So easiest is if you put in too much, it goes into the lung. So that is why you need to see whether the movement is happening, the tidling is happening. So it could be malpositioned. What else? Complications? Can you introduce air into the lung while you're putting in a chest tube? Can that be a complication?
Yes, ma'am.
How?
Ma'am, if the other end of the chest tube is not clamped, then
very
it can
careful.
directly enter lungs.
Should be
Air to the
clamped
lungs.
while we are putting it. Otherwise, we're going to introduce pneumothorax. It might even lead to a tension pneumothorax. It can be subcutaneous emphysema. That can be a complication, especially associated in this patient with trauma, or if there's a bilateral pneumothorax, or if there's a bronchopleural fistula, then it can even lead to a subcutaneous emphysema. So all these complications can happen while you're putting in a chest tube. Now, Nidhi, can we talk about how do we, what are the general, what is, now we've inserted the chest tube, what is the general care of the chest tube? This will help us even while, if you want to shift the patient for surgery, maybe, the patient might be actually having an fast positive, may have a liver laceration, so might want to go to OT. So it will help us in shifting the patient. And otherwise also, if the patient is in the ICU, you need to know what is the general care of the chest tube. So can you let our viewers know about that?
First of all, the bubbling should be checked, ma'am. There should be continuous leakage if it has been placed properly.
Should there be a continuous bubbling, or should there be something?
No, continuous drainage, ma'am, when it has been introduced, and bubbling should be there. Movement of.
There will be a continuous drainage. But how would you know your chest tube is functional? That's the most important.
Column movement, ma'am.
So that is important. So that is what is known as tidling. Okay, tidling or fluctuation. In which direction are we expecting tidling when the patient is spontaneous versus mechanical ventilation?
Ma'am, it is towards the patient in inspiration and away from the patient in expiration in a spontaneously breathing patient. While in mechanical ventilation, it is reverse.
So during spontaneous respiration, the column movement will be up.
Up in inspiration and down in expiration.
Whereas in mechanical ventilation, during inspiration, positive pressure is coming down. So the column movement will be down in inspiration and it will be up in expiration. So appreciating the column movement is very important, because that is what is going to tell us whether the chest tube is functional or not. Any other precautions?
Ma'am, we should check for leaks or disconnections.
Well, we'll come to that. It should always be 1 meter below.
It should always be kept at least 100 centimeter below the patient.
Tidling should be appreciated. Your chest, the flexible tubing should not be full of fluid. There should be no fluid dependent loop there. Why?
Because then in case of during inspiration, the fluid column will move into the lungs.
Yes, and it'll create a resistance to breathing. It'll increase the work of breathing. So you need to sort of that thing will have to be emptied out. So is milking and stripping and all, is that recommended?
No, ma'am.
That is not recommended because it increases the negative pressures tremendously and it can lead to damage to the lung. So you need to be very gentle. If it's a this thing, then you can clamp the tube, get the fluid out, and then this thing. So milking and stripping is not recommended because it increases the negative pressure and can lead to damage to the lung. What precautions will you take while shifting the patient? Say the patient has shifted for a CT or shifted to the OT. What precautions will you take?
During shifting, first of all, it should not be clamped and
Right.
it should be kept 100 centimeter below the patient.
You need to clamp it. Maximum, how long can we leave it as clamp? Maybe a minute, but not more than a minute. Otherwise, even during transport, leave it 1 meter down. Okay?
Yes.
You can fix it to the lower edge of the trolley, the railing. So it should be functional. That's important during transport. Any other precautions? Any other precautions while supposing you have to induce this patient now? You've shifted the patient, you've seen that it's 1 meter below, tidling is occurring, the chest tube, the flexible tubing is not full of fluid, the column is moving. Now, maybe you need to induce this patient for say a hemoperitoneum. Any precautions you'd like to take during induction? Well, we won't go into the details, but just generally, be gentle.
Intermittent positive pressure should be given.
It should be a smooth induction. Avoid coughing, bucking, because if the patient is going to cough and buck, then he's going to inhale the fluid. It will go up during inspiration. Always leave the chest tube open when you're inducing. Never leave it clamped. Okay, and have a smooth induction. You may try and avoid nitrous oxide because that might increase your pneumothorax.
Yes, ma'am.
These are some precautions you can, and monitor your oxygenation, your ventilation. So be gentle with that, with your ventilation. Supposing you have a bronchopleural fistula, what's going to happen? Whatever ventilation you're giving is going to leak out into the tube, right? So if it's that big a bronchopleural fistula, then you might just have to do a double lung, a 2-lung ventilation. So you need to know that. So be gentle with ventilation, okay? Avoid coughing, bucking, have a smooth induction, and leave your chest tube always unplanned, okay? Now, let's discuss some of the troubleshooting, Nidhi. We have a chest tube in situ. Let's see what happens if the column is not moving. What are you going to do? What could the reason be? How will you manage? You come on your morning round and the chest tube column is not moving.
If the chest column is not moving, there are chances that the the tube has malpositioned. It has either come out or it is way beyond the.
Anything else?
Ma'am, there's blockage.
Yes, the blockage where?
Blockage at the level of chest tube.
The patient might be lying on it. It could be kinking.
A patient can be compression under.
As simple as that. The flexible tubing is kinking or the chest tube is kinking. So there could be some kink, there could be some obstruction. It could be malpositioned, or there could be a fluid-filled loop in the flexible tubing, or maybe the lung has expanded. Isn't that possible? Not move if the lung has expanded. So all this is possible. So you need to know the reasons why the column is not moving and look into them. You can do an X-ray, see maybe the lung is expanded. Okay. Now supposing there's a continuous leak. There's a continuous bubbling which is happening into the bottle. What does that indicate to you?
There are chances that there's a disconnection or a leak at the flexible tube or the chest tube. At any level, there can be leaks. So we have to check for disconnections and leaks.
How do we check for it?
Ma'am, we start proximally from the level of chest tube and then we go down.
What do we do? What do we do?
We clamp it.
Right. So you clamp the chest tube closest to the patient. From proximal, you come distal. Supposing the air leak stops, what do you think it is?
That the leakage is above that level.
Yes, so the leakage is in the lung or the pleura. If it stops immediately as the chest tube, it's probably in the lung or the pleura. So that is what. Do we have 5 minutes?
Yes, ma'am. Yes.
To wind up?
Yes, ma'am. Just another 2 minutes, ma'am.
Okay, another 2 minutes. Okay, so that is how you come, and then you kind of take it distally down. And if you put your clamp between the air leak and the water bottle, where it stops, you know where your air leak is. Okay, and supposing your chest tube gets, you see that on the morning round, you've seen that it comes out. What do you do?
If the chest tube comes out, then
yes.
we completely remove the tube and we put purse string sutures over the side.
Put it back in. Would you like to reinsert it?
We can reinsert it on the other side.
On the other side, meaning?
Matlab,
you will not reinsert the same tube.
Reinsert the tube, same tube back. We'll change the tube and we'll take a fresh tube.
Immediately seal that site. You would put a pad and bandage there. Immediately seal the site, because otherwise the patient will have pneumothorax. So immediately seal it and get ready to put in another chest tube if the patient so requires. Now, we've been monitoring the patient every day. Now it's time to remove the chest tube. What are the things which we see before removal of chest tube?
Ma'am, we check if the patient has clinically improved, ma'am, and there is no dyspnea, the bilateral air entry is equal. Then we can, the patient is better, ma'am, and there is no further drainage. The drainage had reduced, and then we can do X-ray for the confirmation if the lungs have re-expanded.
The patient is clinically improved. Air entry is better. When you auscultate, you find an air entry now. On the X-ray, the lung has expanded. The saturation is better. Okay, and your drainage is less than 100 ml per day. Or if it's a pneumothorax, you've not seen bubbling for 24 hours. So now you may want to remove the chest tube. Okay, after removal of chest tube, again do an X-ray chest to confirm that the lung is expanded. And when do you remove the chest tube? During inspiration, expiration, you can.
Ma'am, we ask the patient to perform Valsalva maneuver, and at the end of expiration, we remove it.
Maneuver during exhalation, and then the chest tube is removed. So I think with that, I would have liked to summarize, but I think time is up. And I think we have discussed most of the salient features in chest tube. Does anybody have any questions? And or I'd like to thank Dr. M.D. Kaur. I'd like to thank all the organizers, Dr. Neeraj, Neerjan, all the other organizers for getting this discussion on the chest tube. I hope it benefited most of the PGs who would have attended it. So thank you very much. There are no further questions.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Ruchi.
We thank you, Dr. Vandana, ma'am, for the great interaction that we had with the PG. And it is an art to pick up the cues that are given during the exam. So the examiner actually guides you for the Viva session. Thank you, ma'am.
Thank you so much. Thanks.
Thank you, Dr. Neha and Dr. Hema, and thank you, Dr. Nidhi. So moving on to our next session, it is a slide change. 1 second. Slide change in the order of.
Hello, can we have the slide of Dr. Shiv Kumar?
Yes. Dr. GD Puri, sir, are we joined? Are you joined?
Alok?
Hi guys. I was happy with the program. I thought there was another talk before the lunch. If you want to me to do it early, I'm fine.
So Dr. GD Puri, sir, will introduce our speaker, Dr. Shiv Kumar Singh, sir. It is also his birthday today. We wish you a very happy birthday, Dr. Shiv.
Thank you very much. Yeah.
So do we have Dr. GD Puri, sir? Sir, can you please introduce Dr. Shiv?
Ma'am, sir is not here at the moment.
Okay.
Should I start then?
Good morning, sir.
Good morning.
It's a pleasure to have you here.
Thank you.
And
Thank you very much.
especially on your birthday.
Thank
It's
you.
nice. And actually, sir needs no introduction. He's a chairman theaters and anesthesia. He's a lead in regional anesthesia. We see a lot of posts of sir in the anesthetist group. So he's liked by all and he's one of the very known teachers. Over to you, sir.
No. Can I share my screen?
Yes, sir.
Yes.
Okay, let me know if you actually see the whole screen before I start, because sometimes What are you seeing? Are you seeing?
Yeah, we are able to see your
Yes.
screen, sir.
Yes.
Are you able to see the whole screen, or are you seeing everything?
Whole
The
screen, sir.
whole screen. Okay, all right. So thank you, Aklesh, for inviting me and your team. And let's see if, yeah. This lecture is dedicated to my guru, Dr. D.K. Pawar. I'm sure a lot of you know Dr. Pawar and Dr. Mrudula Pawar. He was my guide, and he's the one actually who taught me proper oxygen therapy to actually understand what exactly the oxygen therapy is, what is the physiology behind it. I have no disclosure or conflict of interest. So this is the outline of my lecture. So why do we need to actually know about oxygen therapy? Okay, the physiology behind oxygen delivery and utilization, how oxygen can be delivered. That's what the topic is about. How much oxygen each device delivers, and I'll be also talking a little bit about the oxygen newer methods of oxygen delivery. I'm not going to go into ECMO, IVOX, or NovaLung, but I'll talk something about NoDSAT and Thrive in a little bit because they were used quite a lot, especially Thrive was used quite a lot through COVID times. Now, this is a very important article. I think everybody should actually read it, understand it well. This is about pulmonary complications, post-operative pulmonary complications. Because one of the important thing about anesthesia is that we need to prevent this post-operative pulmonary complication. And the main reason for that is that you don't want that the patient who is actually fit ends up in the bed. Okay, he should be able to get up and go about. At the same time, you get a patient who is frail, elderly, you should be able to actually make them walk around. Okay, so these are the two things you should be able to do. Now, post-op pulmonary complications, they're very common and they increase the cost of the stay. Then they increase patient mortality as well, morbidity as well as mortality. So as soon as you actually induce general anesthesia in patients, there's changes occurring in the respiratory system. So even if the patient, you're going to keep them spontaneously breathing, there is reduced respiratory drive, the muscle functions are altered, the lung volumes are reduced. But one of the important things everybody has to understand that atelectasis develops in more than 75% of patients who receive a neuromuscular blocking drug. The reason for this is that a lot of places, if you actually look at the literature, people are not monitoring the neuromuscular junction. And it is very important to monitor the neuromuscular junction to actually reverse it as well. So even if a minute amount of neuromuscular drugs are existing in the post-operative period, they lead to increased post-op pulmonary complications. So reversing is very, very important. And that is only possible to do it by having neuromuscular junction monitoring. And if the patient develops post-operative pulmonary complications, this can lead to, a long-term morbidity. It takes almost 6 weeks for patient to return back to his normal state. There are modifiable and non-modifiable risk factors, and I will go through some of them. So the preventive measures are that we use appropriate protective ventilatory strategies during the ventilation in the theaters. And then you manage the neuromuscular junction, that is blockade, appropriately. Like I said, you need to start monitoring them. Okay, so people who give or use long-acting neuromuscular blockers, they need to monitor the neuromuscular junction. And obviously there is preoperative optimization of comorbidities, and asking them to stop smoking. And this need to be, for almost 6 weeks, not that, oh, I've stopped smoking yesterday or 2 days ago or a week ago. No, it need to be almost for 6 weeks before you can actually see the benefits of it. And the correction of anemia is actually very, very important. This has been talked about again extensively in the postoperative outcomes. So protective ventilatory strategy, though it's not part of this lecture, it's important that you use low tidal volumes, which are based on ideal body weight, not the total body weight, and use the appropriate amount of PEEP. And you need to initiate recruitment maneuvers at any stage where you think that there is some atelectasis developing. and also before extubation of the trachea. Before you actually have the patient, sitting up, you need to get them out of the bed, sit them up, make sure that there is recruitment of the lungs, and then take out the tube. And for high risk patients, you need to make sure that the surgery is not a prolonged surgery. And then in the postoperative period, you avoid nasogastric tubes and make sure the patient gets appropriate analgesia. They're mobilized early, they get chest physiotherapy, and they actually get a proper oral hygiene to prevent chest infections. So coming to normal respiratory physiology, all of us know we breathe 20% oxygen, and 78% of that is nitrogen. Now, nitrogen is very, very important. All of us, actually, whenever we're talking about doing a rapid sequence induction, we do denitrogenation. But is denitrogenation good? Now, this is long back ago, and if you look at the last author is John B. West. John B. West is a known author, or he's a specialist in respiratory physiology. The books on respiratory physiology is by John West are read throughout the world. And they actually did a study long back. This is in 1974, and they looked at continuous distribution of ventilator perfusion in patients breathing air and 100% oxygen. And what did they actually see? They saw that if you are actually allowing patients to breathe 100% oxygen, the patient will develop shunts within 30 minutes of commencing oxygen breathing, that is giving 100% oxygen. And this atelectasis occurs because of denitrogenation. Okay, so denitrogenation is not a good thing. And that also brings us to the fact that when we are, people call it pre-oxygenation, it is a denitrogenation. You don't have to do 100% denitrogenation. You can actually use 80% oxygen, so use oxygen air, and you get similar times for desaturation. So you get the safety margin is no different between 80% oxygen and 100% oxygen. But then you would actually prevent, if you don't give 100% oxygen, you would prevent atelectasis, which can occur from giving oxygen. So oxygen we deliver, or oxygen we breathe, go through a cascade, or as a whirlpool, as people call it. And this happens because there is a gradient. There's a huge gradient between the alveoli and at the mitochondrial level, where the oxygen utilized by the mitochondria, where it is converted to energy and water. So this gradient is very, very important. And every student need to know about oxygen cascade. Now the oxygen we breathe, okay, so it is 21%, we all know. But where does this numbers come from? Why that is the oxygen breathed is partial pressure of 150 millimeters of mercury? How do you know? This is very important for everyone to know. Okay, so this is a alveolar gas equation. Everybody should know it by heart as a student. That's PaI2 is equal to PiO2 minus PaCO2 by R. The R is the respiratory coefficient, which is constant for most, is 0.8. And CO2, obviously, you will measure it. It will depend whether how much you're hyperventilating or hypoventilating. So this is what PiO2 is. This is what refers to the 150. So PiO2 is a barometric pressure with 760 millimeters of mercury minus the partial pressure of water vapors in the lungs, that is all in the air, which is 45, into the FiO2, which is 20 or 21%. So if you put some numbers, that's where the 150 actually comes from. The respiratory quotient, so say the normal CO2 is around 40 millimeters of mercury, respiratory quotient of 0.8. That gives you a value of 50. So 150 minus 50 is 100, and that's where the 100 comes from. That's what is there in the alveoli. That's the partial pressure of oxygen in the alveoli. And then there is obviously the partial pressure will drop because of various reasons. There's diffusion of oxygen, carbon dioxide coming in. There are normal shunts, there are physiological shunts like the Sebacean veins, okay, bronchial veins. So these will lead to shunts in normal patients, assuming there is no atelectasis. And then obviously the consumption at the tissue level, throughout there is an increase, there is oxygen consumption in various tissues, and it drops to a very low level. Now, whenever there is, hyperventilation or whatever reason, the partial pressure in alveoli drops, you need to look at the cause for it. What is the cause for this hyperventilation or drop in the PO2 level? And to some extent, you can improve this by giving extra oxygen. That is what oxygen therapy is. But is that the only way? I think just, yes, you can improve the oxygenation. So patient has dropped the saturation to 89%. You start them on 60% oxygen by venturi mask. Yes, oxygen improve. And no, you don't go back to bed. You need to find out why the patient actually has dropped this oxygen. Okay. So two things which is very, very important. We know that the lungs, the oxygen is going in at the alveolar level, carbon dioxide being diffused out. Okay, and you think that the ventilation perfusion matching is the best. The oxygen and carbon dioxide diffused through a very small membrane, which is only 0.5 micrometers, and you need to know about these. There are obviously other aspects of it, like what are the cells, which keeps the alveoli open. But we're not going to go through this part in details. But what is important is the role of hemoglobin. Now, if you look at the hemoglobin when it reaches the alveoli is in a relaxed form. Okay, I say why it is relaxed? It's relaxed because now it can breathe oxygen. Okay, but when it has a tissue level, it's in a tense or tau form. Okay, so easy to remember, starts with T in the tissues, right? So the hemoglobin molecule, which is a deoxygenated hemoglobin, it is in tense form in the tissue levels, and this is helpful in delivering the oxygen to the tissues. So in a situation where there is low pH, so it's acidotic environment, there's low PO2, again at the tissue levels, okay, and increased carbon dioxide, the hemoglobin, which has got oxygen, it delivers the oxygen to the tissue. But in the lungs, where there is going to be plenty of oxygen, okay, it can take big breath and get relaxed. Okay, that's just relaxed. That's how you remember it. So where the increased oxygen tension, the hemoglobin will attach one oxygen, and then it helps in attaching another oxygen. That is what is cooperativity. So in the presence of higher oxygen tension and low hydrogen concentration, that is higher pH and low CO2 levels, the hemoglobin is able to attach 4 molecules of oxygen. So this cooperativity is very, very important to know. This is also known as the Bohr effect. The Haldane effect is more to do with what actually happens to the carbon dioxide. So deoxygenated hemoglobin has got higher affinity for carbon dioxide, and that is your Haldane effect. So carbon dioxide can be dissolved in the blood, as well as is combined with deoxygenated hemoglobin and then delivered at the lung level. So this is again important. So Haldane and Bohr effect, you need to remember O is for oxygen, H is for hydrogen ions, okay? So there's another thing is that in the tissues, the red cells are actually larger. It's actually bigger than the red cells in the lungs. And that happens because the carbon dioxide diffuses in. It combines with water, so it needs water to form the carbonic acid. And the carbonic acid then dissociates in hydrogen bicarb ions. And these bicarb ions are then exchanged for chloride. This is called chloride shift. So there is increased amount of chloride and water in the red cells at the tissue levels. And they say the cells are bigger at tissue level. But when they actually come to the lungs, they lose out the water and the chloride, and they shrink in the lungs. So they're able to actually go through the capillaries and acquire a lot more oxygen. So Bohr and Haldane effects, they promote oxygen binding and carbon dioxide release in the pulmonary capillaries. And the reverse happens in the tissue. Like I explained, that the hemoglobin tends to release the oxygen in acidotic environment, in environment which has got high carbon dioxide levels, and where the partial pressure oxygen is low. So that's Bohr effect, Haldane effect. These are very, very important to know. This is at tissue level, something which we need to look at the hemoglobin. So hemoglobin is very, very important. Knowing about the acid-base status is very important. Knowing how much of the partial pressure is there, that's what you do with the blood gases. But then coming to like say, okay, this patient has dropped saturation. Now is the patient in the theater. There are two things which you need to know. Is there a dead space happening or a shunt happening? And we need to actually know the causes and importance of it. And we consume around oxygen around 250 mLs. Okay, the oxygen at the venous level is 150. The partial pressure is, we're looking at around 200 mLs per liter of oxygen at the arterial level. The consumption only 250 mLs per minute. So you need to know about this 3-lung model where there is atelectasis, there is wasted perfusion. The perfusion goes without picking up oxygen or delivering carbon dioxide. So that forms the shunt. Whereas if there is a pulmonary embolus which blocks the capillaries, there is wasted ventilation. So the alveoli is full of oxygen, but it can't deliver that oxygen to the tissue at the capillary level. So that is the dead space. Okay, so the oxygenation and exchange is affected by both a shunt and a dead space. So let's see what happens if there is, embolus happening. So there is no flow in that area. The alveoli is getting everything is filled up with oxygen, but there is no exchange at all. So there will be increase in the PCO2 level because it's not been washed out, and decrease in the PO2 level because no oxygen is coming in. So no good for that space. Same thing with the, you have atelectasis. Okay, so the venous blood which is coming in is not able to deliver carbon dioxide, and it's not able to actually get oxygen again. So there's again drop in the PO2, there's drop in the SPO2 levels here. So no good. So we have to look at it. So we have to actually know what is shunt and what is iso shunt lines. So if you look at the iso shunt lines, now normally everybody has got 5% shunt. Like I said, these are physiological shunts. And if your PO2 is low, you can increase the FiO2 and you will likely get normal oxygenation. But as the amount of shunts increases, so there is more and more of atelectasis happening, or there is, for whatever reason, like ARDS, once the shunt levels go up to 50%, if you look at that, whatever amount of oxygen you actually give, that is by, whether it's endotracheal tube or with a CPAP or whatever, you not be able to raise the PO2 levels. That means the gradient between the alveoli and the tissues is markedly reduced. That's where the severe hypoxia will happen. So more than 50% shunt, it's bad. You can see that around even the 25 to 30%, you can actually reach a PO2 of probably around 90 to 100% and still maintain oxygen. But once it actually exceeds more than 50%, you are in a bad situation. The other concept you also need to know about is the coefficient of utilization. And for this, it's very important to know what's the arterial oxygen content. And this requires to know how much oxygen is bound, that is to the hemoglobin, and how much dissolved. Dissolved oxygen is very, very important. So if you put some normal numbers to this, we see that the oxygen flusk is around 1 liter per minute. So we have 1 liter per minute, but we only use around 250 mLs. And that's why the coefficient of utilization is only 25%. And that's very good. But if you look at that, even if the consumption is normal and the oxygen delivery is reduced for whatever reason, or if there is increased consumption, for example, you have patients, you're giving normal oxygen being delivered, and the patient is shivering a lot. There is increased consumption, almost 300% increase in consumption, or your cardiac output is low for whatever reason, hemoglobin has dropped because the surgeon had bled the patient, or you are actually operating at the Himalayas, high altitude where the oxygen availability is reduced. This will all increase the coefficient of oxygen utilization. Okay. So who needs oxygen? We all need oxygen, which is enough for us, and 21% is enough, but who needs this extra oxygen? And you can actually see whenever there is a ventilation perfusion mismatch at any level, then you need to actually deliver increased oxygen. And look at this, patient who's got a low cardiac output, low hemoglobin, POT is only 8, saturating 8, 91%. And even if the oxygen consumption is low, say 250 mLs, the delivery is only 380, 385. And that means the coefficient of utilization increased to 65%, and thus reduces the safety margin. Okay, it's not good. So we need to ensure the cardiac output is improved, hemoglobin is improved, the oxygen saturation improved. Okay. So high coefficient of utilization will lead to relative tissue hypoxia. That's, trying to deliver more oxygen, like the more effects comes into effect there, then anabolic metabolism sets in. And we know that metabolic acidosis shifts the oxygen decision curve to the right. I'm not going to talk too much in that, I'll only talk briefly. And that's for delivery of oxygen at the tissue level. Bohr effect is important. And like I said, the environment where low PO2, low pH, and high CO2, then oxygen is delivered tissue. So tissue delivery is increased. And if there is reduced cardiac output, you need to improve it. And metabolic acidosis depresses cardiac contractility and cardiac output. So improving acidity or improving the pH or improving the acid-base state is important. And so low oxygen availability and increase in coefficient of oxygen utilization is no good. This you need to know as a students, you need to know what shifts the oxygen decision curve to the right, what shifts it to the left. What is the effect of temperature, 2,3 dpg, what is pH, what is CO2, all this you need to actually know for the exam purposes. But I want to talk about another important aspect is that what happens to lung volumes in normal and in elderly patients. And that's where the understanding of FRC versus the closing volume or closing capacity comes in. So we know that in the post-operative period, there is diffusion hypoxia, especially if you're using nitrous oxide. Right. You give nitrous oxide, it diffuses out very quickly, and it dilutes the oxygen, whatever you're giving. So it's important that you give 80 to 100% oxygen, like 100% not, but 80%. Okay, most people tend to use 100%. I would never. So mine is 70 to 80% I normally maintain. You need to actually give 70 to 80% at least towards the end of around your post-operative period for 10 to 15 minutes before you decide to extubate the trachea. And we know that in long procedures, they're going to be basal atelectasis and shunts will be forming. So it's very, very important that you recruit the lungs before you start thinking of extubating the trachea. Do recruitment maneuver, increase the flows, increase the PEEP, make sure the patient is sitting up and improve. Now, why the sitting up is very important. Keep talking about sitting up. Okay. Now, if you look at this graph, this is your age versus the FRC and the closing volume. Now, if you look at the age of 45 years, the closing volume will encroach onto the functional residual capacity. That means it starts getting bigger than the FRC in lying down position. And that means that there will be a closing of the, collapsing of the alveoli if you actually even have a young patient more than 40 years in lying down position. But if you look at patients who are in 65 years and above, their closing capacity is more than the functional residual capacity, even in the upright position. So these patients tend to actually have some amount of, atelectasis, even in a normal position. And that's why probably they actually have more frequent size to actually recruit the lungs and increase their functional residual capacity. So even for young patients, leave alone the older patients, young patients, it's important that they do not keep lying in a supine position for a long period of time. Have them sitting up, especially soon after the surgery, where there is some amount of hyperventilation because of your residual opioids or your residual neuromuscular blockers. You need to actually keep them, sitting up. Have them propped up around 45 degrees if they can allow. In some patients, you may not be able to do because of the hypovolemia. So in that case, you would not need to fill them up if that's possible, maintain the oxygenation, ensure that the hemoglobin is fine and they're ventilating well. So the factors that reduce the availability, this is summarizing for what I have actually talked about, the physiological basis. Low oxygen content can happen because low saturation, and that happens if the patient is anemic or there's low PaO2 for whatever reasons. Okay. Low hemoglobin is no good. It can happen because of anemia. It can happen because of dyshemoglobinemia. So smokers who have high carbon monoxide levels, they may appear very red, they appear pink, they have 100% saturation. But if you look at the actual PaO2, measured PaO2, that will be very low. Same thing with methemoglobinemia. Okay. Then is the low cardiac output. So maintaining the cardiac output is equally important in case of when we calculate the coefficient of utilization. And then we also need to look at what are the factors which are increasing the oxygen requirement of the patients. Okay, that is raising the coefficient of utilization more than 25%. It's increased more than that. So patient, waking up cold. That's why it's very, very important to maintain normothermia during the intraoperative period by giving warm fluids or using forced air warmers. This is very, very important. You need to look at what is the oxygen cost of ventilatory effort, especially if patient is ventilating spontaneously. Now, that's where the neuromuscular blocker actually comes in. So even if there is a little amount of neuromuscular blockade remaining, you have, given the reversal and still patient has got a little bit of residual, that will increase the oxygen cost of ventilatory efforts. Patients who are tachycardic, tachycardia or pulse rate comes on both sides of delivery of oxygen as well as in the consumption side. So tachycardia is no good. Patient, if they are hyperparexic, they have got temperature pyrexia because of whatever reason, again, increase the oxygen cost of patients. So how do we manage the oxygen delivery? Okay, how do you ensure that enough oxygen is reaching the tissue level? It's important that the oxygen gradient is maintained from the lungs to the tissues, and the tissues are not in an acidotic condition. Okay. So this we can do by increasing the availability. So you raise the oxygen arterial tension, and that's possible if you look at the alveolar gas equation. If you increase the FiO2, you increase the PiO2. You can't affect the barometric pressure. You can't affect the pressure of the water vapors in the atmosphere. But what you can actually affect is the FiO2. So by increasing the FiO2, you increase the PiO2. Then hemoglobin content. If the patient is anemic, the hemoglobin is 6 or 7. Okay, you need to give red blood cells to these patients. You need to make sure that the acid-base status is normalized in patient. You look at why the patient is acidotic. Is it because of the metabolic acidosis, respiratory acidosis? Is the patient hypoventilating for reasons? And then improve the cardiac output. Okay. So this will ensure that the delivery of oxygen, the oxygen flux is actually maintained. In certain situations, you might have to reduce the requirement. It might be that the patient is breathing so rapidly, his oxygen, ventilatory efforts are huge. You need to paralyze and put them on the, IPPV. You might have to control the rate using drugs like beta blockers. You might need to cool the patient down if they are, whether giving paracetamol or physically cooling them down. And in extreme situation, we tend to do this. This has been used. Hypothermia, 30 to 35 degrees to reduce the oxygen requirement is known in cardiac arrest patients. Okay. So 3 things you need to actually understand very well is the alveolar gas equation. You need to understand what dead space and shunts are, and what are the factors which are affecting the coefficient of oxygen utilization. These 3 things, if you understand, then you have almost mastered the respiratory physiology or delivery of oxygen at tissue levels. Okay. So always remember your alveolar gas equation. Remember what is PI2. PI2 is very, very important. You can't affect, like I said, affect the barometric pressure or the pressure of the vapor. Okay, fine. If you have a patient who is actually on Himalayas, you can bring them down to the sea levels. But the easiest thing is to increase the FiO2. That will increase your PiO2. Now, the second part I haven't talked much about this is PaCO2R. When patients are hypoxic, why do they, ventilate rapidly? Why do they try to wash out the CO2? Now, you know that if the patient is breathing 21% oxygen, the PiO2 is going to remain constant. Hello, somebody's got their mic on, please. Can they switch off the mic, please? Thank you.
Request all to switch off the mics, please.
So if you actually have patients who actually are hyperventilating, then you will reduce CO2. Now, if you halve the CO2 to 20 by 0.8 is 25. So you are actually increasing. So if the PiO2 is constant 150, that's that you are actually increasing the partial pressure oxygen within the alveoli without doing anything. So this can only be for a certain period of time. The patient will exhaust themselves after some time. You see this in action when patients are actually throwing pulmonary emboli. If you have a patient who was normal and suddenly start hyperventilating for no reason, think that something is going wrong there. Okay, and one of the reasons is the first symptoms of patients throwing a pulmonary emboli is hyperventilation. They will stop, and they will start hyperventilating to wash out the CO2 to maintain the partial pressure within the alveoli. And in this case, obviously, you are going to improve the oxygenation. You have to prevent that alveoli happening, but at the same time, you need to give higher concentration of oxygen to that. So coming to oxygen therapy devices, how can you actually deliver increased oxygen to the patient? You could use simple devices, nasal flow, cannula. And one of the questions I asked is that, okay, you are giving 2 liters of oxygen through this. What is the FiO2? So for every liter of oxygen delivered through cannula, the FiO2 goes by 4%. Then we have certain newer device, and I will talk about this in a minute. This is a part of the Thrive. And this was again used quite a lot during the COVID time. And the reason or how it works, I will briefly describe as well. This is the common way, another common way of delivering oxygen. You can have venturi device, or you can actually have a reservoir flow. So this can actually give higher concentration of oxygen. So you can actually see the oxygen is filled up in the reservoir bag. So this is a rebreather mask. You can have tents. Patients, there are some patients who are claustrophobic, will not allow. Okay, this is again was used in some places. You can just use tents. Tents are mostly used in pediatrics. You all know that tents in kids is used more commonly. But the most common way of delivering oxygen still remains through venturi devices. So there are different color venturi devices which tell you what percent of oxygen they'll deliver. So you can look at that. It's 24% with blue, it's 28% with the white, and it goes up to 60%. You cannot actually go above 60% with a venturi device. So they are there. But if you have to deliver 100% oxygen, best thing is to go back to the anesthesia system, the breathing system. And we tend to actually use these systems quite a lot. These are not used in theaters, but in the recovery and in the emergency, these are called water circuit. Okay, Mapleson C types, where what happens, these are nice to use because your mask, your APL valve, the bags are all together, so easy to hold and control everything. PEEP, the positive pressure within the bag, everything is easy to ventilate. They do require higher flows. They're not very efficient, but these are actually very useful for delivering oxygen. And now the newer systems come in, is Thrive and NotiSat. Okay, so Thrive is used quite a lot during this time. So we all know what Thrive is, transnasal humidification for rapid insufflation or ventilation exchange. And I'll talk about NotiSat because for Thrive, you need special equipment. Okay. So high flow nasal oxygen therapy, it is also known as HFNOT. So high flow nasal oxygen therapy in adults. So these are special kind of cannulas, nasal cannulas. This is a wide bore. So these are wide bore cannulas. So the cost is greater. They have two special machines. Okay, so you need this high flow machines which have got humidifiers. They can deliver very high flows have high FiO2s. I'll show. So if you look at this, the flow meter. Now, if you look at your normal flow meter, they can deliver anywhere from 15 to most flow meters will actually give you around 15 liters of oxygen. Okay, some give 20, but these can give up to 70 liters of oxygen. They have got special humidifiers. So these are the humidifier. So you are giving high flow oxygen through the nasal cannula system, which is wide bore, and they are temperature. This is the latest version of the machines. There are various machines available in that. So what is the system? How are you able to actually deliver such high flows? Because if you actually give, say, 8 liters or 10 liters through a normal nasal cannula, patient will likely say, no, they can't tolerate. It causes crusting, drying up, and that's why humidification is important. So there are two things within the system. So there is humidification, which provides comfort and compliance from the patient. Then there is the high flow. So the high flow in expiration produces some amount of PEEP. Now this came from the pediatric studies when they were using high flows in these patients. So these are good. And this PEEP effect leads to recruitment of the alveoli, and it causes the dead space washout. So the CO2 is actually washed out. Sorry, guys. It's my birthday and I'm getting constant messages and because there is washout of the carbon dioxide, there is improvement in PO2 and washout of CO2. In the inspirative time, there is, if the patient is breathing rapidly, their peak inspirative flow requirements increases quite a lot. So this 100 to 150 liters per minute. Now this is again delivered by the high flows. And again, there is more of alveolar recruitment and there's better ventilatory perfusion matching happens. So both these factors, that there is high flow, which is causing a peak effect, and there is better compliance. These are actually better for patients. So coming to no DSAT. So this is actually a very useful system. This is something which anybody can actually apply. This no DSAT is not no desaturation, but it does actually, the acronym actually fits in. No DSAT is about nasal oxygen during the during securing of a tube, endotracheal tube. So the DSAT is during efforts. So nasal oxygen during efforts to secure a tube. So this is like giving a normal nasal oxygen along with whether it's a face mask, anesthetic circuit, or you're giving through the venturi mask. So I think it is more of that. So for example, you got a patient who is now, for emergency rapid sequence induction, you start nasal cannula, you start pre-oxygenating, and you start giving them 15 liters of oxygen as soon as you induce. And you maintain this oxygenation during laryngoscopy as well. Same thing at the end of the surgery, you increase the flows to 15 liters when the patient is waking up till they can tolerate that. Okay. And this will help in reducing the desaturation which happens. Okay. So how do you classify methods of oxygen therapy? Oxygen therapy can be classified into fixed performance devices, which is like the high flow venturi devices, or low flow, the anesthesia circuit. They can be divided into variable performance devices, which have no capacity, or they have capacity, which can be again small capacity and large capacity. The no capacity systems are the oxygen catheters and cannulas. As small capacities are the catheters like the cannula at high flows, oxygen flow, that is the high flow nasal oxygen therapy, or oxygen mask with venturi, without the venturi. A large capacity is like your venturi mask with reservoirs, the oxygen tanks, hoods, and incubators. These are the high or large capacity variable performance devices. So coming to this, the summary of it, I think it's very important to understand that is the oxygen therapy harmful? Yes, it can be. Denitrogenation of lungs is not good. it can lead to absorption atelectasis. So ensure that even when you are denaturalizing the lung for your rapid sequence induction, you can still use 80% oxygen. You can use no desat technique, and that actually helps in prolonging your efforts without leading to desaturation. Oxygen toxicity happens with hyperbaric therapy. That's another topic on its own. And what do you do when saturation falls? You increase the delivery, you increase the FI2, but this is to deal with a crisis. You need to understand why the oxygens are dropping. In ventilated patient, measure, ensure that you have recruitment of the collapsed alveoli, and look for the cause for the drop in saturation. Reduce the consumption. Is the patient adequately reversed? Is there hypothermia, or is there increased requirement because of shivering? So thank you very much for listening to the lectures. I'm ready to take the question if there is any, and I'm going to stop sharing the screen. And sorry for the disturbances because of my birthday.
Thank you, sir.
Thank you, Dr. Shiv.
We would like to tell.
Thank you, sir. Thank you very much.
I start listening to you, and there are a couple of questions on the chat box. I think
please.
Before we go further, Madam, do you have anything to speak, or should I just carry on with these questions?
So we would just like to apologize for the glitch that we had before. We could not introduce you earlier.
Doesn't matter. I'm Dr. G.D. Puri. I'm professor and head of department anesthesia, PGI Chandigarh. So don't worry.
Yes,
so
everybody
it's a
knows
very
this, sir.
topic. It's a very interesting topic, and it's one of the very practical topic in day-to-day emergency care of any patient, because we are the people who are intensivist and emergency care managers or the caregiver. So and oxygen therapy is a very major component of resuscitation. So knowing the various devices and the basis behind that, and the mechanisms of hypoxia, I think you're very clearly elucidated. Now, before I go further, there are questions please clarify chest tube insertion space. Is it?
Oh no, that is not mine. That is the question which was, I think.
Okay. Okay, fine. Now I will just try to ask a question from my side. As you have very well explained the role of the lungs, the shunt fraction, the other cardiac output, I just want to discuss about the role of cardiac output. You talked about the cardiac output as oxygen flux. How does the cardiac output affects the shunt fraction or the hypoxia? Just the cardiac output as such.
So for that, I think
for the listeners to understand. I'm sure.
So one of the things I think this need to be have discussed in the respiratory physiology. I don't know if they're covering or not. You need to know about the West zones as well. So you know that there are zones within the lungs, and it is the lowest part of the lung where the ventilation perfusion actually happens. So it's like you have got a gradient. The heart need to pump. If this gradient is low, you can have lungs which are, the lungs are filled up. The alveoli on the top are easy to fill up, but there is no perfusion happening. So if there's not enough cardiac output to pump this blood up, your ventilation perfusion is going to get affected by it. So it doesn't actually increase the shunt, it actually increases the dead space. The shunting occurs when you are actually preventing the flow, that's at the capillary level. So you have to be very clear, the shunting happens because of the alveoli collapsing for atelectasis, basis of the lungs, depending on how the lungs are. So shunt is about the wasted ventilation. The blood is not able to exchange gases, not able to take up oxygen, not able to deliver the carbon dioxide to wash out. That's shunt. But if your cardiac output is low, they will be part of the lungs which are ventilated but not perfused. So there is So low cardiac output will increase your dead space, okay, the physiological dead space.
Yeah, I think I just want to add here that the low cardiac output, as you explained, the dead space effect increases. At the same time, for whenever the cardiac output decreases, the mixed venous oxygen decreases, and for any shunt effect, the alveolar to arterial oxygen tension gradient also increases. So the effect of given FiO2 improves if the cardiac output is better. So I think this cardiac output is very essential, as you have highlighted. That just giving oxygen, well, it is important. But we need to ensure that the cardiac output also should be good. Now, here, Dr. Shiv, what will be your choice of inotropes if you have to use in a patient who has been, having partial, having hypoxia? Now you are going to give inotropes. What will be your choice of inotropes? I think that the listeners will get some idea of the shunt which you have been explaining much easier.
So here you need to actually give. I mean, ideal thing is actually to give something. If you have to know what are the cause for drop in the cardiac output. Is it because it's hypovolemia? Okay, or is it because now you have filled up the patient, the cardiac contractility has to be improved? Or is it because the patient is going septic? You need to increase your SVR. So in theaters, we normally use just the vasopressors. We're not using inotropes as we would do it, because they're easily, all of us actually use vasopressors. We use ephedrine, we use metronidazole to increase the systemic vascular resistance. But again, it's very, very important to actually understand what is causing this drop in cardiac output. Is it because of hypovolemia? Is it because the patient is going acidotic? Is it because patient has had a cardiac event? So it's not what is your best one. It is this, what is the cause for your drop in the cardiac output and contractility? And here again, one practical tip I will actually give people. And this is, even if you things are not going, they're not going bad, everything is going fine, and you're still actually having hypertension. One of the things which is usually avoided in patients with chronic diseases and patients who have poor nutrition is calcium. This we have seen that hypercalcemia is very common in patients we have, and use calcium gluconate, right? And know the difference between calcium gluconate and calcium chloride. 10 mL of calcium chloride will provide you 8 millimoles of calcium, ionic calcium, whereas 10 mL of calcium gluconate only provides you 2 millimoles. So give around 30 to 40 mL in a bag of fluid, and you will see calcium increases the contractility of the heart as well as increases SVR. So it improves your blood pressure and cardiac output. Something which is very practical, as something which is always missed out by people. So if you have elderly patients, have patients who have chronic disease, patients who have poor nutrition, people who have been a little frail, okay, make sure if you can measure calcium levels, fantastic. Okay, but even if you actually can't measure, just give it. It causes no harm. Give it in a bag of fluid, and you will actually see the beneficial effects of the calcium.
Thank you, Dr. Shiv. I just want to highlight one other angle. You very rightly said the vasopressors is or maybe depending on what's the cause for low cardiac output. But we normally see about in septic shock, the cardiac output may be high, and so you need to give vasopressors.
Yes.
But I'll choose NRIDR as the first line.
I was just coming to that. NRIDR,
Yeah,
right.
because any vasodilators who have got any inotropes or vasopressors who have vasodilator action are going to increase the chances of shunt effect by dilating inhibiting the hypoxic pulmonary vasoconstriction which may be having. So that's I just wanted to,
absolutely, sir. Absolutely. I think even like I actually teach on my group, which has got 30,600 members now, and more teach that if you are looking at the best kind of a vasopressor, is noradrenaline or norepinephrine, we call it. You can actually give it even through peripheral lines. We use it in our place. You can mix 4 milligrams into 500 mLs and actually use it as a low concentration peripherally. And one of the greatest advantage of noradrenaline over other vasopressor is it's got some amount of beta effect as well. So it does improve a little bit of contractility as well. It's not greater than anything else, but it does actually have some beta effect and alpha effect. So it's, I think, a best agent, especially where we are thinking that there is vasodilation and a bit of cardiac output is affected by it.
Well, there is a question of how to treat shunting. I think it's a very, though looks a very simple question, but it's a very wide. But let's see how Shiv can very briefly tell how to.
Yeah, so I think I have actually, if they have listened to the lecture, they would have actually got the idea. You need to know the physiology of what exactly is shunt, isn't it? Shunt is happening because there is, wasted perfusion. So if you understand these two, is it a wasted ventilation? Is it a wasted perfusion? Wasted perfusion will only happen if the alveoli are going to collapse. There is atelectasis. So the problem is here is atelectasis for whatever reason. You need to prevent. And like I said, you need to maintain the FRC above the closing capacity. In a patient who is more than 65 years old, even in sitting up position, there is that, like, the graph is very, very important. In a patient who is more than 45 years, you lie them flat, the closing volume increases more than your FRC, they will be collapsed. You need to apply, even in a patient, a young patient who is lying down, you need to apply PEEP and maintain the functional residual capacity. If the patient is post-op, you need to have them sitting up. If the patient is developing infection, you need to make sure there's a chest physiotherapy, they're coughing out. You're maintaining humidification, post-op humidification is equally important. So do not leave them on dry oxygen for hours and hours. Okay, it's all right for giving nasal oxygen or venturi mask for about, half an hour, 1 hour. But if you are needed to go beyond that, give humidified oxygen. I did not talk about it. I didn't show this. This lecture actually doesn't end here. It is actually more, but I was restricted by time. I talk about the salt level, gel level within the lungs, about the ciliary action. Okay, there's a lot more. I can go on for a whole day on respiratory physiology and this, but how to restrict to oxygen therapy. So it's very simple. You need to actually make sure, in single word, that the patient does not develop atelectasis. One single word.
So there are not many other questions in the chat box. Here, as Dr. Shiv has said, ensure that the ventilation perfusion mismatch is minimized, whatever possible, whether by putting a CPAP or whether you're ensuring that you suck out the secretions, you ensure that the endotracheal tube is in the right place, and so on and so forth. And the things which we stressed was to ensure that for the oxygen delivery, you need to have good cardiac output. So make sure that the perfusion pressure as well as cardiac output is okay. So Dr. Anupama is getting jittery. Should we wind up, madam?
Yes, please. Thank you.
Yeah. Thank you, sir. I think all the doubts and basics of postgraduates must be clear after this extensive lecture and clarifications on all the small topics. And I would like Dr. M.D. Kaur ma'am to kindly thank both the experts of the field. Dr. M.D. Kaur ma'am, can you please conclude the session of this session? MD ma'am?
Yes, I'm there. Can you hear me?
Yes, ma'am. Yes.
Okay, I really actually thank Dr. Shiv and Dr. G.D. Puri sir for joining us in this PG assembly. It is actually, a lot of grace has been added by the presence of both the speaker and the chairperson. I again thank you and thank you so much. We close the session here with Dr. G.D. Puri's permission here, I think.
Thank you very much for giving me the opportunity, and thank you, Dr. Shiv. It's a pleasure listening to you. Thank you.
Thank you, sir. Thank you. Bye-bye. Bye.
Thank you, ma'am. So moving on to our next session. Before lunch, we have a small session on drugs, on long-acting and short-acting beta agonist, inhaled corticosteroids, and long-acting muscarinic antagonist, short-acting muscarinic antagonist. For this, we have a very good speaker with us, Dr. Deepak Verma. He is a medical officer in the Department of Anesthesia in ABVIMS and Dr. RML Hospital. And his areas of interest are pediatric anesthesia. We apologize for the slight change in the schedule. Let's begin with your lecture. We welcome you, Dr. Deepak.
Good afternoon, everyone. You all must have come across patients with respiratory distress, either due to asthma or COPD in ICUs, and at times dealt with intraoperative bronchospasm in OTs. Here comes vital role of various drugs administered using inhalers or nebulizers for relief of symptoms. Before discussing about these drugs in details, you should have knowledge about two important factors that determine the ease with which drug achieves target concentration while managing respiratory emergency cases. Number one is optimum particle size of inhaled drug, which is 1 to 5 micrometer. Second is the type of delivery devices used for administration of drugs. Basically, there are three types of devices. Number one is the pressurized metered dose inhaler. These devices are portable and easy to use. Chlorofluorocarbon inhalers has now been replaced by hydroxyfluoroalkane inhalers because they are ozone friendly. To increase the drug bioavailability to lungs and reduction of amount of drug deposition in oral cavity, spacer has been introduced between patient's mouth and metered dose inhaler. Second commonly used devices are nebulizers, which are of two types. One is the jet nebulizer, other one is the ultrasonic nebulizer. Both are used in cases of severe asthma or COPD. It is best suited for the use in children. Third commonly used devices are dry powder inhalers, which uses drugs in form of fine powder. However, children less than 7 years of age find difficult to use. For drug tables fiber, it should be kept in mind that a given drug should be described under following headings. That is, first the structure, then the mechanism of action, followed by pharmacodynamics, kinetics, clinical uses, side effects, and drug interactions. So today we'll quickly go through bullet points of commonly used drugs in inhalers and nebulizers either in OT or ICU. Starting with first drug, this is a pressurized meter dose inhaler of salbutamol which contains 200 meter doses and each puff delivers 100 microgram of drug. Salbutamol is a short-acting selective beta-2 agonist which produces bronchodilation within 5 minutes and action lasts for 4 hours. It is also known as albuterol, which is available in racemic mixture containing both R and S enantiomers. However, only R enantiomer is responsible for beta-2 agonist activity. Levosalbutamol contains only R enantiomers and thus have increased potency as compared to salbutamol. Salbutamol is available in different preparations. MDI doses is 1 to 2 puff every 4 to 6 hours. For nebulization purpose, 0.5 to 1 ml of 0.5% solution in 5 ml NS is added in jet nebulizers and is delivered every 15 minutes up to 3 to 4 doses. This is followed by every 4 to 6 hours until the symptoms resolves. There are other preparations like salbutamol tablets and injections. Beta-2 agonist attaches to the receptors in airways, causing bronchodilation by inhibiting neurotransmitters and inflammatory mediators. 10 to 20% of drug reaches to the lung when delivered through inhaler or nebulizer, while 80 to 90% get deposited in oral cavity, which undergoes first pass metabolism after absorption from gastrointestinal tract. Drugs entering into the circulation are responsible for systemic side effects. Short-acting beta-2 agonist is a drug of choice during exacerbation and intermittent asthma. It also prevents exercise-induced bronchospasm. Daily and chronic use of SABA is not recommended. It is also not effective in COPD. Drugs and its metabolites entering into circulation causes muscle tremor, tachycardia, temporary hypoxemia, metabolic and electrolyte abnormalities, that is hypokalemia and hypomagnesemia. Now coming to identification of second group of drug. This is a metered dose inhaler of salmeterol, which contains 120 metered doses, and each puff delivers 25 microgram of drug. It is also available in form of rota capsules, and each capsule contains 50 microgram of salmeterol. Salmeterol is a long-acting selective beta-2 agonist which causes bronchodilation within 15 minutes and action lasts for 12 hours. Dose is 50 to 100 microgram twice daily. Newly developed ultra-long-acting drug is effective for 24 hours after single dose and are used for COPD cases. Long-acting beta-2 agonist is not used as monotherapy in asthma for long-term control. Combinations of long-acting beta agonist and inhaled steroids is most effective in treatment of asthma due to synergistic action. It also prevents exercise-induced bronchospasm and provides longer protection than shorter-acting beta agonist. Combinations with antimuscarinic and inhaled corticosteroid also reduces air trapping and exacerbations. These are the various available preparations of long-acting beta agonists and inhaled steroids. Mechanism of action, drug metabolism and side effects are similar to SABA. Downregulation of beta-2 receptors occurs due to prolonged treatment with beta-2 receptors. It develops over days or weeks. It is an autoregulatory process occurring either due to uncoupling of receptors from adenylate cyclase or due to internalization of uncoupled receptors. Now coming to third group of drugs, that is inhaled steroids. Two commonly used inhaled steroids are fluticasone and budesonide. Fluticasone are available in two salts, that is fluticasone propionate and fluticasone furoate. They are available in different forms of MDI, DPI in various strength of 50, 100 and 250 microgram per puff. Budesonide is also available in form of MDI, DPI and respues. Both drugs are available in combinations with long-acting beta agonist. It primarily acts on inflammatory mediators, thus promoting anti-inflammatory actions on respiratory tract. Drug metabolism are similar to inhaled beta-2 agonist. Inhaled steroids are used as first-line therapy in patients with persistent asthma. It is recommended in treatment of COPD and reduces number of exacerbations. It is also recommended in COVID patients with ongoing symptoms aged more than 65 years or more than 50 years with comorbidities for at least a week. Local side effect includes pharyngitis, dysphonia, reflex cough, oropharyngeal candidiasis, xerostomia, and taste perception change. This occurs due to deposition of drugs within oral cavity during nebulization. This can be avoided by rinsing oral cavity with water after inhalation. Systemic side effects include adrenal insufficiency, adrenal suppression, growth retardation, osteoporosis, diabetes, cataract, and glaucoma. Now coming to identification of fourth group of drug, this is a meter dose inhaler containing 20 microgram per puff of ipratropium bromide. It is short-acting inhaled antimuscarinic drug and is also available in combination with salbutamol. It has a gradual onset and late peak at 30 to 60 minutes, and action lasts for 6 to 8 hours. It attaches to muscarinic receptors and thus prevents cholinergic mediated bronchoconstriction. It also inhibits vagal mediated airway tone, causing bronchodilation. Drug metabolism is similar to inhaled beta-2 agonist. It is used as a rescue therapy in asthma and COPD. It is also used as maintenance therapy in COPD, but not in asthma. Local side effects like bitter taste, glaucoma, dryness of mouth occurs due to deposition of drug on eye and oral cavity respectively during nebulization. Systemic side effects are those similar to atropine. It can be easily remembered as 9Ds, that is, dryness of mouth and throat, dilatation of pupil, dry hot skin, delirium, drowsiness, dysphagia, difficulty in talking, and drunken gait. Now coming to identification of fifth group of drug. This is a meter dose inhaler containing tiotropium bromide, and each puff delivers 9 microgram of drug. It is a long-acting muscarinic antagonist and is also available in dry powder inhaler form. It is also available in combinations with long-acting beta agonist. Long-acting muscarinic antagonist is indicated for maintenance therapy in asthma and COPD, either as monotherapy or in combinations. Mechanism of actions, drug metabolism, and side effects are similar to short-acting muscarinic antagonist. So take-home message is, inhaled bronchodilators are key to symptomatic management of asthma and COPD. Regular and as-needed doses of short-acting beta agonist and muscarinic antagonist improves acute symptoms. Combinations of short-acting beta agonist and muscarinic antagonist is superior in comparison to monotherapy. Similar benefits are seen with combinations of long-acting beta agonist and long-acting muscarinic antagonist. Combinations of long-acting beta agonist and muscarinic antagonist have greater effect on exacerbation reduction on comparing with monotherapy. And among monotherapy drugs, LAMA have greater therapeutic efficacy. Thank you.
Thank you, Dr. Deepak. That was a very well delivered talk. I hope all the doubts on the drugs must have been clear of the delegates. And we do not have any questions on the talk. We thank you for such a good talk, Dr. Deepak. So
Thank you, ma'am.
Before breaking for lunch, we have MCQs. Two MCQs will be shown in your link, and kindly answer in the chat box. And we'll resume the session after 15 minutes of lunch break. Can we have the questions? Thank you. Next session will start at around 2:45, 2:50. Thank you.
And I just talked to sir, he'll be asking to
Really? We welcome you back after the lunch session. So let's begin with another exciting session. This is a live case presentation. As you all know, that long case is the one which scores the maximum marks in the exam, in the practical exam. And to master the viva of a long case, if you master it, it will be very useful for your exams. So for this particular case presentation, we have a very popular speaker, very popular examiner, Dr. Nishkash Gupta, sir. Sir is additional professor at the Department of Onco-Anesthesiology and Palliative Care, All India Institute of Medical Sciences. His area of interest are palliative care, onco-anesthesia, and skill training. Sir has received many awards, and he has received recently an award for excellence in research by ISA in 2021. He has received the Reviewer Award by IJA in 2021. And he has edited Palliative Care Case-Based Discussion by Oxford. He is an editor of Clinical Anesthesia by Barash. He is an editor of South Asian edition of DOSH and DOSH. And he has publications of more than 200 in various indexed national and international journals. We extend a warm welcome to you, sir. To coordinate with Dr. Nishkash, we have, and with the postgraduate, we have Dr. Nitin Chaudhary. He is assistant professor at ABVIMS and Dr. RML Hospital. His area of interest are pediatric and obstetric anesthesia. We welcome you, Dr. Nitin. And we have our postgraduate, Dr. Ajita, third year postgraduate, who will be presenting the details. I hand over to the session to Dr. Nishkash.
Thank you, Anupama. So we'll be having a case discussion of pneumonectomy. Am I audible? It is clear?
Yes, sir. Yes, sir. You're audible, so very much audible.
Before we start, thank the organizers, Dr. Kaur ma'am, for giving this opportunity. So during this next 90 minutes, we will try to cover this case and example. There is some background noise. So we'll start with Nidhi. So Nidhi is a postgraduate in our for case discussion. So she will present a history. नाम गलत लिखा है. Hello.
So Dr. Achita.
Actually, इसका नाम उसमें नहीं लिखा हुआ है. So Achita will start the case discussion and then we'll proceed. We'll take it as a viva case. Suppose you have this is a long case if it is available, and it will be covering all the possible aspects of a thoracotomy, whether it is esophageal dissection or we are taking case of a lobectomy, which is being posted. So we'll go from the history point of view. Ajita, please start.
Yes, sir. Good afternoon, sir. I'm going to present a case of Mr. Rakesh, a 50-year-old male, resident of Carol Bagh, who is a daily laborer by occupation, belonging to lower socioeconomic status, presented to RML OPD with the chief complaints of cough with expectoration for the past 10 months, breathlessness for the past 8 months. Patient was apparently asymptomatic before 10 months. Then he developed cough, which was gradual in onset and progressive in nature, associated with expectoration, which was initially white-colored serous in nature, copious in amount as described by the patient, and it was blood tinged for the past 1 week. There is no postural, diurnal, and seasonal variation. The cough is associated with breathlessness for the past 8 months, which was gradual in onset, progressive in nature, aggravated on exertion. He is having shortness of breath when walking at his own pace. No history of any nocturnal awakening to breathlessness and breathlessness on lying down. History of loss of appetite for the past 6 months, associated with loss of weight of around 10 kg for the past 3 months. No history of chest pain, palpitation, or syncope. No history of evening rise of temperature, fever with chills and rigor. No history of hoarseness of voice or difficulty in swallowing. No history of any bone pain, muscle pain, swelling of legs. No history of yellowish discoloration of skin, sclera, abdominal pain, headache, and seizure. No history of nausea, vomiting, confusion, easy bruising, weakness, and frequent urination. Past history, patient is not a known case of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, epilepsy or thyroid. No history of any previous surgery or previous anesthesia exposure. Any hospital admission and drug allergy. No history of any blood transfusion. No history of any recent COVID infection. Personal history, patient is a known smoker for the past 30 years. He smokes around 18 to 20 cigarettes per day, one pack, which is one pack for the past 30 years with a pack year of 30 and smoking index of 600. He is not a known alcoholic, is a mixed diet taker, normal sleep habits, normal bowel and bladder habits. Treatment history, patient is on salbutamol and ipratropium bromide inhaler for the past 8 months. He takes 2 puffs 2 times a day. Family history, there's no relevant family history. He is working as a daily laborer in a textile factory for the past 25 years. On examination,
Before we move to examination, so based on the history, what are the salient points and what is the most likely diagnosis based on the history?
Sir, from the history, patient is having chronic symptoms like cough and cough with expectoration and breathlessness for the past 10 months. And also he's a smoker and works in a textile factory. So most probably my primary diagnosis would be like pneumonia or primary tuberculosis or any interstitial lung disease and primary lung malignancy.
So basically, classically, the patient has no breathlessness. There is a history of smoking, which is very, very kind of positive, and patient has loss of weight, loss of appetite.
Yes,
so these are the possible diagnoses. So if you have to classify as 1, 2, 3, which is most likely? So you have said them correctly. So you may have COPD or asthma. You may, because patient has history of textile factory work also, no?
Yes,
so they have interstitial disease component because of some inhalation of local things, and patient might have tuberculosis, the weight loss and loss of appetite, and a malignancy is a possibility. So if you have to grade 1, 2, 3, what will be the first likely diagnosis?
So my first would be tuberculosis, since it is common in India. And my second would be lung malignancy or interstitial lung diseases.
So you talked about smoking pack years and smoking index. So what actually do we mean by that? How do you calculate and what is the significance of this?
So pack years we calculate by number of packets of cigarettes smoked per day into total duration in year. If it is more than 40 pack years, patient is high risk of bronchogenic carcinoma and other pulmonary complications. In smoking index is number of cigarettes smoked per day into total duration in years. It is classified as mild, moderate and severe smoker. If it is less than 100, it's a mild, 100 to 300 is moderate, and more than 300 is severe.
So, so a patient is in high risk category with respect to cigarette smoking as well.
Yes, sir.
And you said a patient had breathlessness also. So how did you check breathlessness, the severity of breathlessness? What are the scores available for that?
Sir, it's based on modified medical research counseling grading. According to that, dyspnea is graded into 5 grades. Grade 0, breathlessness with sterness exercise. Grade 1, breathlessness when walking, when hurrying on a level ground or walking up a slight hill. Grade 2, walk slower than the people of same age because of breathlessness or has to stop for breath when walking at a own pace. Grade 3, breathlessness after walking about 100 meters. Grade 4 is breathlessness at rest.
So one important more thing, let us come to the confirm the findings of history on examination, then we'll discuss further. So what are the examination findings?
Yes. On examination, patient is conscious, well oriented to time, place and person. He is thin built with a weight of 50 kg, height of 160 centimeter, with a BMI of 19.5. Patient is adequately hydrated and venous access present. Pella present, clubbing present, which is of grade 2. No cyanosis or icterus or pedal edema or lymphadenopathy. Vitals, his pulse rate is 80 beats per minute measured in the radial artery, which is a regular rhythm, normal volume and character, no radial or radiofemoral delay, no vessel wall thickening felt in all palpable peripheral vessel. Respiratory rate is 16 beats per minute. It is abdominothoracic type, no chest wall retraction or use of accessory muscles of respiration. Blood pressure is 110/70 mmHg measured in the right arm in sitting posture. Temperature is afebrile, JVP not elevated, no engorgement of veins over face and neck. Airway examination, no obvious deformity of the face, neck, nose, eyes, mandible, and ears. Both nostrils are normal and patent. Oral hygiene is poor. No artificial tooth or buck tooth or loose tooth. Mouth opening is adequate, more than 5 centimeter. Thyromental, hyomental, and stenomental distance are within normal limit. Neck movements are normal. No retrognathia. Temporomandibular joint mobility adequate. Modified Mallampati grade 1. Bedside PFT, breath holding time is 25 seconds. Single breath count is 25. Forced expiratory time is 6 seconds. Snyder match blow test, he is able to blow the candle at 6 inch. Systemic examination, respiratory system. On inspection, shape of the chest was normal and bilateral chest movements are equal. Trachea appears to be in the midline. Shoulders are symmetrical. Chest wall appears normal. No intercostal retraction or flattening or bulging. No dilated vein, pulsation, scars, skin appendages. On palpation, trachea is in the midline, no tenderness over the chest wall. Chest expansion reduced on the right side. Chest wall diameter, AP diameter is 28 centimeter, transverse diameter is 26 centimeter, the ratio of 5:7. Tactile local firmitas increased on the right side when compared to the left. On percussion, normal resonant note is noted on the right upper zone and left lung, whereas dull note is noted on the right middle and lower zone. On auscultation, reduced air entry on right middle and lower zone, no added sounds. Cardiovascular system, on inspection, apical impulse not seen, no precordial bulging. Palpation, apical impulse felt on the left fifth intercostal space, half an inch medial to the mid-clavicular line, no palpable thrill or murmur, no parasternal leaf. Percussion not done, auscultation S1, S2 heard, no added sounds. Abdomen, shape of the abdomen was normal, flanks free, all quadrant moves equally with respiration, umbilicus is central and normal, palpation, no palpable mass or organomegaly, auscultation, bowel sounds heard. CNS examination, no focal neurological deficit, higher mental functions were normal, cranial nerve, motor and sensory functions are normal, spine, normal curvature of the spine with no obvious deformity.
Okay. So on this clinical examination, so what do you think now? What is most likely? What is the diagnosis after history and examination?
So patient, because on examination, the vocal parameters are increased on the right side and also dull note on percussion. These suggestive of probably consolidation over the right lower limb. So I'd like to investigate further to confirm the diagnosis.
So we started with the diagnosis of a tuberculosis or a malignancy to begin with, and there's some kind of consolidation, some mass or some kind of old head lesion which is leading to this. So we have to confirm with the finding.
Yes.
What are the investigations you want to do?
Sir, I'll go for complete hemogram, which include hemoglobin, total leukocyte count, differential leukocyte count, and platelet count, and go for kidney function test, which include blood urea, serum creatinine, and also serum electrolytes, and liver function test, including total protein and albumin, and coagulation profile, chest X-ray, and 12-lead ECG, and spirometry, and CT chest, and 2D echo.
Okay. So what were the findings in your case? Hello. Okay. So suppose we did this.
Yes, sir.
So why do you want to get a hemogram done? No, why do we actually need a hemogram in this specific case? So we suspect a malignancy and patient has maybe posted for a lung resection surgery. So why do we want a hemogram?
Sir, hemoglobin, basically patient is a COPD patient. So there is a chance of polycythemia, and total leukocyte count, there are more chance of infections. To see whether for that I have to.
Definitely, and in fact, if you're talking about tuberculosis and malignancy, the nutritional status may also be impaired. No, he compared kind of loss of appetite, so that might also be there. If we find it is low, then we need to do something to improve before posting for a major surgery.
Yes, sir.
Okay. Suppose this patient had chronic smoking history, so there might be some changes suggestive of COPD as well. So, what are the classical signs you were likely to see on an X-ray if patient had lung changes because of smoking and long-standing COPD?
Sir, in COPD there will be flattening of ribs and flattening of diaphragm and horizontal ribs, tubular chest, hyperinflated lung fields will be there in case of COPD.
Okay. Because so this you have got, and in the liver functions you mentioned proteins. So why do we need the protein? What is the significance of getting serum albumin and total protein in this case?
So to assess the nutritional status and also if in laboratory parameters, if albumin is less than 3.5, there is increased risk of post-op pulmonary complications. For that I have to.
So this case can had showed a large kind of mass in the lung and patient was posted for a pneumonectomy.
Yes, sir.
So you told this patient is a chronic smoker, so he had 30 packets, you said? So how many packets?
30, sir. 30 packets.
So what is the significance of smoking? What are the possible changes which might occur because of smoking, and what do we do about them?
Yes, sir. Smoke contains particulate and gaseous phase. In particulate phase, nicotine is the main component. That nicotine stimulates adrenal medulla and also autonomic ganglia and increases the sympathetic activity. Because of that, there will be increase in heart rate, systolic, diastolic, mean arterial pressure, and also peripheral vascular resistance. So there will be imbalance of myocardial oxygen supply and demand ratio. So they're more prone for ischemia during the periop period. And also smoke contains carboxyhemoglobin, which binds with hemoglobin with increased affinity. Carbon monoxide, which binds with hemoglobin with increased affinity, and also carbon monoxide itself causes arrhythmia. Because of increased affinity, it shifts the oxygen hemoglobin dissociation curve to the left, which leads to chronic tissue hypoxia. And in respiratory system, the irritants in the smoke stimulates mucus production. The mucus become hyperviscous, and also the ciliatoxins will damage the cilia. So there will be decreased tracheobronchial clearance. And the irritants will stimulate the subepithelial receptors, and there will be increased airway reactivity. And also there will be narrowing of the smaller airways and decreased surfactant production. The electrolytic enzymes will destroy the alveoli and leading to emphysema. In gastrointestinal system, it relaxes the lower esophageal sphincter, so they are more prone for aspiration. And also it suppresses the alveolar macrophages, and they are more prone for infection and poor wound healing and all. It also increases RBC, WBC platelets, so there will be increased chance of coagulability. So they are more prone for arterial thromboembolism and also coronary artery disease.
So we know, so there are a lot of changes which might occur because of smoking. So what do we do now? This patient is a possible malignancy, confirmed malignancy on a CT scan. The biopsy is done. This is suggestive of malignancy. So what do we do? So do we stop smoking, and how many days we need to stop it before these changes kind of revert and the patient is risk free because of smoking?
I would ask the patient to quit smoking as soon as possible. Ideally, it should be stopped within 12 to 24 hours. The carbon monoxide and nicotine levels will decrease, and with 48 to 72 hours, there will be increased tracheobronchial clearance. And 1 to 2 weeks, there will be decreased sputum production. 4 to 6 weeks, PFTs improve, and 8 to 12 weeks, there is a decreased risk of post-op morbidity and mortality.
So basically, we'll have to ideally wait for about 8 weeks before all changes are reverted. But so you may have to discuss with the surgical team regarding the possibility of balancing the risk of smoking and delaying surgery for that much time. So you will have to take a call, and how much depending on the possibility whether it is 2 days or 2 weeks or 4 weeks, whatever is feasible should be done, because at least some kind of reversibility of some changes will be there. So that will have an added advantage for managing this patient. Okay, so now, so what are the other things specifically you look for in the pre-anesthetic evaluation with respect to other systems like, so respiratory we discussed. So what are the other investigations you want to do, considering this is a pneumonectomy case posted for surgery?
Investigations, sir.
From the evaluation with respect to respiratory system, in addition to whatever we have written here. So what are the specific investigations for respiratory system you would like to do?
Sir, for assessment of lung resection, there is a 3-leg stool approach for respiratory system, which involve assessment of respiratory mechanics, lung parenchymal function, and cardiopulmonary interaction. So I will do a spirometry done. For respiratory mechanical function, I would calculate predicted post-operative FEV1. If it is more than 40, low risk, patient is at low risk. 30 to 40, increased risk. If it is less than 30%, then patient is at high risk. For lung parenchymal function, I would do predicted post-operative DLCO. If it is more than 40, it's a low risk. 30 to 40, increased risk. Less than 30 is high risk. For cardiopulmonary interaction, maximal oxygen consumption, that will be calculated. If it is less than 15 ml per kg per minute, then patient is at high risk, and less than increased risk, and less than 10, patient is at high risk.
So how do you calculate this VO2 max? How do you calculate this VO2 max?
Sir,
Maximum.
yes, sir. The gold standard is the laboratory evaluation of VO2 consumption, but other surrogative tests are available, like stair climbing test, shuttle walk test, 6-minute walk test, and exercise oximetry.
So can you elaborate about 6-minute walk test and how do we interpret the results?
Sir, we'll ask the patient to walk for 6 minutes at his own pace level, and the distance covered by distance that he covered in 6 minutes divided by 30 gives us the amount of like how much the VO2 consumption is.
So you have to be specific. The distance.
If it is,
it has to be a flat surface. Patient should be walking at his normal speed, and the distance is measured in meters. So the meters he travels. What is the other thing which we do in 6-minute walk test specifically we look for, and we if it is there then we think it is more riskier to operate in such patients?
yes, sir, in 6-minute walk, if he covers less than 400 meter, then his VO2 is less than 10 ml per kg per minute, 15 ml per kg per minute.
And also if there is a decrease more than 4% during the test, so risk of complications is much more. So we put a pulse oximetry on the patient and we also measure the change in the saturation levels. Okay, you talked about stair climbing test. So how do we know specifically about the VO2 max with stair climbing?
So for a pulmonary resection, at least climbing two flight of stairs is minimal. So one flight of stairs is almost 10 feet, 3 meters. So if he able to climb one flight of stairs, his METs will be almost 4 METs.
So it says about two flight of stairs is about VO2 max corresponds to about 12 ml per minute. So
Yes, sir.
ideally it should be, if we are targeting 20 to 5 flight of stairs, the person should be able to do without much. Okay, so these are the basically surrogate markers. So we have nowadays a lot of CPET is also available. This is cardiopulmonary exercise testing, so which will objectively measure the VO2 max of the patient, and if available, that should be done. But if it is not available, these tests should be done, and they will help you to understand regarding the patient. So then we talked about predictive. You have written predictive value. No, there's something called a post-operative predictive FEV1.
Yes, sir.
How do we calculate that, and what is the significance of post-operative FEV1 values in these patients?
So to assess the respiratory mechanics, we are calculating predicted post-operative FEV1, which is calculated by pre-operative FEV1 into 1 minus percentage of functional lung segments removed divided by 100.
Okay. So how many lung segments are in the right lung and left? So this is a pneumonectomy, no? So one lung is removed. So what do you expect? Total lung segments, how do we calculate?
So right lung is divided into 3. Upper lobe is 6, and middle is 4, and lower is 12. And left side is divided into 2, 10 for upper and 10 for lower.
So about 42 segments.
It's a total 42 segments.
So if one lung is removed, so 50% of it roughly. Okay, so if it is 2.4, so the predictive will, you have to calculate the predictive, and if it is less than 30%, it will be difficult for you to take up the patient for surgery. Okay, so any of the specific changes in the because it is a malignancy, no? There might be malignancy which will we have to specifically look for in the history examination and the CT scan. So what are those changes which we are worried about?
Sir, yes, sir. In malignancy, there are 4 M's which we have to look up. First is metastasis. Metastasis to any liver, adrenal, bone, and brain. And medications, patient must be taking chemotherapy and its complications have to be ruled out. Then there will be mass effects like obstruction, cavity formation, superior vena cava syndrome, or any chest wall extension and all. Then metabolic effects because of paraneoplastic syndromes. There will be Lambert-Eaton syndrome, hypercalcemia, hyponatremia, or Cushing's. These things we have to rule out in history and examination.
Have to mostly you have covered the changes, so but you must specifically have in mind that these are the possible reasons why we are taking the history, so that if you find some finding, you have to modify the plan accordingly. Okay, so something about can you tell me something about ventilation perfusion scanning? So what is it about and what do we do in it?
So ventilation perfusion scan is basically determines amount of ventilation or perfusion that is contributed by the lung which we are removed, so that we can determine how much the ventilation or perfusion that the lung which we are removing will contribute it.
Okay, so now this patient done the PAC and patient has the pre-posted for pneumonicty. You have to put in the PAC orders. So what do you want to put on the what are the particular specific things you will look into it, and what are the orders in the pre-anesthetic checkup you will give to the patient?
So first I'll ask quit smoking and nil per oral orders I'll write. Then return informed iris concern explaining about the procedure and need of post-op ventilation, and also I'll explain about the analgesia plan of analgesia, and I'll arrange adequate blood and blood products, and I'll ask the patient to continue the inhaler which he is taking. Yes.
Anything else? So no, you have to prepare the patient for surgery also. So you can start kind of incentive spirometry.
Yes,
I
sir.
tell you about incentive spirometry, and because this has to be done in the post-op period as well. So depending on the patient's condition, so you have to educate them about that, and so that they can be continued in the post-op period. And also, from your point of view, what is the should we advise regarding anxiety and glycopyrrolate for this patient? What is your take on giving anxiolytic routinely and
Yes.
to these patients?
Yes, sir. On the day of surgery, I would give glycopyrrolate to decrease the secretions.
Well, glycopyrrolate is something which is kind of debatable. Either way, but it depends on the patient. So the advantage is that you will have less secretions, and bronchoscopy you eventually do for confirming lung isolation will be better. But it has its own disadvantages. So you can do as per institutional protocol. Similarly, for anxiolysis, if you find patient is anxious and there is a need of giving alprazolam or some shorter acting drug, that can be given to the patient. Okay. So, what is your anesthetic plan? So we have given pre-op orders. So surgeons you have discussed. So they say about they can wait for about 2 weeks. So in 2 weeks you have stopped smoking and try to start incentive spirometry, and patient has now been posted for surgery. So what is your plan for surgery? What anesthesia you want to plan?
So my plan of anesthesia would be general anesthesia with control endotracheal intubation with double lumen tube and control mechanical one lung ventilation.
Okay. So and what you want to give for analgesia? You talked about regional anesthesia for the patient. What is the plan for analgesia to the patient?
Sir, my plan would be thoracic epidural analgesia.
Suppose this patient says he is not willing for a thoracic epidural. He had some kind of surgery some year back, and he has some backache, so he's afraid of getting a thoracic epidural being placed. So what do you do?
So first I'll counsel the patient regarding the importance of analgesia, and if that is if no contraindications are there, then I'll counsel him and I'll go for thoracic epidural, or else I'll explain him the other approaches, other modes of analgesia like IV medication.
What are the other possibilities? If we are not able to give a thoracic epidural or patient is not willing, so what are the other possibilities which we can consider in these patients?
Sir, IV systemic opioids and anti-inflammatory drugs, and also other blocks like paravertebral block and erector spinae block and serratus anterior plane block.
So depending on the feasibility and patient acceptance, so you do a combination of a regional block and a combination of analgesic drugs starting with NSAIDs to reduce the pain in the perioperative period. Okay, that's. And what else? So you said you will want to do a put in a double lumen tube in this patient.
Yes, sir.
How do you calculate the size of double lumen tube? What size you want to use?
Sir, it's based on the height. If it is adult female, less than 160 centimeter, 35 French. If it is more than 160 centimeter, it's 37 French. In adult male, more than 170 centimeters, 41 French, and less than 170 centimeters, 39 French. In adult male, less than 160 centimeter, 35 French. In adult female, less than 152 centimeters, 32 French.
In this patient, what will be the size you will be using?
Sir, it's 170 centimeter. I'll go for 39 French.
Any other this is a rough idea, no? Calculation based on the height.
Yes,
So we have a better method of assessing the size of the
yes, sir. In CT, I'll measure the diameter of the left, whichever side bronchial diameter, and according to that, I'll calculate.
Okay, so that will be more objective way, and you can measure the outer diameter. It is usually given, and you can just calculate which one is an appropriate size. Suppose this was a child, the patient was a child. So what are the other options we have for lung isolation?
So bronchial blockers can be used, or endobronchial tubes are available, or endotracheal tube inserted endobronchially.
Okay.
In child, I would prefer bronchial blockers.
What all blockers you know of?
Sir, and Fuji, EZ, and Cohen.
So I believe this has been discussed in the previous session, so we'll not go into much details. But yes, you must know about the possibility of putting in a bronchial blocker in case DLT is not feasible for some reason, or it is not appropriate size is not available. Okay, so once we are inserting a double lumen tube. So which side you will prefer, right side or left side? Which DLT you will prefer?
Sir, I'll prefer left-sided DLT.
Why?
Because it has more margin of safety.
What is this margin of safety we are talking about?
Sir, it is the length of tracheobronchial tree over which the DLT tube can be manipulated without causing any obstruction to the airway or lobar.
Because on the right side you will have a pickup of the right upper bronchus. So
yes,
the distance between the carina and the upper bronchus is much lesser and less predictable. So the chance of hypoxia much more tend to miss it, and it may lead to problems. Okay. So tell me something about, so we are planning one lung ventilation in a child in this patient for thoracotomy. So what all things you will arrange in the operation theater when you are planning this case? So
yes, sir. First, I'll get my OT ready by checking the temperature of the OT, and I'll keep the temperature warm. Then I'll check suction, oxygen, anesthetic machine, and emergency drugs and all anesthetic induction drugs, which will be diluted according to the weight. And also I'll check the bronchoscopy and other airway equipments. Difficult airway cart will be checked. After arranging everything, I'll wheel in the patient.
So once you wheel in the patient, what monitors do you want to put?
Yes, sir. After taking the patient into OT table, I'll attach all standard ASA monitor, 5-lead ECG, and non-invasive blood pressure and pulse oximetry. Then I'll secure a large bore IV cannula, and I'll start the IV fluids. Then after explaining the procedure, I'll make the patient to sit. I'll secure a thoracic epidural in a sitting position at the level of T4 to T5. Then after securing, I'll give the test dose and I'll ask the patient to lie down. Then I'll induce the patient.
Okay, so what test dose you want to give?
Sir, lignocaine and ADR. Lignocaine is 45 mg and ADR is 15 mics.
So what does it do? What does test dose do?
Sir, to see whether the placement is intrathecal or intravascular. If it is intravascular, there will be increase in heart rate and blood pressure. If it is intrathecal, patient will come. Since patient is awake, he'll complain of symptoms of local anesthetic toxicity.
Okay. So now, so we know that the patient will be operated upon. There will be thoracotomy, so there will be open chest. So there are some changes you might expect in a patient, especially under GA. So what are those changes which may occur in doing ventilation to ventilation and perfusion in patients with open chest? In a spontaneously breathing patient, and how it is different in a patient who is on controlled ventilation?
So in open chest, in spontaneously breathing patient in lateral position, the ventilation will be increased in non-dependent lung by 10%, and perfusion will be more in the dependent lung because of gravity. And in anesthetized patient, open chest, the same non-dependent lung will receive more ventilation, and dependent lung will receive more perfusion, thereby resulting in ventricular ventilation perfusion mismatch.
Okay, so now you want to anesthetize this patient. So before we go, we discussed about possibilities of one lung isolation. Nowadays we have a Viva side DLT also. So there's a camera fitted in the double lumen tube, so which can help you place the tube more precisely. Okay, so now we have anesthetized this patient. So what drugs you want to give on the table? So we have put in an IV line, large bore, say for 18 gauge or 16 gauge, whatever you prefer. So what next? What drug you want to give first?
So first I'll pre-oxygenate the patient with 100% oxygen for 3 minutes. Then I'll give injection midazolam 1 mg.
The procedure of pre-oxygenation. So what is the prerequisite? How much flows you put on the machine?
Sir, I'll keep the flow at 10 liter, and I'll pre-oxygenate for 3 minutes with the normal tidal respiration.
What is the objective endpoint of oxygenation? When do we say the pre-oxygenation is?
Sir, when end tidal oxygen concentration more than 90%.
Yes, so that will be better considering the patient has a borderline lung and you are putting in a DLT. So it will be better you have a good pre-oxygenation status. Okay, so we have pre-oxygenated the patient. What next?
Then I'll give injection midazolam 1 mg IV. Then injection fentanyl 100 mics in it slowly. Then my induction agent of choice would be propofol. I'll give injection propofol in a titrated doses. After checking mask ventilation, then I'll give injection vecuronium 5 mg IV. Then I'll secure under direct laryngoscope. I will secure the double lumen tube.
So you have put in a double lumen tube now. So how do you confirm that the tube is in the right place?
The confirmation is done by clinically by auscultation and fiber optic bronchoscope. First, by auscultation, 3-step approach. After inserting the tube, I'll inflate the tracheal lumen and confirm the bilateral ventilation. Then I'll clamp the tracheal lumen and open the tracheal cap. Then I'll inflate the bronchial lumen, bronchial cuff accordingly. Then I'll auscultate for unilateral ventilation. Then I'll remove the tracheal cap and tracheal clamp and close the tracheal cap and confirm for bilateral ventilation. And also by fiber optic.
So what do you see in the fiber optic bronchoscopy to ascertain that it is placed correctly?
Yes, if first I'll insert the bronchoscope through the tracheal lumen. If the tube is placed in the left side, I'll just at the level of carina, while entering the left side tube should be just visible. The cuff should be just visible, almost 5 to 10 mm below the carina.
Just visible below the carina, I'm not able to get you. So you want to.
Or if it is.
The cuff of the bronchial lumen should be inflated or deflated when you're doing this procedure?
Inflated.
So you want to see just below the carina, okay?
Yes.
Difficult to measure. It is 5 millimeter or 10 millimeter. That will be difficult. Okay, then you insert bronchial lumen.
Yes, sir. I'll insert into bronchial lumen and then I'll see for the right side. I'll go for the right upper lobe and there will be 3 divisions to confirm whether it is upper lobe. Then I'll see the right middle and lower lobe openings.
Okay, so we have confirmed that. Anything else you want to do to confirm any leak? Some leak test is there specifically to find any leakage? No. Leave it. So once you are doing it, so you have to ensure that the upper lung has to be completely blocked and you have to disconnect from the ventilation so that isolation is complete. Otherwise, if you keep ventilating, it will be difficult for you. You have to clamp it properly.
Yes, sir.
So now you have patient. So we have put in a DLT. We have appropriately fixed. Any other monitoring you want to put in this patient specifically, since it is a pneumonectomy and posted for a long thoracic?
Sir. Sir, end-tidal carbon dioxide monitoring and temperature monitoring and urine output monitoring.
What else?
Sir, I'll secure an invasive arterial line and for bit-to-bit monitoring and also for ABG.
So, okay, so ABG. So, how frequently you plan to do the ABG?
Sir, every 30 minutes to 1 hour.
So, okay, okay. So then we have put in a center. You want a central line?
Yes, sir. I'll secure central line for my patient. For inotrope, if in case inotropes are needed, or to guide fluid therapy in post-op period, not in the intra-op period.
So now we have secured the invasive lines and we have put in all monitoring. So you talked about ASA monitoring standards. So what is the most monitor as per ASA monitoring standards? Most important.
So ASA 1 and 2, one is presence of experienced trained anesthesiologist. ASA 2 is for oxygenation and ventilation and this thing like lead ECG, and non-invasive blood pressure and pulse ECG.
Okay, so now so we so now we have started the case. You have made the positioning. So the patient has been made lateral, and surgeons have started, and you have done one ventilation.
Sir?
You have started a one lung ventilation. Okay.
Yes.
Another 10 minutes after this, so you find that there is a sudden drop in. Before that, so what are the change in ventilatory parameters you will do when you're shifting from a patient from a two lung to a one lung ventilation? So what will be the tidal volume? What will be the respiratory rate? Other things when you're doing a two lung and how it is different in a one lung ventilation?
Yes, sir. In one lung, I'll put my patient on pressure control mode. Volume control can also be used, and tidal volume will be 5 to 6 ml per kg with the aim of peak pressure less than 35 and plateau pressure less than 25. Respiratory rate of 12, and to maintain normocapnia, accordingly, I will change the respiratory rate with a PEEP of 5 to 10 centimeter. In case of COPD, the no added PEEP will be given. Yes, sir. Volume control. Before initiation of one lung ventilation, my goal is to maximize atelectasis in non-dependent lung and minimize atelectasis in dependent lung. So I'll preoxygenate again to wash out the nitrogen and to facilitate collapse. After that, then I'll recruit the dependent lung by inflating it.
Okay. The tidal volume is little on the higher side. So for a two lung ventilation nowadays we say about 6 to 8, and for if you shift to one, you may have to reduce it further, maybe 4 ml per kg, and increase the rate to match the ventilation. So you may have to go up to 20 or little more depending on the CO2 buildup and the patient ventilation status. Okay. So can you tell me about something about you talked about atelectasis? No, as anesthetist, we are very worried about perfusion and ventilation of this patient. Classically, lung has been divided into zones for with respect to perfusion and ventilation. So, what are those zones which are there in the lung?
So best zones for perfusion. 1, 2, 3. From base to apex, in ocean, ventilation decreases, perfusion decreases, whereas ventilation perfusion ratio will increases.
So, what is happening in a patient who is lateral and upper lung is deflated? So, how does the zones change, dynamic change in these patients?
So dependent lung will be in the most dependent part. So the perfusion will be more in the dependent lung because of gravity. And because of in general anesthesia, there will be decrease in FRC, and because of muscle relaxant, diaphragmatic movements won't be there. In that case, non-dependent lung will be easier to ventilate.
So, but in any case, non-dependent lung, we are not ventilating, no?
Yes, sir. Because shunt.
Because you have to, in any case, not only that, but operated, no, for operated lung, it has to be the non-dependent lung. So we are operating on that lung, so that will not be ventilated. Okay, so to counter this, so we expect hypoxia in this patient, now. So we have there may be some ventilation perfusion mismatch. So we might expect some hypoxia. So there is some inherent mechanism in the body to counteract that hypoxia. So what is it? And
It's hypoxic pulmonary vasoconstriction. It is a
can you tell me more
yes.
elaborate?
Sir, it is a protective physiological response in which it decreases the blood flow to the decreases the blood flow by 50% from the non-ventilated lung. So basically, the stimuli is pulmonary alveolar PO2. It causes constriction of precapillary vasoconstriction, thereby diverting the blood flow. It is a biphasic response. The initial phase starts immediately and plateaus at 20 to 30 minutes. The second phase will start at 40 minutes and will last up to 2 hours.
So, okay, so basically, it is a good thing or it is a bad thing, and what are the things which may increase HPV, and what are the factors which will decrease HPV?
So the factors which increase HPV are hypothermia, hypocapnia, any any vasodilating drugs such as nitroprusside, NTG, and volatile anesthetics more than 1 MAC. This inhibits HPV.
And
Whereas
drugs like noradrenaline might decrease HPV. There can be some hemodilution, change in position. Those things might affect. Okay. So, anything else we can do? So HPV is protective, we know. So depending on the perfusion, the ventilation will be shifted to the lung, which is better perfused. So this is a normal physiology, and this will be happening in this case also. What are the additional things which we can do for this patient to improve oxygenation on a one-line ventilation?
so we'll add PEEP to the dependent lung.
Okay. Mm-hmm.
And other
You told this patient COPD, no? So you might be having a non-compliant lung. There might be bullae which might rupture. So you will have to titrate PEEP, and you have to somehow optimize for the patient. So in addition to that, what else you can do?
So recruitment maneuver to the dependent lung, and also for non-dependent lung, I can apply CPAP of 1 to 2 centimeter water.
How do you apply CPAP to a non-dependent lung in such patient? What do
Sir,
you advise, or you can improvise on things when you apply a CPAP?
So before applying CPAP, I'll basically recruit the lung, so the amount of CPAP which I'm delivering will be less, so it won't interfere in the surgical field. It can be delivered through a nasal cannula inserted and a suction catheter inserted and connected to oxygen of 3 liters per minute.
So you basically will have to insert a catheter through the lung which is not ventilated. Okay, and then you'll have to connect the oxygen through it. And there are specific devices where you can actually control the amount of CPAP in millimeters which is being given to this patient. So you can just turn the knob and adjust the pressure which is being given to this patient.
Yes,
Okay, so now you talked about some, you wanted to give fluid in this patient giving responses. So what is the current status of giving fluid in these patients?
Sir,
Fluid you want to give crystalloid or a colloid? Do you give ml per kg, or what are the methods of giving fluid? So what do you do?
Sir, I'll give balanced crystalloid solution. And the only deficit and maintenance fluid I will give. Third space I won't give. Then total positive fluid in 24 hours should be less than 20 ml per kg, and also total crystalloids in 24 hours should be limited to 3 liters, and urine output should not be more than 0.5 ml per kg per hour. If increased tissue perfusion is needed, I will start inotropes.
So So you want to give fluid. So what is the best way of giving fluid? So either you want to practice a restricted fluid therapy or a liberal fluid therapy, or you want to give a goal directed. And if
Sir,
it is what is the goal you are looking for?
Sir, I'll go for goal directed fluid therapy.
Right. So something which is so basically goals are endpoints which you're looking at. So it will be like you talk about urine output. They are the kind of crude goals. So good urine output. You're monitoring the arterial blood pressure. So you have this
Pulse volume.
you can see the pulse volume variation. So if you have possibility of cardiac output monitor, you can see that. Then tissue perfusion surrogate marker is lactate, so you can see the change in lactate levels over a period. So these are the endpoint goals, no? So that will help you to somehow optimize the fluid and balance them with the inotropes you are giving. So you have to somehow balance, and you rightly said you have to kind of the fluid should be uh, we should not overload the patient. I'll put it this way. So and it is very difficult to say follow this formula to every patient. So depending on the patient, you will have to customize and balance the amount of fluid you are giving and the inotropes you are giving for the patient. Okay, so now we are doing this intra. We are doing a pneumonia patient. No, so it is a kind of major surgery. Your one lung is being removed. So what are the kind of possible complications which might occur, and because some of them are very common, and what you will do, how you plan for them?
So the complications are hypoxia, uh, hemorrhage, sudden hypotension. There will be sudden change in ventilating pressure. Bronchospasm can occur. Arrhythmias can occur. These are the
So what are the
complications.
common arrhythmias in these patients?
So atrial fibrillation is most common.
Atrial fibrillation is very common. So what you will do if the patient has an atrial fibrillation during the procedure? So what you will do?
Sir, if patient if patient is already taking beta blocker, I'll continue the beta blocker, or I'll add a diltiazem if he's not taking that. Then I'll consider amiodarone and statins.
So beta blocker, I don't think be preferred in patients who are COPD, no?
Yes, sir. There are. So I'll go for calcium channel blocker like diltiazem.
Okay. So suppose this patient, you talked about bronchospasm also, and patient was on 2 inhalers before surgery also. So suppose we had intubated this patient, one lung ventilation was done, and suddenly you find the chest is silent, so you are able to hear on either side. So probably a severe bronchospasm has occurred. So what will do next?
Uh, First, I'll confirm the position of the tube.
How do you
Then
do?
I'll,
You
sir,
want
by
to,
bronchoscopy.
we do a bronchoscopy, we'll confirm. Okay.
If tube is intact, and I'll increase the FiO to 100% and make it any bronchospasm either I'll give bronchodilators.
So there may be other kind of changes which you may see in the monitor. There's a spasm. So what are those changes?
In ETCO2 there will be shark fin appearance.
What else? What about
And
the
increase the peak pressures.
pressures will be more, so you know
Pressures will
the spasm which is happening. So what you do? So you gave 100% oxygen, you rightly said. So
Yes,
and
sir. Then I'll give inhaled salbutamol or corticosteroids. And I'll go for IV steroids also, if it is not relieved.
suppose it is not relieved with IV steroid, then what
And I'll
next?
go magnesium.
Okay, much better than magnesium. So magnesium is a tricky drug. So it is one of the drugs mentioned for bronchospasm, but yes, you have to measure. You should have pre-op levels, monitor changes. So I will keep the last resort. So other important drug which is less, which has a wider therapeutic window. I'll put it this way. So common drug which you.
Sir, deriflin, theophylline.
Okay, so we have then also we can use even theophylline has an aerotherapeutic index. So I'll first it is a personal choice, but yes, it will be better to give ketamine low dose. It might cause add to the depth of anesthesia also, and if not control, then we may use adrenaline also because okay. So and simultaneously, so if the patient is surgery is ongoing, that will need to stop, and you have to deepen the plane of anesthesia because any stimulation in a lighter plane can tends to aggravate bronchospasm, and that may be problematic for the patient. What other complications you mentioned about?
Sir, hypoxia.
Hypoxia we discussed.
Sir, hypotension, hemorrhage.
So those can occur, and you will have to manage them if and when they occur. Okay. So now the surgery went fine and they were able to uh, do a pneumonectomy. Then in the after the procedure, so what is your plan for extubation in this patient?
Sir, in my patient, the predicted post-op values are more than 40. So I'll plan extubation if patient is alert, warm, and comfortable, and other hemodynamic parameters are normal.
So he was alert. So these things were met. So you want to extubate with DLP directly tube to a single lumen tube before extubation.
Sir, I changed to single lumen tube, then I'll extubate.
Why do you say so?
Sir, no, in case of difficulty.
It's a personal choice. So some people will prefer to change to a single lumen tube and then extubate. Some people will extubate on a DLT itself. So it depends. Both. So whatever you do at the institution, you can do that. But you should have an experience of doing what you do, so that will be better depending on what you do. Personally, I'll prefer to change to single lumen tube and then extubate. Okay. So what are the complications which we are looking at in the post-operative period? No, since it's the major surgery, so there are possibilities of changes which might occur. So what are those?
So in cardiovascular system, there can be arrhythmias or sudden hemodynamic collapse due to cardiac herniation or any myocardial ischemia. In respiratory system, there will be chance of atelectasis, pneumonia, respiratory failure, which is most common, and torsion of the stump or dehiscence of the stump or pneumothorax.
Pneumothorax, for that they generally put in a chest tube mostly, so that will be there. But if the pneumothorax occurs, you'll have to be, patient has to be in a close watch. When you extubate on table, you will have to shift him to ICU, closely monitor. And we have to look for most bronchospasm is also a possibility. Patient already has bronchospasm. So you have to have a close monitoring of this patient. More importantly, so we talked about this atelectasis in the post-op period. So major surgery, long term, you may have pain. So what you will do for analgesia in the post-op period?
So my primary modality will be thoracic epidural analgesia with the continuous infusion of local anesthetic, which is BP vacant 0.25%, and fentanyl 2 mics per cc at the rate of 5 ml per hour. Other options would be I would add on NSAIDs and paracetamol. If it is not controlled, I will add the opioids.
Okay. So, what is the recent evidence with respect to continuous infusion of local anesthetic through epidural versus intermittent boluses? What does recent evidence suggest?
So continuous infusion is better pain control.
Why do you say so?
Because the patients.
Okay, this is on who's listening, so it may come as a kind of question in the recent advances. So, so now you have put in epidural, but not strange thing happens in anesthesia. No, once you are shifting the patient from the table, the epidural catheter has come out, and patient is in severe pain in the post-operative period in the ICU. What do you do next?
I'll go for other modes like patient control analgesia, like with the systemic opioids.
Okay, so what kind of drug systemic opioid you want to give? What is the baseline infusion and the PCA mode you want to put in this patient?
So we don't have PCA pump, so I'll go for
Infusion pumps. No, we can do a continuous infusion. Suppose we had PCA pumps, so what you'll do? So what you must know the kind of dosages and the drugs you want to give. Suppose we want to give fentanyl or morphine. Fentanyl or morphine.
So fentanyl.
So what is the dose you give?
Sir, bolus dose I'll give 2 mics per kg.
50 kgs, 100 microgram we have given. What next?
Then there will be. So
Okay,
then I'll
so
start the infusion. Infusion at 0.5 and to 1 mics per kg.
you start a continuous. Or you can, if you have a PCA pump, we can set in the baseline infusion and the demand, and we can set and patient can give opioids. But what is the inherent opioid? No, at first place we have put in epidural catheter. Somehow it has come out, but there must be some reason that we are putting most of analgesia. So what are the problem for patients, especially primarily only
Sir, I couldn't hear you.
what is the problem of only opioids for analgesia?
Sir, at that the level which we needed to achieve for adequate pain will be exceed the toxic dose, so patient might land up in respiratory depression.
Okay. Okay. So what about you talked about other modalities? Can we give other regional blocks in the postoperative period?
Yes,
So
sir.
what block you will give?
So
And
paravertebral block or erector spinae block.
have you given a paravertebral block?
No, sir.
Rectus spinae? So no, what I'm asking specifically, so when the such question comes, no, you know the answer, so we can give this, but so there may be a personal choice because of expertise and availability. So if you because next question will be how do you give a paravertebral block, how do you give a rectus spinae, or what is the anatomy of paravertebral block, or a rectus anterior plane block. So you must be aware of one or two at least. So this is a common kind of question. I'm sure it must be happening in your setup as well. So you must be ready with a backup plan for anesthesia because it is very important considering the patient will not be having a proper breathing if patient has severe pain, and if there is pain he will not breathe, there will be atelectasis, then it will develop a pneumonia will develop, and then it will add to the problems. So we do not want that. So you can either give a single shot. Uh, Serratus anterior plane probably will be easiest and safest. You can just put in an ultrasound probe and identify the muscle at the level of nipple, fifth intercostal space, and you will be able to give them. Okay, so what are the other specific things you look at in this patient in the post-operative period?
Sir, in post-op, I'll monitor the vitals and I'll supplement oxygen if its PO2 is less than 60 mmHg. Then I'll analgesia, adequate analgesia. Then I'll ensure early mobilization and chest physiotherapy, incentive spirometry.
You have to ensure that regular physiotherapy is being done to this patient, and so that they are able to manage well and they recover faster. Okay, so when you come to exam, so you may have a specific short note on analgesia, perioperative analgesia for thoracotomy patients. So you will have to list, you have to divide into regional and the drugs. You have to enlist all intraperitoneal. Now, since we have discussed about the case mostly, so we now come to topic of enhanced recovery after surgery. Now this is something which is in fashion, and everybody is talking about ERAS. So what do you mean by ERAS, and what are the guidelines specifically for thoracic surgery?
Sir, ERAS is enhanced recovery after surgery. It's a multimodal, multi-systemic, multi-speciality approach. It incorporates various peri-op care measures. The concept is to mitigate the surgical stress response and also facilitate early recovery. Recent guidelines are, it includes pre-admission, pre-op, intra-op, and post-op phases. In pre-admission phases, patient information, education, and counseling. And nutritional assessment. If he is malnourished, I start nutrition supplementation, smoking and alcohol cessation, and pulmonary rehabilitation and prehabilitation. In a pre-op period, and fasting guidelines should be restricted to 6 hours for solid and 2 hours for liquid. Oral carbohydrate loading can be given, and protein pre-medication should be avoided. Sedative pre-medication should be avoided. Then antibiotic prophylaxis 60 minutes before the incision, and venous thromboembolism prophylaxis, which include pharmacological and mechanical prophylaxis. And intra-op hypothermia should be avoided. Like normothermia should be maintained by active warming devices. And lung anesthesia, balance of general and regional anesthesia should be preferred, and lung protective ventilation strategies should be used. And PONV prophylaxis, pharmacological and PONV prophylaxis should be initiated. Regarding analgesia, regional anesthesia should be added along with the systemic analgesics like in anti-inflammatories. NSAID should be combined with paracetamol, and ketamine can be given, and Dexa can be given for pain relief and also for PONV. And arrhythmia preventions by giving prophylaxis. And fluid therapy, very restricted and liberal fluid therapy should be avoided. Our target is to maintain euvolemia. Balanced crystallized solution preferred over normal saline. And in post-op period, chest drain should be removed early, and single suction chest drain should be avoided, and single tube should be used. And chest drain should be removed even if even if there is more volume, high volume effusion, around 400 ml also we should remove. Then urinary catheter should be avoided, and urinary catheter should be inserted if patient is having thoracic epidural anesthesia, and if anemia is there, we should correct anemia.
Okay. So these are the about 20 odd interventions, which includes pre-op, intra-op, and the post-op period. So we may be doing it in bits and pieces, and from postgraduate point of view, it is important that ERAs will come in some form or other in the exam. So you must know about them thoroughly. In addition, we have not specifically discussed much about one lung ventilation strategies, the possibilities which are there, like blockers and various tubes. So that the reason being there was a class today only. So we have not specifically discussed, but you may be asked about the choice of DLT, indication of one lung ventilation, why, what are the blockers used, what is easy blocker, what is univent tube, when you will do a single lung ventilation. If everything fails, you will have to do a normal and do a one lung ventilation, and other lung is not being ventilated. So you must be very, very aware about those things. And lung case is important. So you will definitely get this in exam, some form or the other, whether you do a practical. So you may have a long case, 20 marks in theory, or as a long case in practical, or you may have specific short notes on HPV. You may have it on how to do isolate lung, information of the tube. You may be asked about three-prong approach we discussed in respiratory pre-op management of the patient, the predictive post-operative FEV1. So these are the things. There may be many more. The point is that this is an important case, and you must be thorough with this case throughout. Every word is important for this case. One more suggestion for the practical exam. So don't commit to the wrong side in the Viva. So whatever you utter, the next question of the examiner will be definitely on, but especially if you say something wrong or a borderline kind of thing. So do not say anything wrong. It is better to accept that you do not know, so that examiner has time to ask you another question. But if you commit yourself on the wrong side and try to say something which is very grossly wrong, then it becomes really difficult, and examiner might take the viva to kind of other side. So as a postgraduate student, so you will be the most well-read when you go to the exam, and you have to act smart. And believe me, you can take your viva the way you want if you're doing it correctly. So the questions are pretty standard for most of the cases. So some questions will all examiners will definitely ask. So if you know about them and you do it correctly, the Viva will proceed as we were doing today because we were prepared for it. So sometimes, so they are standard questions if you prepare well. So you will be definitely going to a lot of anesthesia management of this patient. And believe me, when we were postgraduates, so we were told if somebody starts anesthesia management, then means your Viva is over. So you must be very thorough with the cases and be honest about whatever you are telling. So it will be better to say I do not know in a case discussion if you do not know. So that will be the best strategy. I think that is from my side, Nitin. So I think you are summarizing few important points Over to you, Nitin.
Yes, sir.
You did very well, and you're well prepared.
Thank you, sir.
Thank you, sir, for the wonderful case discussion. So we will briefly go ahead with the important points that one needs to know regarding the anesthesia for pneumonectomy. And so the anesthesia for pneumonectomy. Now, the objectives of my talk would be preoperative assessment, the challenges that are caused by the pathophysiology associated with pneumonectomy, approach to anesthetizing a patient for pneumonectomy, and the common complications post pneumonectomy. A brief discussion about the history that the first stage pneumonectomy was done in 1993 on Dr. James Gilmore. He was a gynecologist and obstetrician who was apparently posted for lobectomy, but however, because of the extension of the cancer, it had to be converted to pneumonectomy. And following pneumonectomy, he survived for 24 years. Now, why are we so much worried about the anesthesia for pneumonectomy and the pneumonectomy surgery per se? Because it has the highest post-operative mortality of all pulmonary resections. Pneumonectomy is taken to be the last option in case staged resection is not possible for a patient. With a right pneumonectomy, has a more morbidity and mortality compared to left because of the smaller left lung resulting in increased PVR and right ventricular failure with increased incidence of bronchopleural fistula. Coming to the indications of pneumonectomy, they could be malignant or non-malignant. For malignant, it is the most common indication is bronchial carcinoma, especially at anatomical locations which are not amenable to alternative resections. That is, those originating from the main bronchus or proximal to the bronchus intermedius or has a hilar involvement. The non-malignant indications are traumatic injury to the lung, and thereby there is a risk of aspiration onto the other side, which can cause further deterioration of the patient, or a chronic infective disorder of lung, likely tuberculosis, and fungal infections resulting in lung destruction. Coming to the preoperative assessment. So the most important system to be assessed is the respiratory system, wherein a detailed history of patient's life gives a significant amount of assessment of the respiratory function. If the patient has got a good quality of life, he is able to do his daily day-to-day activities, that means the respiratory reserves are good. Next would be your baseline spirometry. And you have certain objective measures of pulmonary functions like the CPET, which are required for anesthetic management. So for assessing the preoperative respiratory function, we have a three-legged tool, wherein we talk about the respiratory mechanics, the cardiopulmonary reserve, and the lung parenchymal function. The respiratory mechanics, there are various tests which can be done, and the PF, that is the FEV1, which is most important. Then we have the forced vital capacity, the maximum voluntary ventilation, and the ratio between the residual volume and the total lung volume. And the most valid test for the post-thoracotomy respiratory complication is the predicted post-operative FEV1, because it not only helps us to know the respiratory function, but also helps us to predict the likelihood of extubation in these patients. Now, how do we calculate it? The post-operative FEV1 is calculated by knowing the preoperative FEV1, and you have to know the amount of the lung tissue that has been resected, for which you need to know the total segments and the segments which are to be removed during the surgery. Next, we have the lung parenchymal function, which helps us to assess the ability of the gaseous exchange between the pulmonary vascular bed and the alveoli. For this, we have ABG, which can routinely be done in a preoperative setup. The PaO2 and the PaCO2 will give us as a warning indicator. For example, if the PaO2 is less than 60, that means the patient is at a high risk of post-operative pulmonary complication. Or if a PaCO2 is more than 45, that is the patient perhaps has a COPD and is on a hypercarbia is there. So these patients will be at a high risk. And the most useful test for the gas exchange will be the diffusing capacity of carbon monoxide, that is your DLCO. Now, what does the DLCO tell us about? It tells us about the total functioning surface area of the alveolar capillary interface, and it can be calculated in the same way as we do for the postoperative FEV1. If the postoperative DLCO is less than 40%, there is likelihood that there will be an increased risk of respiratory and cardiac complications. However, a thing that one needs to note is that these patients might be undergoing chemotherapy in the preoperative setup, which might negatively affect the preoperative DLCO. That is, you're predicting the postoperative DLCO. So if a patient has had a chemotherapy, then a single DLCO value may not be of too much of a significance. Lastly, we have the cardiopulmonary reserve, for which we have the formal laboratory exercise testing, that is the CPET, which is the gold standard, and which helps us to calculate the maximum oxygen consumption, which is the most useful predictor of postoperative pulmonary complication. That is, if the VaO2 max is less than 15 ml per kg per minute, the risk is increased, and the risk becomes very high if it is less than 10 ml per kg, wherein pneumonectomy may be a contraindication. So how do we talk, when we talk about CPET, how do we do it? There are two modalities. Either you can go for a cycle ergometer or a treadmill test can be performed. And through these, we have to calculate two things. One is the peak oxygen consumption and the anaerobic threshold. Now, what are the various indications of CPET? Firstly, to make a diagnosis of dyspnea as to what is the origin of dyspnea, whether it is of cardiac origin or a pulmonary or a peripheral limitation. Secondly, the exercise-induced bronchoconstriction. And lastly, the exertional desaturation. The other indications are the pre-op evaluation and risk stratification, as in case of pneumonectomy, the prognostication of life expectancy, fitness evaluation, and any response to the therapy that has been given to the patient. The most important parameter evaluated with CPET is the peak oxygen consumption, that is the PaO2 peak, wherein if the patient has a VO2 peak of more than 20 ml per kg per minute, the patient is likely to have a safe perioperative period. With a value between 15 to 20, he has a good physiological function, and a value of less than 10 is a contraindication to pneumonectomy. In case you don't have CPET, what are the other alternatives that are available? Firstly is the 6-minute walk test, which gives an excellent correlation to VO2 max, which is calculated by the distance that is traversed by the patient in 6 minutes in meter divided by 30. Or if there is a desaturation of more than 4%, which indicates that the patient is at increased risk of postoperative pulmonary complication. The other test that we have is a stair climbing test, wherein if a patient is able to climb 5 flights of stair, that means the VaO2 is more than 20 mils per kg per minute. So he has a good pulmonary reserve. And if he is only able to climb 2 stairs, that means the VaO2 max is 12 mils per kg per minute. He is at an increased risk. Then we have something called as the ventilation perfusion scintigraphy. It helps us in identifying the non-functioning or the minimal functioning lung tissue. If we know the VQ, if we have this ventilation perfusion scintigraphy, we can predict the postoperative outcome of this patient. If the lung tissue to be resected is already non-functioning, then the likelihood of the patient undergoing any decompensation is less, because the tissue that has been removed was already non-functioning. The other thing that it helps us is in modifying the predicted postoperative function, and it should be considered in patients who have a pre-op FEV1 or DLCO of less than 80%. However, it has a limited role in predicting the post-lobectomy function. So just one single test may not be sufficient. It has to be a multi-approach, and a 3-legged stool for pre-thoracotomy respiratory assessment has to be followed, considering the respiratory mechanics, the pulmonary reserve, and the lung parenchymal function. Coming to the operative mortality. Now, how can you calculate? The British Thoracic Society gives a thoraco score, which can help us to predict the postoperative mortality, wherein it incorporates 9 factors. However, this score per se may not be sufficient, and one has to focus more on the exercise capacity and the physiological reserve. These patients may have other associated comorbidities. The perioperative myocardial events are not are very likely to happen in these patients. As these patients are chronic smokers, they might have a CAD or an associated ischemic events. So cardiologist's opinion is required for all patients who have active cardiac conditions like unstable angina, heart failure, significant arrhythmias, or the severe heart valve disease. Without any active cardiac condition, one has to assess. You have to use the revised cardiac risk index. And if it has a more than 3 or has a poor functional capacity, then stress exercise testing and cardiologist's opinion is required. And in all patients, especially the older age group, it is advised to undergo a transthoracic echocardiography. If the patient has got an MI, then it is requested to wait for at least 4 to 6 weeks before you go for a pneumonectomy. If the patient has had a stenting, in case of bare metal, wait for 4 to 6 weeks, and in a drug-eluting stent, 6 months wait is required. Arrhythmias, they are the most common complication after the post-operative pulmonary complications to occur in these patients. Roughly 30 to 50% have an incidence, it has an incidence of 30 to 50% in the first week post-operatively, with atrial fibrillation being the commonest arrhythmia that occurs in 60 to 70% of the patient. The reason is an increased flow of resistance through the pulmonary vascular bed, and the other is an increased sympathetic stimuli and oxygen requirement in these patients as they become mobile in the post-operative period. So we have these guidelines for the American Society of Thoracic Surgeons, wherein they advocate that all patients should continue their beta blockers if they have taken preoperatively, and magnesium if the serum level is low or suspected total body stored is depleted. In patients who are in increased risk of atrial fibrillation, you have to give Dilzem if there is a preserved cardiac function and the patient is not taking beta blockers, or you consider amiodarone on statins. Pulmonary hypertension is likely to happen in these patients, and you have to find out which pulmonary hypertension he is suffering from. Either it is due to the left heart disease or because of the lung disease. And pulmonary hypertension in lung disease ranges from 40 to 50%. Because of this, one has to keep certain things in mind. If the patient has pulmonary hypertension, try and avoid hypertensive and vasodilating anesthetic agents. Ketamine does not exacerbate when pulmonary hypertension. Support the mean arterial pressures with way of vasopressors, use inhaled pulmonary vasodilators, use thoracic epidural, and monitor the cardiac output. Age is again a factor. If the patient is an elderly patient, then the mortality of 3% is seen in patients between 80 to 90 years of age. And the risk of respiratory complications nearly doubles, and of cardiac complication nearly triples with age. COPD is likely to be found in these patients, as majority of these patients are smokers or chronic smokers. And you have to consider these 3 treatable complications which can be seen in these patients. That is the atelectasis, bronchospasm, and the respiratory tract infection and pulmonary edema. And you try and improve these conditions in the preoperative period. So the initial assessment, what all you need to see? All patients, you have to assess the functional capacity, spirometry, postoperative analgesia should be discussed, and discontinue smoking. If the patient has got an FEV1 or DLCO of less than 60, ask him to go for CPET. Cancer patients, consider the 4 M's, that is the mass effect, metabolic effect, metastasis, and medications. In a COPD patient, go for ABG, physiotherapy, and bronchodilators. And in increased risk patients who have impaired renal function, you measure the creatinine and the blood urea nitrogen. And the final pre-anesthetics assessment should consider reviewing the initial assessment and the reports, assess the difficulty in lung isolation that you can do with the X-ray and the CT scan that are available, and assess the risk of hypoxia with 1 lung ventilation. Coming to the physiology. Now, in 1 lung ventilation, the patient in pneumonectomy is in a lateral position. So the dependent diaphragm is pushed up. There will be an increased perfusion to the dependent lung because of the gravity. And because of insufflation of the gas in a video-assisted thoracoscopy or an opening of the thorax, there will be a downward mediastinal shift causing circulatory changes. Again, there will be also changes in the lung compliance. Because of the loss of volume, there will be a decrease in the lung compliance, and thereby there will be an increased VQ mismatch will be further increased, resulting in a greater shunt. So what are the factors which correlate with an increased risk of desaturation during 1 lung ventilation? First, the high percentage of ventilation or perfusion to the operative lung. Secondly, the poor PaO2 during the 2 lung ventilation. Thirdly, right-sided thoracotomy. Fourth, the preoperative spirometry or normal spirometry or a respiratory lung disease. And lastly, if it is a supine position during one lung ventilation. So how do you go about giving anesthesia to this patient? The plan of anesthesia would be general anesthesia under controlled ventilation. You go for placement of a thoracic epidural. Pre-oxygenation is mandatory. Maintain 2-lung ventilation as far as possible. Continue medications for the comorbidities which are already the patient is taking. An antisyllagogue may be helpful as it helps to decrease the secretions, and it may facilitate bronchoscopy when you're trying to do it for the placement of double lumen tube. Anxiolytics, IV midazolam can be given. However, be watchful. Oversedation may be harmful. And antibiotic prophylaxis in these patients is required. Opioids should be given in liberal doses. An IV induction agent of choice, depending upon the cardiac condition of the patient. It could be propofol, it could be etomidate. An NDR and an inhalation agent, one has to be watchful that a MAC of less than 1 is maintained so that you do not inhibit the hypoxic pulmonary vasoconstriction. Nitrous is to be avoided. Firstly, because of the higher incidence of post-thoracotomy atelectasis, then you have increased pulmonary pressures are likely to be there in patients with pulmonary hypertension. It also inhibits the hypoxic pulmonary vasoconstriction, and it is contraindication in patients with blebs and bullas, which are likely to be a patient cohort as these patients might have COPD. Then we have the lung isolation technique depending upon your surgery. Maintain normothermia, adequate hydration, and prevention of bronchospasm. For intraoperative monitoring, one has to go for the standard ASA monitoring. Along with it, an invasive hemodynamic monitoring should be done in these patients. PA catheter can be placed in case patient has pulmonary hypertension and you want to measure the pressures in the perioperative period. Ventilation and your transesophageal echocardiography can be performed as it gives a real-time monitor of the myocardial function and the cardiac preload. A word about HPV. Now, it is a local response of the pulmonary vascular smooth muscles to the decreased blood flow of the lung and an increased pulmonary artery pressures, and it increases the risk of arrhythmias. It has got 2 peaks, one peak at 30 minutes and the other peak that happens at 2 hours. And the surgery may oppose the hypoxic pulmonary vasoconstriction by release of the vasoactive metabolites. Thereby, your aim should be to try and maintain the hypoxic pulmonary vasoconstriction and avoid any factors which decrease it. Lung isolation techniques, you can go for a double lumen tube, bronchial blockers, a single lumen endotracheal tube with an inbuilt bronchial blockers, that is your univent tube, or a single lumen endobronchial tubes and your endotracheal tubes, which can be advanced into the bronchus. I'm not going into the details because we have a lecture subsequent for this. The position of the patient is lateral, so you have to be very careful that you do not cause any injury to the patient, likely on the dependent parts like the eye, the ear, the pinna. The cervical spine should be stabilized and should be in line with the thoracic spine. The dependent arm and the non-dependent arm, you avoid injury to the brachial plexus or circulation. Avoid any nerve injury. Avoid nerve injury in the dependent lung also, likely the peroneal nerve and any circulation issues. Ventilation strategy is very important. Maintain 2-lung ventilation as far as possible. The tidal volume should be restricted to 5 to 6 ml per kg of the ideal body weight. Peak airway pressures to be restricted to less than 35 centimeters of water with the planned airway pressures of less than 25. Maintain a peak between 5 to 10. Aim for normal PaCO2. Limit to the respiratory rate of 12 or maybe increase in case you have hypercarbia. Mode of ventilation can be pressure or volume. However, pressure is preferred to avoid any injury because of barotrauma and avoid hyperoxia. Titrate your FiO2 to maintain the oxygen saturation between 94 to 98. Fluid management, again, you have to be careful that you do not overload these patients, and the total positive fluid balance in 24 hours should not exceed 20 ml per kg. And crystalloids should be less than 3 liters in the first 24 hours. No fluid to be given for any third space loss, and a urine output of greater than 0.5 ml per kg per hour is not necessary. Intraoperative complication, one should be watchful, which are likely to be hypoxemia, sudden hypertension. There could be changes in the ventilatory pressure or the volume because of the surgical intervention. Arrhythmias because of the irritation of the heart and is very near to your lungs. Bronchospasm, any massive hemorrhage, hypothermia, or any nerve injury. Managing hypoxia is very important, and ideally you should first go ahead by increasing the FiO2 of 1, resume to 2-lung ventilation, check for the positioning of your double lumen or the bronchial blocker with the help of a bronchoscope, ensure that the cardiac output is optimal, and apply a recruitment maneuver to the ventilated lung. After you have done it and you want to maintain saturation in following subsequently, then you can add CPAP of 1 to 2 centimeters of water to the non-ventilated lung. You can go ahead with the partial ventilation technique of the non-ventilated lung. Pharmacological manipulations can be done. Mechanical restriction to the blood flow to the non-ventilated lung using a Fogarty catheter can be done. And in case of a persistent refractory hypoxemia, suspect PO4. Last resort is ECMO or bypass. Now, coming to the extubation, predicted FEV1, the post-operative predicted FEV1 gives a very good indication as to what will be your plan of extubation. If it is more than 40 and the patient is warm, alert, and comfortable, go ahead with your extubation. Between 30 to 40, you have to consider the other the VQ scan and any other associated. That is when you have to be very watchful. It has to be a staged weaning from the mechanical ventilation, and consider extubation if it's more than 20%, provided you have adequate analgesia. Post-operative period, you should be watchful that you are resuming to both lung ventilation, you have recruited the lungs, and you have gone for a suction and you have fully inflated your lung. Post-operative X-ray is advised to rule out any pneumothorax, hemothorax, or collapse, or any misplaced drains. And adequate pain relief is very important, as it helps the patient to cough out the secretions, helps the patient to do deep breathing exercises and physiotherapy, thereby decreasing the post-op pulmonary complication. And be watchful of the fluid therapy. Try and have a positive fluid balance below 20 mils per kg in the 24 hours. Post-operative analgesia is the backbone of post-operative complications. So if you have given adequate analgesia, it significantly decreases the likelihood of post-operative pulmonary complications. So you either go for systemic analgesia like opioids, NSAIDs, ketamine, or dexmedetomidine, or you can go for local anesthetics and nerve blocks like the intercostal nerve block, epidural, paravertebral blocks, the rectus spinae, and the serratus anterior plane block. Post-op complications have an incidence of 2 to 4%, likely the respiratory failure, ARDS, empyema, right ventricular failure, as these patients have pulmonary hypertension, which significantly increases and can result in failure in the post-operative period, arrhythmias, as we have already talked about, and cardiac herniation. And last but not the least is the ERAS protocol. It is a multidisciplinary collaboration where you have to inculcate the surgical team as a whole, with patient being the center of this protocol. You have to educate the patient, has to counsel him in the preoperative period. Preoperative optimization is very essential. Risk assessment has to be done. Accordingly, you have to plan your anesthesia and extubation and your postoperative management. Reduce fasting periods, improve the nutrition, antibiotic prophylaxis, and thromboprophylaxis to be done. In the intraoperative period, try and go for a minimal invasive technique. Use shorter acting anesthetics. Stick to lung protective strategies. Avoid fluid overload, and ensure adequate analgesia. The postoperative phase has to revolve around the effective analgesia, early ambulation, good nutrition, early removal of chest drains, avoid any fluid overload, and the physical therapy or the physiotherapy. So this is the end of the discussion. Thank you so much for your patient listening, and all the best to all the exam-going postgraduate students.
Thank you, Dr. Nitin. Thank you, Dr. Nishkash, sir, for the excellent case presentation, for moderating the case. I am sure the PGs would have benefited from this discussions. Thank you, Dr. Nitin. Thank you, Dr. Ajita. We do not have any questions in the chat box. Thank you, sir. Would you like to conclude?
No, thank you. So thank you, Anupama and Nitin. So it was, I must thank the organizers for the arranging such a good workshop, and we learned a lot of things with the case discussions. And I wish best of luck to all the students. And if you have to read about one lung ventilation and thoracic surgery, you must read physiology, respiratory physiology from Miller Part 1 and anesthesia for lung surgery, or whatever the chapter they call it in. Prepare them well, and I wish them luck for their future exams as well. Thank you.
Thank you, sir. I'm sure this information will be helpful for them. Thank you. So moving on. Before moving on to the next session, I would like to tell an answer to a question which was asked in the previous case discussion. So there was a question in which it was asked that where should the ICDs be placed in a pediatric patient, in a child. So Dr. Vandana ma'am has answered this. So the chest tube should be placed in the 4th or the 5th intercostal space in the anterior axillary line. So now I'll announce the winner. These were the questions which were asked pre-lunch. The answer to the first question is B. Salmeterol inhalation is not used to treat the COPD patients. So this is not true. And the answer to the second question is the C. Patients with oromaxillary bleed and head injury due to vehicular accident presenting in emergency department with decreased level of consciousness requiring AV protection. So these are not the perfect scenarios for doing fiber optic intubations. So the names of the winners are Dr. Akansha and Dr. Javed. Congratulations. You will be awarded suitably at the end of the conference. Let's move on to the next session. So we have two very interesting lectures, and to start the session, can we have Dr. Akhilesh sir's CV? Sir is chairing the next session. Can we have the next slide? So we have two lectures. The first lecture is on the equipment. That is the airway devices for one lung ventilation, DLT, and bronchial blockers. And the second lecture is on laryngospasm. Dr. Akhilesh sir, are
Good
you
evening,
there?
everyone.
Good evening, sir. Sir is sir is the professor in the Department of Anesthesia and ABIMS and Dr. RML Hospital. Sir has